I'm Myron Posniak from the University of Wisconsin. We're going to discuss CT evaluation of trauma in the emergency department. Trauma is a big factor in the work that I do as an abdominal imager. I'm at a level 1 trauma center, and we see a fair amount of it. It's the leading cause of death in the first 4 decades of life. Approximately 150,000 deaths per year in this country from trauma, and about 2 million non-fatal injuries. I looked at the National Trauma Data Bank, which is compiled by the surgeons, and there's some interesting statistics. So first of all, this is patients by age, and then you can see there are peaks in traumatic injuries as we go through time. The first peak in the youthful age is from firearms. In this country, that's probably a very controversial issue these days, but it is what it is. In the mid-age range, it gets to be the MVAs. There's a peak from those. And then in the senior years, the traumatic deaths come mostly from falls. And when we split this out into male and female, it's the young guys who end up shooting themselves and driving their cars erratically. And then in the older years, there are fewer men around, and so it's the women who dominate with the fall statistics. There's one other curiosity that I found when looking at the data, and that's the mortality, the fatality rates by mechanism, and firearms have just a much, much higher fatality rate. Again, another aspect of society that we live in. Alcohol has a significant role in this. About 10% of accidents of MBAs have involved the use of alcohol, and drug use as well. So trauma management has evolved. Years ago, people used to die in the street, but now we scrape them up, throw them on a helicopter, and they're in the emergency department, and it's up to us to try and help them. So what we need to do is obtain as much information as we can, as quickly as we can, so we can treat these patients accordingly. Now, I will say one thing. The critically unstable patient does not belong on the CT scanner. They belong in the operating room. Why do we do CT? Well, we have an unexplained drop in hematocrit. We may have a confusing physical exam, but we want people who are hemodynamically stable. By that we mean that the fluids that are being put into the circulatory system at least equal the fluids that are coming out, so this patient is not going to crash on you on that CT scanner. You shouldn't be running codes there. That patient belongs in the OR. Their chance for survival is greatest with a diagnostic surgical procedure. Now, let's say the patient is stable. What are we going to do? Well, there are 2 options. There's ultrasound and there's CT. So ultrasound is really performed by the ED docs. Sometimes they know what they're doing. Other times we worry about them. But they're looking for one thing. They're looking for intraperitoneal blood. They may look for organ laceration, and some people suggested even using contrast for that. But personally, I think it takes too long, and it does not give you the big picture. Finding fluid in the cul-de-sac, fluid in the pleural space or around the liver, they're good at that. They can find, and if you see large volumes of fluid, they may just say, no, we got to go to the OR, this person's on the edge. Finding lacerations of the organs, you can do that if they're big. The subtle ones are tricky. A little hematoma, a little clot sets up, and the echogenicity can mimic that of adjacent tissue. And besides, if you have an injury like this in the liver, what's not to say that you don't have an injury in the kidneys and elsewhere? Really, the CT gives the big picture. The advantage of ultrasound is it's quick, it can be done at bedside, and it identifies the patient that needs to go to the OR emergently. The disadvantage is, well, obviously operator dependence is a big one, but if you have only a retroperitoneal injury, or if injuries are not capsule disrupting, they will be missed because you are not going to see a large volume of free intraperitoneal fluid. CT, it's non-invasive, it's pinpoint, where it's very, very accurate. And the good thing with CT, you can, nowadays non-operative treatment is very popular. We just watch. And if crit drops again, well, you can repeat a CT scan. So it does allow non-operative management. You can compare, are there changes? Disadvantages are radiation, cost, IV risk. We're also bowel, pancreas, and diaphragm immediately. Some of these injuries take time to evolve, and it is a relatively time-consuming study. Now, the scan itself takes, 20 seconds, maybe 30, but it's getting the patient set up in the scanner, getting the tubes and lines anchored, making sure that the patient can move through the scanner without anything falling out or getting pulled. That's what takes time. So what's used, CT versus ultrasound? Well, it's the trauma manager's preference. They really need to make a decision. Do we rush to the OR? Let's take a quick peek with ultrasound. If the patient is stable, then they will choose to go for a CT scan. So on our side, if we're going to be providing that service, we need a scanner close to the ED. We've got a scanner right across from the trauma bays in the emergency department. It's a sub-second rotation, multi-detector system, big tube, power injector, and it's got all the remote patient monitoring equipment that we need. We do not hesitate to sedate patients if they are combative, and now with alcohol, drugs on board, they can very easily be combative, or if they've got a head injury and they're confused. They have reversible agents. We will sedate. We want, if you take a picture of somebody and they're moving, it's useless. So we want the patient to be still for that scan, and then the agent can be reversed quickly. We don't bother with oral contrast. It takes too long. It increases the risk of aspiration. We don't bother with it. We clamp the Foley catheter. I want to stress the urinary system. If there is a bladder or a urinary tract injury, we want positive pressure to develop, so it pushes the urine out and makes it easier for us to identify. And we minimize artifacts, like getting tubes and lines out of the way, getting the EKG leads off the patient. I don't want this adding confusion to the interpretation. We get the arms up, if possible, because we want to avoid this kind of artifact. Now, you can't always do that. If there's a big fracture, clavicle, whatever, the patient may not be able to do that, but you can see how much harder it is to interpret when you have that kind of artifact. Work with your EMS services. Get the metal out of the boards. You don't want to add that artifact, but not all metal is necessarily artifact. The carpenters these days, they've got those fancy nail guns, and they can do pretty impressive things with them. That one, not so bad. It's in the liver. This guy was looking into the gun just to figure out what was wrong with it at the time. That he missed his eyeball. But how about this one? Take a look at that again. Ouch, that is not one I want to pull out. I think that went to the OR. Technique. First of all, we use contrast, IV contrast. We give a liberal amount of it. We follow it with a saline chaser. We're usually injecting at a brisk rate, 4 or 5 cc's a second. If the patient has a big traumatic chest injury, we will use bolus tracking, because if the patient has a significant cardiac contusion and their cardiac output is decreased, the perfusion time may be slowed, and you don't want to have the injection go in and not have the contrast circulate appropriately. Of course, you can get a delayed scan, but that's extra radiation. There is no role for non-contrast CT in the evaluation of the trauma patient. It adds nothing. What you're looking for is vascular disruption. You're looking for that big leak of contrast, like you're looking for the organ parenchymal disruption, and you're not going to see that without IV contrast. So how do we perform our studies? With the patient's on the table, and we start at the diaphragm and we scan up using CT angiographic technique. Then we go back to the diaphragm, we scan down through the abdomen and pelvis during the parenchymal phase of injection. The arterial phase here, because we're looking for disruption of the aorta. We want to make sure we don't miss a traumatic aortic laceration. And then in the abdomen, it's mostly looking for parenchymal injury, and we give enough time, if there is a vascular disruption, for acute extravasation to occur of contrast, and then for us to be able to pick that up. If there is any fluid around kidney or bladder, we will do a delayed sequence at 7 minutes. So the first scan is popped up quickly. The tech transmits it to the reading room and asks the radiologist or the resident on call, give it a quick check. Do I need to do a delayed? If there's no fluid in the peritoneal cavity, if there's nothing around the kidney, if the bladder looks good, no, we're done. But if there is some fluid around there, we'll get a delayed sequence at 7 minutes. That's usually enough time for the bladder to fill with contrast. If you noticed, our technique was fairly narrow collimation here in the chest, because we want want to reconstruct the aorta with great detail, looking for intimal tears. In the abdomen, great detail as well, but that's primarily because we're doing targeted bony anatomy reconstruction. T&L spines get reconstructed on just about everybody these days, and you need those thin slices for those recons. Now, some critical observations. Always look at the scout. That is going to be your quickest and easiest way to pick up a tension pneumothorax, all right? And this one, it's pretty obvious. There it is. You know, on the CT, you might go past it. Sure, you can see the pneumothorax, but is that shift of the mediastinum, I'm telling you, I think it's much more conspicuous on the scout view. There's one on the right, here's one on the left. You can see how it's pushing things over. You can also pick up on an ileus or a possible bowel obstruction really quick. And in this case, you know, if there's a resident involved right in the scan, they may say, "Hold, stop, don't inject yet. Let me go put a tube in and get this tension taken care of." I like to tell the residents, look at the box. So you get something from UPS, there's a big gash in the box. Obviously, what's inside isn't going to be in good shape. So if you see large body wall hematomas or even small ones like this, there's an indicator, and likely, you know, look right under that because you may find the laceration. That area where the hematoma happened is where the impact hit, and the underlying organ is more likely to get injured. Look for free fluid. It's really important in the belly because it could be any of these fluid products. And then look at the attenuation of the fluid. If you see it increasing as you go more dependent, this is likely blood within the peritoneal cavity. This is basically a hematocrit level that is developing slowly over time. A little rib fracture over here, right? So it doesn't look significantly displaced. Don't be fooled by that. Remember, during a traumatic impact, you have coup and counter coup. Those crash test dummies, they're going over the over the steering wheel, and then they're going way back over the back of the seat. With those forces, there's energy that's being build up, suddenly a rib will snap, and as it does so, there's a lot of release of energy. This thing moves in all over the place. It can hit the lung, it can hit the liver, but then with counter coup and the elastic properties of the tissues that are holding the fragments together, it tends to bring them very close back to where they were. And so what looks like a non-displaced rib fracture was probably significantly displaced at the point of impact. In this case, lacerating the liver. So just have a low threshold, low suspicion for calling organ injury related to rib fractures. The non-displaced, that's kind of a misnomer. All right, and let's see, here, you look at this scan, you've got some high attenuation material here. Well, are these fragments of bone here? Was this a fracture, or is this active extravasation? If in doubt, get a delayed scan. The delayed scan is your friend, all right? Things with hemorrhage are happening quickly, fluids accumulating, you're gonna have an easier job of diagnosing the hematoma. All right, now, very important point. We talked about this yesterday with aortic injury. The same thing here. Very important statement. The size of the potential space is the key determinant of survival. What you are bleeding into will determine whether or not you need surgery or whether or not you're even going to survive. So this bleed into the soft tissues of the body wall is going to basically, the pressures in the artery are going to equilibrate with the buildup of pressures in those soft tissues. That's why contused soft tissues end up feeling woody, very rigid, because pressure builds up in compartments. Well, but actually that's working to the advantage of the traumatized patient, because as that pressure builds, it's now counteracting the pressure in the vessel, and less blood is escaping. Eventually it'll equilibrate and the bleeding will stop. However, this patient who has a major liver laceration is bleeding into their peritoneal cavity. This bleeding will maybe result in millimeters of volume loss. This will result in liters. This patient's going to need intervention. Okay, here's a renal laceration. All right, do we operate on this one? We can observe this one. This is a relatively small space. Gerotus fascia, contents within it will pressurize. The bleeding will stop. You can just watch this one versus bleeds into the peritoneal cavity. Those need to go into the OR. All right, let's look at some specific organs. The aorta, 63% of MVA deaths are attributable to aortic rupture. Most of them die on the street. They're dead. 94% of them are dead within an hour. They don't even make it to the ambulance or the helicopter. You're not going to see them. But the ones that do make it to the hospital, a high percentage of those will die within 24 hours if not properly intervened upon. So aortic injury, what are we going to look for? Well, the mediastinal blood collection is always something that worries people, and I'm going to tell you, you need to back away from that. So if you look at this CT scan, you're going to say, wow, there's some blood along the aorta. So how many of you are going to read that as can't rule out aortic injury? All right, just be careful. Most of these bleeds are venous. Most of these bleeds are from just a little tugging and that causes a small venous tear, and that blood accumulates and gives you the concern that this aorta is not intact. Well, we had a series of about 20 of these early on as we were interpreting these cases, and all of them we ended up calling the angiographer. It was the middle of the night. Those guys hated us. And I'll tell you that all of them were negative, no aortic injuries. So realistically, use CT angiographic technique. You're not going to miss aortic injuries. You're not going to miss those little intimal tears. You don't want to yell wolf and have people do procedures that are unnecessary. That small mediastinal collection of blood, more often than not, is nothing. So here's a case, maybe there's a little mediastinal widening, right? And then clearly here's an aortic transection. Here it's seen on the reconstructed view, and these patients end up with stents these days. This is the way to treat them, but also your job is to identify aberrant vessels, because treating with stents, you want to make sure that you're not dealing with an aberrant left subclavian. This one will cause problems for the individual trying to put in one of these stents. Endovascular repair of aortic injury is now increasing rapidly. Why? Because emergent aortic surgery had a very high mortality rate. Again, this was a space that contained the bleeding, but as soon as a surgeon cracks the chest and opens it up, the bleeding reestablishes, and that's the aorta. It's vigorous. So the ability to get in there and cross-clamp the ascending aorta, no matter whose hands it in, it's hard to do. And so a high percentage of these patients used to die. With endostenting, the success rate is much, much better. Now, there are some adverse effects, paraplegia and stroke, but it's a hell of a lot better than mortality. Okay, now, what do you think of this aorta? Or that one? Okay, these are little raised intimal flaps. So this is a patient who had a rapid deceleration injury, but it was not so rapid that it transected the aorta completely, just little intimal tears. So remember, you have in the blood vessels, any artery, you have an intima, a media, and the adventitia. The media is that thick muscular wall that holds in all that pressure. The intima is a relatively thin layer. It's like Teflon. It keeps blood cells from sticking on it. The media is more elastic. It can stretch. The intima, not so much. It's more brittle. And so if a patient has just the right decelerating forces, they can tear the intima, but the vessel itself still has integrity. And so you end up with these little intimal flaps that stick into the lumen of contrast. We can pick these up. So are we going to treat these? How about this one? This one's actually got a little bit of ulceration developing in it already. Contrast is oozing under that flap. We don't know the natural history of these, how these are going to evolve. The policy is that we need close follow-up on these patients if they're going to be doing non-operative management. So once the intima tears, it creates a pathway for the pressure within the aortic lumen to pump into that aortic wall, and eventually what's going to happen is you end up with little pseudoaneurysms, and then these can grow. This was a post-traumatic intimal tear that had a 6-month follow-up, and look at this massive pseudoaneurysm that developed. So just be aware, small intimal tears, you should include in your report the suggestion for follow-up scanning, because the risk of pseudoaneurysms is 5%, and these can rupture. With intimal tears, also dissections can develop, and you hopefully know about these already. All right, splenic injuries, about 9%. It's the most commonly injured organ. We look for organ disruptions such as this. The trauma surgeons have grading scales. I don't like to use them. Personally, I think they're out of touch with today's imaging techniques. They're really for research purposes. I tell my residents, if you're busy on call, don't bother. If you look at this, really, who cares about these kind of gradations? What's most important is there active extravasation or not? Is the organ intact or is it fragmented? Those are important criteria. Here's a patient who had a little splenic laceration. All right, 4 days later was rescanned because there was a drop in hematocrit. In this patient, observation failed, rebled, went to the OR, had a splenectomy. I'll tell you that the vast majority of patients who we scan for a drop in hematocrit post-trauma, we find nothing. It's hemodilution. Some nurse had the IV running vigorously, they drew bloods, the crit dropped, they got worried, they got a scan, we find nothing. This is an oddity. Maybe 1 or 2 a year do we find that have delayed bleeds. But here's an interesting one. This patient obviously had a splenic injury, follow-up 8 days later, and now there's an unusual accumulation of contrast here. What do you think we're looking at there? Pseudoaneurysms. Any vessel with the right amount of deceleration and intimal degradation can develop pseudoaneurysms over time. Liver, second most common injured organ. Penetrating injuries, not so much, but this is an important concept. Shear injuries along stress risers. A stress riser is a weak point in the system. If an architect is building in an earthquake zone, they make sure the building has uniform structural integrity throughout. You don't want to have a floor that's particularly more rigid than another, because that then becomes the focal point at which energies start to focus, and the building can collapse. And the same thing in the liver. There are structures, anatomic structures, that focus shearing energies, forces, and you get these kinds of shear injuries. Note this one, from the cava along the hepatic veins right out to the edge of the liver. There's a hepatic vein right there. So stress risers are very significant. Here's one, the shearing injury is right across the falciform ligament. It just extended on upward. Just keep that in the back of your mind as you're looking at trauma cases. And now, in this era, interventional embolization is getting more and more popular. So really only 4 out of 5 patients who we see acute bleed end up getting intervened upon, and a lot of them now, instead of going to surgery, will get interventional embolization. So what are we going to do with this case? There's a big injury in the posterior right lobe of the liver. Do we intervene? Do we follow it? You know what? I don't see any active extravasation of blood, even though that's a big injury. These just get followed. Renal trauma, direct blow, maybe laceration by a liver, but stress riser, again important. Hydronephrosis, fetal lobulation, underlying cysts, those are points at which stress is imparted and injuries happen. Gradation, and the vast majority of these are managed non-operatively. Again, they are within Gerota's fascia, leave it alone, let it heal. Grade 1 is about 80% of injuries. These are contusions, little focal areas of decreased perfusion, maybe a little subcapsular hematoma. Note, it spares the hilum. Grade 2, non-expanding hemorrhage. You can see a subcapsular, a little perinephric hematoma, maybe a little laceration. This is a grade 3 injury, but they don't involve the collecting system. There's another one. Grade 4 injuries extend into the collecting system. That's why you need those delayed scans to see the extravasation of contrast. One other important point. With patients like this, the creatinine level is going to go up because that urine is rich in creatinine. It just spilled into the soft tissues. It's becoming reabsorbed. Creatinine is recycling in the body, therefore creatinine levels are going up. Guess what? Don't bother getting creatinine levels in the emergency department because this is the kind of patient who really needs the contrast to identify the injury, and you're going to miss it. Vascular injuries can be completely, vessels can get intimal tears, can get transected, and you end up with non-perfusion of a kidney, decreased perfusion, or in this case, non-perfusion to a segmental area. This is a polar artery injury. 10% of patients have these little arteries going directly through the capsule into the kidney. Segment 5, grade 5 injuries are shattered, devascularized kidneys. Guess what? In this age, we leave them alone. If you go in there surgically, these are going to end up being nephrectomies. You can't put this back together again. Devascularization. All right. Bottom line, 85% of kidneys, 90% of kidneys are salvaged without surgical intervention. All right, let's move on. We're running out of time. Bladder trauma. 10% of all GU injury involves the bladder, and there's two main types we have to consider. Intraperitoneal, these are usually related to seatbelt injury. Pressure comes in from the outside, and the path of least resistance for the urine in the bladder is to pop up through the dome of the bladder into the peritoneal cavity. Extraperitoneal injuries are usually related to pelvic fractures that come and lacerate the base of the bladder. So on cystogram, contrast will spill into the peritoneal cavity with intraperitoneal injuries and then into the soft tissues of the pelvis with extraperitoneal. So this curious collection of contrast is extraperitoneal. It's coming up along the psoas. That's an extraperitoneal pathway of spread. On CT, the intraperitoneal extravasation is between bowel loops and extraperitoneal within the musculature of the pelvis. We don't do X-ray cystography anymore. We do cystograms on the table in CT if we need to. We use some dilute contrast, put it in, and we get a scan like this. It makes it just a slam dunk. You know immediately if there's an injury. Urethral injuries are typically at the urogenital diaphragm, and it will elevate the base of the bladder. With those kinds of injuries, placement of Foley catheters is usually a misadventure. As you can see, contrast down here from a retrograde urethrogram ends up going down the into the soft tissues of the pelvis. Urethral injuries usually result in elevation of the bladder, and that is due to the fact that the hematoma accumulates under the bladder, pushing it up. We're not good at intestinal injuries, okay? We don't use oral contrast. It takes too long. There's an aspiration risk, and the patient is likely, this contrast isn't going to go anywhere anyway. If there's significant injury, there's going to be an ileus. Sure, if you gave it and it extravasates, it's easy to find, but most of the time, you're not going to, it's not going to go anywhere. What we look for is collections of blood in proximity to the duodenum, thickening of the duodenal wall, maybe an intramural hematoma, or air and blood extravasating out. Duodenum is a commonly injured organ. It's right in the path of the airbag, and it gets pressed against the spine, and it's also fixed. It's not freely mobile. It doesn't have a mesentery. We're not good at looking for contusions or mesenteric hemorrhages unless the patient is obese. Body habitus makes a big difference. So here you can see a mesenteric hematoma or an active extravasation of blood or intramural bowel hematoma. These can actually lead to bowel obstruction. And don't forget to check for free air. Use your window width and level settings. Make sure you identify free air because that is really good for identifying any kind of perforated bowel. Okay, what do you think about this bowel? Emblazon this in your memory. This is shock bowel. This is an injury of hypoperfusion. This patient was profoundly hypotensive for a prolonged period of time. This is not from a direct blow to the gut. Remember, the gut is very highly metabolic. And so with ischemia, it's very susceptible to injury. There's a breakdown in the basement membranes. When you inject contrast, there is leaking of contrast through the basement membrane into the tissues, and so the bowel folds, the walls become hyper-enhanced, and the bowel is just typically sitting this. What does this mean? Well, this means that this person is toast, because if the bowel is looking this bad, the brain isn't any better. All right, so this is a bad finding. We're not good at pancreas injuries because most of them take time to evolve. Yes, if there's an acute fracture or an acute blood collection, that's one thing. But most of the times, pancreatic injuries take a week to manifest as pancreatitis, and then maybe 2 weeks to develop a pseudocyst. We're also not good at traumatic injuries of the diaphragm. Mortality rate's pretty high, but that's usually because it's, if you rupture the diaphragm, you're likely to do a lot of damage to yourself. Incidence about 4 to 6% of MVA cases. Why we don't do well is because these people are typically in the ED on positive pressure ventilation, and that's pushing everything down. Really, for us to make the call, we need to see the herniation. So we miss about 70% of them. Here, the liver is herniating. Here, omentum is herniating. Stomach can herniate through there. If you're doing the CT scan and you find this, speak up, all right? That's a flat cava. The flat cava indicates that this person is likely underhydrated. They need to get their fluids up. These people can crash fairly quickly. All right, one more curiosity. This person was writing something as they were in the passenger seat, and they couldn't find the pencil after the trauma. We found it for them. All right, conclusion. A, hemodynamically stable patient. You don't want to run a code in the CT scanner. Use angiographic technique for aorta. Parenchymal enhancement is critical. Delayed scans for urinary injury. Don't bother with creatinine levels. Don't bother with oral contrast. All right, thank you.
Hello. I'm Steve Primack from Oregon Health and Science University, and welcome to this online talk series presented by the STR. This talk will focus on blunt thoracic trauma. I have no relevant disclosures. In this talk, I will review the imaging features of injuries due to blunt thoracic trauma, while the emphasis will be on CT findings. Pertinent radiographic findings will also be discussed. The talk will be divided into the sections listed below. Due to time restraints, I will not be able to cover skeletal trauma in this presentation. Traumatic aortic injury is the most critical diagnosis in the blunt thoracic trauma patient. The chest radiograph still is often the first imaging study obtained in the trauma patient. In most cases, a negative chest X-ray excludes aortic injury with a negative predictive value of 98%. However, positive predictive value is quite low. Several findings have been described radiographically to suggest mediastinal hematoma. Mediastinal widening is the classic finding. However, there's really no precise way to define this, and most often apparent mediastinal widening is due to low volumes, vascular congestion, mediastinal fat, or just related to the AP technique of the chest radiograph. The more specific findings on the radiograph include right paratracheal density equal or greater density than the aortic arch, should raise suspicion for mediastinal hematoma. If the aortic arch is poorly defined, particularly in a younger patient, that should raise suspicion. Left apical cap due to extrapleural hematoma tracking above the apex. And then NG tube or tracheal deviation to the right, or very difficult finding to make downward displacement of the left main bronchus is a finding of a contained mediastinal hematoma. However, in most cases, the mechanism of injury usually determines the need for CT. CT findings in traumatic aortic injury have been well described. Keep in mind, periaortic mediastinal hematoma is present in most cases, and then most injuries occur in the proximal descending thoracic aorta, just distal to the origin of the left subclavian artery, so that's where most of the evaluation should be paid attention to. Several direct findings have been described. Pseudoaneurysm is the classic finding in traumatic aortic injury. One may see a focal intimal flap. There may be abrupt caliber change of the thoracic aorta. Occasionally, one will see extravasation of contrast indicating a significant surgical emergency in a traumatic aortic injury. And then more recently described is minimal aortic injury, where one might just see some subtle wall irregularity or a small filling defect within the aortic lumen. So let's look at a few cases. It's an 18-year-old involved with an MVA, and we see obvious mediastinal widening. There's increased density of the right paratracheal region. There's loss of definition of the aortic arch, as well as a left apical cap. And on several CT images, we see extensive mediastinal hematoma in a periaortic distribution. There's a focal intimal flap, as well as a pseudoaneurysm in the proximal descending thoracic aorta. On sagittal reconstructed images, we see a large circumferential pseudoaneurysm, abrupt caliber change of the aorta as well, indicating significant traumatic aortic injury. This individual sustained a high-speed MVA. We see a large layering left pleural effusion consistent with a hemothorax. There's a clear-cut left apical cap, loss of definition of the aortic arch, indicating a high suspicion for traumatic aortic injury. Axial CT image shows significant periaortic mediastinal hematoma, and then a classic appearance of a pseudoaneurysm. Sagittal reconstructed images. Image shows a pseudoaneurysm on the undersurface of the proximal descending thoracic aorta. Note the acute angle with the undersurface of the aorta. Different patient. Couple of images here. A small amount of mediastinal hematoma in a periaortic distribution. We see a intimal flap and a classic pseudoaneurysm indicating traumatic aortic injury. In this patient who had severe trauma, we see multiple right-sided rib fractures with subpleural hematoma, large area of pulmonary contusion. The left hemidiaphragm is elevated, and that turned out to be a diaphragm herniation. And then more subtle, we see slight widening of the aortic arch, but really no widening of the right paratracheal region. And then this is an example of subtle but real depression of the left main bronchus. CT images in this case, the first finding we want to be able to appreciate is that there's an aberrant right subclavian artery. Additionally, we see periaortic mediastinal hematoma, as well as a traumatic pseudoaneurysm. So indeed, this patient had traumatic aortic injury in addition to several other traumatic injuries. This 42-year-old man who sustained a MVA, we see right paratracheal widening and increased density. Also note that the right lung is small in volume. Several CT images, so that we see the apparent mediastinal widening is actually due to right lower lobe and right upper lobe atelectasis. This is the top of the pulmonary artery. And then what is this focal outpouching of the proximal descendant thoracic aorta? Note that there's no evidence of mediastinal hematoma in this case. If we look at oblique reconstructed images, we see a smooth outpouching of the proximal descending thoracic aorta. Note that there's obtuse angles with the undersurface of the aorta. And this is an incidental ductus bump, not to be confused with a traumatic aortic injury. So if we look at these side by side, note that the ductus bump is an outpouching classic location of a traumatic aortic injury, but has very smooth obtuse margins with the undersurface of the aorta. Compare that to the traumatic pseudoaneurysm, where we see acute angles with the undersurface of the thoracic aorta. Two other examples, ductus bump on your left, small outpouching obtuse angles with the undersurface of the aorta. Compare that with the traumatic pseudoaneurysm, where we have outpouching and very acute angles with the aorta. 47-year-old sustained MVA. We see widening of the right paratracheal region with increased density, so high suspicion for mediastinal hematoma. A couple of CT images, we see significant mediastinal hematoma in a periaortic distribution. However, if we look lower down, we see a burst fracture, and the thoracic aorta is normal throughout. So no evidence of traumatic aortic injury and a mediastinal hematoma due to a spine burst fracture. This patient sustained a high-speed MVA. We see definite periaortic mediastinal hematoma, and in the mid-descending thoracic aorta, we see this subtle irregularity of the aortic wall. And this would be an example of a so-called minimal aortic injury, where often these are followed conservatively, but important to recognize. And in this patient, we see a CT scan from 3 days following the injury. We see decrease of the mediastinal hematoma and a normal appearing aorta, so resolution of this minimal aortic injury. Another patient, we see evidence of periaortic hematoma, a small amount of that, and then the aorta throughout is completely normal. So we can trust that this periaortic hematoma is very, very likely due to something else with a normal aorta. Notice here's a very common finding due to pulsation artifact in the ascending aorta, a normal finding. This patient had a CT for other reasons 8 days later, and we see an example where the aorta lumen is sharply defined and the small amount of mediastinal hematoma has resolved. The 63-year-old woman had blunt trauma due to being stepped on by a horse. In this case, we see a fair amount of mediastinal hematoma, although note that this is all just immediately above the aortic arch. And then a very abnormal appearance of the proximal right brachiocephalic artery. And on reconstructed images, we see a classic appearance of a pseudoaneurysm at the origin of the right brachiocephalic artery, indicative of a traumatic tear. 64-year-old woman status post-MVA. We see a fair amount of mediastinal hematoma, but in this case, it's in the tracheoesophageal region and also in the region of the azygos arch, but really no periaortic hematoma. And then we actually see a pseudoaneurysm involving the azygos vein at the level of the azygos arch, and this is an azygos arch tear. Very unusual injury, but one that does occur and should be recognized if you come across it. So moving on to pulmonary parenchymal injuries, which are basically pulmonary contusions and pulmonary lacerations. Pulmonary contusion is a lung injury combined with hemorrhage and edema. It's usually evident at presentation and should always be present within 24 hours of trauma. They tend to be peripheral, they cross segmental boundaries. Classically, they present as poorly defined ground glass opacities or consolidation, and air bronchograms are rarely evident within pulmonary contusions. And then on imaging, whether it be radiographically or on CT, there's usually some clearing of pulmonary contusions within 2 to 3 days. So here's two examples. On your left, we see peripheral non-segmental ground glass opacity, very classic for pulmonary contusion. And here's a more focal consolidative opacity in the periphery of the left lower lobe, indicative of pulmonary contusion. Pulmonary laceration is defined as pulmonary parenchymal tear with rupture of alveolar walls. They present as thin-walled cystic spaces with or without fluid within the cystic spaces. There's almost always surrounding pulmonary contusion, and on radiographs, the lacerations are usually obscured by the pulmonary contusion. So here's a classic example. We see extensive ground glass opacity, albeit fairly well defined, and multiple cystic air spaces indicative of pulmonary laceration. A nematocele is defined as a laceration that's filled with air, and that typically presents as a cyst or cavity. A hematoma or a hematocele is a laceration that's filled with blood, and that typically appears as a well-circumscribed nodule. Keep in mind that hematoma can persist for several weeks or months, so it can be confused with a solitary pulmonary nodule. A few examples of lacerations. Here we see several displaced right-sided rib fractures, patchy ground glass and consolidation in the right lung. And on CT scan, we see adjacent to one of the rib fractures a well-defined consolidation with a couple cystic air spaces, indicative of pulmonary laceration. Lacerations can be divided into several types. Type 1 is the most common, and it's a compression injury, and typically is an intraparenchymal consolidation or ground glass with a cystic space. Type 2 is a shearing mechanism and classically are in the paravertebral region, as in this case we see a small pulmonary laceration in the right paravertebral region in the right lower lobe. Type 3 is from actual tearing mechanism, typically from a fractured rib, as in this case we see a rib puncturing the lung, and we see extensive pulmonary laceration in the left lung. Another finding on this one that you want to recognize is the endotracheal tube tip is in the left main bronchus. Here's a presentation. We see a large pulmonary laceration, large cystic space with extensive ground glass and somewhat of a thick-walled laceration at presentation. On an 8-day follow-up, we see clearing of most of the contusion and much of the fluid within the laceration. We see a large, thick-walled cyst or cavity in the left lung. This is the same patient at presentation. We see an air fluid level within this pulmonary laceration, a relatively thick wall. 8-day follow-up, we see decrease of contusion and more thinning of the wall of this large laceration. This patient, we see a large area of contusion and laceration initially. On the CT scan, we see a well-defined contusion with multiple lacerations within it. And in a 3-week follow-up, most of this contusion has dissipated, and we see a well-defined nodule consistent with a pulmonary hematoma. So when we see pulmonary parenchymal opacification, in most cases what we're looking at is pulmonary contusion or laceration. However, keep in mind that aspiration and atelectasis are extremely common in the trauma patient. So if we see a large area of ground glass, fairly well defined with multiple cystic spaces within it, that for sure is going to be a large area of pulmonary contusion and laceration. In this patient, we see a classic appearance of pulmonary contusion in the periphery of the right upper lobe. However, when we look more inferiorly, there's extensive tree and bud ground glass opacification throughout both lower lobes, a pattern very characteristic of aspiration. This patient will have a classic appearance of right lower lobe atelectasis in this trauma patient, sharply defined lateral margin, essential collapse of the right lower lobe. Follow-up the next day has significant decrease in the right lower lobe atelectasis, and we see this high attenuation, well-defined structure here, which is actually an aspirated tooth responsible for the atelectasis. This patient who just sustained blunt chest trauma, really no other findings of trauma within the chest, but we see this fairly well-defined ground glass consolidative opacity with some cystic spaces in it. So keep in mind that not everything is a contusion. This was followed and turned out to be an incidental lung cancer in this trauma patient. Moving on to hemothorax. Classically, pleural fluid that's a hemothorax will have high attenuation values, usually 35 to 70 Hounsfield units. The hemothorax is often heterogeneous. We occasionally can detect active bleeding with contrast extravasation into the pleural space. One may see fluid hematocrit levels. Keep in mind that delayed hemothorax occasionally occurs, particularly with multiple rib fractures. And as the blood clots in a hemothorax, we may get an appearance of so-called fibrin balls, and this may mimic pleural tumors on occasion. So here's a classic case, somebody with multiple rib fractures, and we see this very heterogeneous right pleural fluid collection with low and high attenuation pleural fluid, very classic for a large hemothorax. This patient who sustained multiple rib fractures, and this is a delayed presentation of hemothorax, and we see these focal areas of high attenuation, so-called fibrin balls from clotting blood within the pleural space in this hemothorax. Moving on to pneumothorax, keep in mind that only 45 to 70% are going to be detected on the supine chest radiograph. Classically, we'll look for the visceral pleural line, although this is often not evident on a supine AP chest radiograph because the air is going to be more anterior and not demonstrating a visceral pleural line laterally. We look for a deep sulcus sign or subpulmonic lucency in the supine patient. If one sees subcutaneous gas plus rib fracture or fractures, there's probably pneumothorax present, just not evident on the chest radiograph. Tension pneumothorax is a clinical diagnosis. However, if we see certain findings, we can very highly predict that it's a tension pneumothorax, particularly depression of a hemidiaphragm is going to be the most specific finding of a tension pneumothorax. If we see mediastinal shift or splaying of the ribs, we should also suggest that there might be a tension pneumothorax. In this patient, we see a classic deep sulcus sign, so a lateral lucency over the right hemidiaphragm laterally, as well as this subpulmonic lucency, fairly sizable pneumothorax likely present. In this patient, the visceral pleural line is very, very subtle. There's also this lucency projecting over the lower right hemithorax, very subtle, difficult to appreciate, and we see actually a very large pneumothorax anteriorly on the CT scan in this patient. This patient has a very large left pneumothorax with near complete collapse of the left lung, and then when one sees this depression of the left hemidiaphragm, that indicates that this is under tension in this intubated patient. Briefly on pneumomediastinum, one has to be concerned when one sees a pneumomediastinum in trauma. Could there be a rupture of esophagus, trachea, bronchi, but also just ruptured alveoli can lead to pneumomediastinum. Pneumomediastinum can also occur from air dissecting from neck or retroperitoneal injuries. But keep in mind, statistically, over 95% of cases of pneumomediastinum are from ruptured alveoli. And this has been the so-called Macklin effect, where air from alveolar rupture dissects centrally along the interstitium. Classic case of pneumomediastinum, blunt chest trauma. We see extensive pneumomediastinum tracking into the neck. There's actually some air in the inferior pulmonary ligament here, and this was from a blunt chest trauma from a face plant with a snowboarder. Moving on to tracheobronchial injury, they're very uncommon to detect, and they typically occur in very severe trauma with many associated injuries. Bronchial tears are usually within 2 centimeters of the carina, the right being more frequent than the left. Tracheal tears are usually longitudinal and usually in the posterolateral aspect of the trachea. Iatrogenic tracheal injuries can occasionally occur from traumatic intubation. Tracheobronchial injury is important to recognize because if unrecognized, they can lead to stenosis. Findings that we look for is basically air where it shouldn't be, pneumothorax, pneumomediastinum, subcutaneous air, and there's often a lot of it. Another finding would be that the lung fails to re-expand following appropriate chest tube placement for pneumothorax. The fallen lung sign is a well-described finding, particularly on the chest radiograph, and that's a finding we see in bronchial tear. If we see an extraluminal position of the endotracheal tube, that clearly means a tracheal tear. However, also look for cuff overinflation may suggest a tracheal tear. And also keep in mind that direct visualization of tracheobronchial tears is often quite difficult, and it's really the other findings that we look for and then a high suspicion for it. Here's a patient with a large pneumothorax and the fallen lung sign. So typically a lung, when it collapses from a large pneumothorax, should collapse towards the hilum and not fall with gravity. Chest tube is placed in this patient appropriately in the pleural space, but there was still a persistent large pneumothorax. At bronchoscopic evaluation, this patient was discovered to have a right main bronchus tear. In this patient, a presentation had extensive bilateral subcutaneous gas, had multiple chest tubes placed. With chest tube placement, had a persistent right pneumothorax as well as extensive pneumomediastinum. And at bronchoscopy, this patient was discovered to have a bronchus intermedius tear. This is the same 63-year-old woman we discussed earlier, stepped on by a horse. We see subcutaneous gas, we see pneumomediastinum. On the CT scan, we see the pneumomediastinum as well as this focal defect and extraluminal gas posteriorly in the trachea, and this was discovered to be a tracheal tear. High-speed MVA, we see extensive bilateral subcutaneous gas, extensive pneumomediastinum. And then the other finding one wants to detect is this balloon is quite overinflated. So that should raise suspicion for a tracheal tear. On CT scan, we again demonstrate the extensive pneumomediastinum the overinflated balloon cuff. We really can't see the tracheal tear here, but this patient was explored and had a large posterior tracheal tear. Moving on to diaphragm traumatic injuries. They can be termed lacerations or herniations. Left side more commonly identified than the right at approximately a 3-to-1 ratio. Frequently, other traumatic injuries may distract from detecting a diaphragm tear, so one has to have a high level of suspicion to detect these. Now, there's usually other abdominal injuries, so occasionally a diaphragm injury may be discovered while exploring the abdomen surgically. And it's important to detect these injuries because delayed herniation has a very high mortality if it occurs. Chest radiograph is usually abnormal with diaphragmatic injuries, but is frequently nonspecific. There's often obscuration of the hemidiaphragm. One may see what looks like an elevated hemidiaphragm, which is actually the herniated portion of the abdomen. One looks for a herniated bowel or herniated stomach. One may see an abnormal course of the NG tube. Radiograph, which would be classic for traumatic diaphragm hernia. So we see an abnormally elevated stomach, and then we look at this very narrow waist or collar of the stomach as it herniates through the diaphragm. CT scan, several findings have been described in the literature. Classically, you can see a focal discontinuity of the diaphragm that indicates diaphragm injury. One obviously looks for herniation of abdominal contents. A collar sign is a finding seen in herniation. The dependent viscera sign is a finding of herniation. In most cases, one would see focal diaphragmatic thickening and inflammatory changes or fluid adjacent to the diaphragm for an acute diaphragmatic injury. In the literature, the sensitivity of CT ranges from 70 to 90% with specificity greater than 85%. It's also got a few examples. This is an example of a diaphragm herniation acutely, and we see a collar sign and dependent viscera sign. So here's the collar sign where we see the intra-abdominal portion of the stomach is more anteriorly, and then the narrowing or wasting of the stomach as it herniates through the diaphragm, and then the intrathoracic portion of the stomach is more posterior. And that's been termed the dependent viscera sign. So the stomach, while it's in the abdomen, should be more anterior and not abutting posteriorly, but as it herniates into the thorax, it tends to layer against the rib cage. And on the chest radiograph, we look at this, we can see the collar sign on the chest radiograph indicative of herniation. In this example, we see classic example of the collar sign. So the anterior portion of the stomach here is the intra-abdominal portion, and then the herniated portion of the stomach is more posterior. And then this is an example of the dependent viscera sign where the stomach is abutting posteriorly. We may detect lacerations without herniation. In this case, if we look at a nice normal right crus smoothly tapering, whereas the left crus has an abrupt termination, a lot of fluid and inflammatory changes at the point of the laceration. A couple other examples of diaphragmatic herniation. We see a small focal portion of the kidney is herniated on the right, and you see an obvious defect in the diaphragmatic crus. And in this patient, we see a large amount of colon that's herniated, and the abrupt termination of the right crus indicative of a torn crus with herniation of colon. Sagittal and coronal reformations are very important in evaluating diaphragmatic injury. Although we can detect most of these with axial images, we're clearly limited by the plane of imaging, and using sagittal and coronal reformations definitely increase conspicuity. So in this example, it's an old case, we see this large amount of omentum or fat next to the left heart border, and is that intrathoracic normally, or is that a herniation? And if we do a sagittal reconstruction, we see an obvious defect in the diaphragm with herniated omentum, so a clear-cut diaphragmatic hernia. This patient, we see what looks like an elevated left hemidiaphragm, but this certainly could be a hernia on the left. We do axial images in this patient. We see what looks like a dependent viscera sign. The stomach should not be abutting the posterior ribs. And is this a collar sign, this little focal indentation? If we look at multiple coronal reformatted images, we see here the collar sign on the coronal view. So this is clearly a herniation of the stomach through the diaphragm. And then on multiple images, you see this abrupt cutoff of the diaphragm indicating an acute injury of the diaphragm. Most common pitfall for diaphragm injuries would be incidental bacterial hernias, which occur particularly at increasing frequency in older patients, not as common in younger patients when we see them. And here we see somebody with bilateral incidental bacterial hernias, and the hint that these are not acute is there's really no other finding of trauma in that region, no blood, no inflammatory change in that region, and they're smooth and tapered. 61-year-old individual status post-trauma, we see a large amount of fat next to the right heart border. And on the coronal reformatted images, we see a defect anteriorly in the diaphragm and a clear hernia anterior. So this would be a very unusual location for a traumatic diaphragm hernia, but a classic case of a Morgagni hernia. And if we look at the chest radiograph on this patient, this appears as a right pericardiophrenic angle mass, and in that Morgagni hernia is in that differential. So one last case, 73-year-old woman was in a severe motor vehicle accident, had severe chest pain, and we see here extensive subcutaneous gas bilaterally. If we look on lung windows, a few findings here. We see air in the pericardial space, and this has been termed the empty pericardial sac sign. Addition, we see a very unusual appearance of the heart, where the apex of the heart is projecting more posteriorly as opposed to anterolaterally. And then we see what's been termed the collar sign, where we see this narrow waist of a portion of the heart. And so this is a classic appearance of traumatic pericardial rupture. So very unusual diagnosis, but critical to make this diagnosis because prognosis is very, very poor without surgical intervention. So in summary, aortic injury is clearly the most important finding that we look for in imaging blunt thoracic trauma patients, but other injuries for sure can lead to increased morbidity and are really important to detect as well. And I do thank you for your attention in this online course. Thank you very much.
Radiologist at Indiana University School of Medicine in Indianapolis, and today I'd like to talk to you about imaging of traumatic aortic injuries. I have two financial disclosures listed here, but they are unrelated to the content of this talk. There are three learning objectives of this talk. The first is to describe the various imaging appearances of traumatic aortic injuries on various imaging modalities. Second is to describe the pitfalls and common anatomic variants that may mimic aortic injuries. And third, to list the existing definitions of minimal aortic injuries. First, we'll start with a discussion on the clinical background and mechanisms of injury for patients with aortic injuries. We'll then discuss the various imaging modalities available to us. We will then talk about major aortic injuries, such as the injury seen here. We'll then briefly discuss minimal aortic injuries, followed by imaging pitfalls and anatomic variants, and wrap up with patient management and imaging follow-up. Traumatic aortic injuries are the second most common cause of traumatic death in road traffic accidents, second behind traumatic brain injury. A vast majority of these patients, over 80%, die usually at the scene, but at least before reaching a trauma center. However, patients who do survive to get to a trauma center, a majority of those patients will ultimately survive their injuries. The literature says about 40% of patients have other severe coexisting injuries. In my experience, that percentage is actually higher than that. And a vast majority of patients with aortic injuries are seen in the setting of high-speed motor vehicle collision, by definition, which is over 30 miles per hour. The short-term outcomes of untreated traumatic aortic injuries is quite dismal. The historical literature from the 1950s shows that approximately half of patients will die within 24 hours, which is the time frame during which an aortic injury is most likely to rupture. However, newer literature from the 1990s shows an even higher mortality rate within 24 hours, with most of these patients dying. It's thought that because of improved in-field care, rapid transport of patients from the scene to a trauma center via helicopter or interstate system has gotten these severely injured patients who in the past may have died from the injuries are getting to the trauma center and then dying. Traumatic aortic injury morphology spans a wide spectrum, ranging from minimal intimal injury all the way to transection with active bleeding. However, most aortic injuries are secondary to a transverse tear in the aortic wall, resulting in a pseudoaneurysm formation. The image on the right, you can see contrast collecting outside of the aortic lumen and what appears to be a dissection flap, but this is not a dissection. This is contrast opacifying a flap of the aortic wall in the axial plane. If we look at this image in the sagittal plane of another patient and imagine yourself scrolling from top to bottom, you encounter this level where you have contrast surrounding an intimal flap in a patient with a large pseudoaneurysm. Shearing injury is felt to be the primary mechanism of injury for patients with aortic injuries. This happens primarily at the relative fixed points of the aorta, primarily at the ligamentum arteriosum. Other potential theories include hydrostatic forces, where increased intraluminal pressure overcomes the tensile strength of the aortic wall, as well as osseous pinch due to crushing injury of the aorta between the sternum and the spine. These last two theories may not be as significant as previously thought, and shearing injury is felt to be the primary cause of aortic rupture. The aorta can be injured anywhere along its entire course, from the aortic root to the aortic bifurcation. However, a vast majority of patients with aortic injuries occur at the aortic isthmus or the proximal descending thoracic aorta at the level of the ligamentum arteriosum. There are a number of imaging modalities at our disposal for evaluating patients with suspected aortic injuries. The primary modalities are chest radiography, computed tomography, and catheter angiography. MRI, though it can evaluate aortic injuries, is not typically used in the acute setting. Intravascular ultrasound can acquire high-resolution images of the aortic wall. However, it requires a special probe and expertise to perform this. Transesophageal echo also requires specialized expertise, but can be performed in the operative suite if the patient is too unstable to undergo computed tomography. The workhorse for trauma imaging, especially of the aorta, is CT. A chest X-ray is routinely obtained in the trauma bay for the initial imaging evaluation of the trauma patient, primarily to detect life-threatening injuries requiring immediate intervention. However, some information about the mediastinum may be obtained. You cannot use a chest X-ray to reliably diagnose and exclude an aortic injury. Thus, you cannot clear the mediastinum with a chest X-ray. And any mediastinal abnormality on chest X-ray warrants further evaluation, usually with CT. Understandably, patients with major aortic injuries can have substantial mediastinal hemorrhage, which is what distorts the mediastinal anatomy as seen on a chest X-ray. The findings on chest X-ray for thoracic aortic injuries include many things, but one thing you should not rely on is mediastinal widening. The old idea that mediastinal widening greater than 8 centimeters is sensitive for aortic injuries is not true. You can have normal, non-widened mediastinums with an aortic injury, and you can have wide mediastinums without an aortic injury. Other imaging features include abnormal aortic arch and aortic contours, left apical pleural capping secondary to hemothorax near the apex, rightward tracheal shift, inferior deviation of the left mainstem bronchus, and rightward deviation of an NG tube. Here's a classic chest x-ray of a patient with a traumatic aortic injury. We have abnormal mediastinal contours with an ill-defined aortic arch. We have inferior displacement of the left mainstem bronchus. We have rightward deviation of the trachea and NG tube, and left apical pleural capping due to hemothorax. Here's another patient with mediastinal hemorrhage secondary to a traumatic aortic injury. We have indistinct, ill-defined abnormal aortic and mediastinal contours, rightward deviation of the trachea, and inferior displacement of the left mainstem bronchus. There is a left apical pleural cap, though it is less evident compared to the prior image. Aortography historically was the gold reference standard for the diagnosis and exclusion of aortic injuries due to its high performance metrics. In the era before advanced CT technology, any abnormal mediastinum on a chest x-ray would warrant further evaluation with catheter angiography. This was low yield, it was time intensive, it was expensive, and it was invasive, and over 80% of the angiograms were negative. Current day, catheter angiography is delegated primarily to a problem-solving role and for treatment. Take this patient, for instance. This is a patient with a transthoracic gunshot wound. On the left image, you can see a large amount of mediastinal hemorrhage with contrast foci not clearly within vascular space. The image on the right demonstrates a large bullet fragment with extensive beam hardening artifact obscuring the vasculature. It's difficult to exclude or diagnose an aortic injury based on these images, but it was felt to be high risk for an underlying aortic injury. At aortography, you can easily see that there is rapid opacification of the pulmonary arteries due to an aorticopulmonary arterial fistula. The patient was treated with an aortic endovascular stent graft with post-stent aortography image on the left and post-stent pulmonary angiography on the right. Early research of aortic injuries with CT began in the early 1990s, and even then, using older technology with conventional and single-slice CT, accuracy routinely exceeded 90%. This was slow to gain acceptance within the surgical field due to the severe nature of this injury. So at that time, any abnormal CT would undergo confirmation with catheter angiography, and understandably, this would increase the rate of true positive angiograms. Contrast-enhanced CT of the chest has effectively replaced catheter angiography as the primary screening and diagnostic tool for traumatic aortic injuries. Current CT technology for detecting and excluding aortic injuries has high performance metrics. If CT is unequivocally positive or unequivocally negative for aortic injury, then no further evaluation is necessary, regardless of what the mediastinum looked like on chest x-ray. But if a CT is equivocal for an aortic injury, then further evaluation is necessary, keeping in mind that catheter angiography will likely still be low yield, so further evaluation with intravascular ultrasound or transesophageal echocardiography or cardiac-gated CT may be warranted. The direct CT signs of a major aortic injury manifest primarily as a pseudoaneurysm or a contained rupture contained by the adventitia. Active bleeding from the aorta can be seen on CT, however, it is very rare and is often later fatal. Abnormal aortic contours can occur, as well as aortic pseudocoarctation, which is manifested by acute intramural hematoma and narrowing of the lumen. Again, with pseudoaneurysms, the intima and media are almost always injured, contained by the adventitia. However, the adventitia can be injured in up to 40% of patients, which is often rapidly fatal. However, there is some potential for temporary tamponade from the surrounding soft tissues. In this image, we see an aortic pseudoaneurysm involving the proximal descending thoracic aorta. Again, this looks like a dissection, but it is not. We're simply seeing contrast collecting outside of the aortic lumen. Here's another patient with a major aortic injury. There's a focal defect along the anterior surface of the proximal descending thoracic aorta, resulting in a contained rupture or pseudoaneurysm. And here's another image of another patient with a transected proximal descending thoracic aorta with pseudoaneurysm surrounding the injured site and intimal flaps noted proximally. Here's another image from a patient with a major aortic injury. There's an injury of the proximal descending thoracic aorta with contained rupture or pseudoaneurysm and a large amount of mediastinal hemorrhage. Again, this looks like a dissection flap, but it's not. This is contrast extending beyond the aortic wall. Here's another patient with an injury to the proximal descending thoracic aorta with pseudoaneurysm formation. Here's another patient with a major aortic injury. The chest X-ray shows abnormal mediastinal and aortic contours. Coronal CT image through the chest demonstrates a rupture of the right lateral wall of the thoracic aorta with a pseudoaneurysm formation. The patient also has a left diaphragmatic rupture with herniation of the stomach through the diaphragmatic defect. Here's a patient with blunt thoracic trauma demonstrating a pseudoaneurysm of the proximal descending thoracic aorta. The image on the right shows diffusion of contrast into the mediastinal soft tissues. Sagittal oblique image demonstrates active bleeding from the aortic rupture. Most of these patients who are imaged with CT will succumb to this injury. The indirect CT signs of an aortic injury are less important now in the advent of high-resolution multi-detector CT. Mediastinal hemorrhage and perivascular hemorrhage are indirect signs. However, as you can see in the patient on the right, there is mediastinal hemorrhage with a clear fat plane between the hemorrhage and the aorta, which was uninjured. If you do see indirect signs of an aortic injury on CT, you could do a number of things, including follow-up chest CTA without or with cardiac gating. You could do catheter angiography, however, this is likely going to be low yield. You could also do intravascular ultrasound. Let's shift gears and talk about minimal aortic injuries. These smaller aortic injuries were encountered as early as 2001, and at that time were defined as small intimal flaps with minimal to no periaortic hemorrhage. The original study found that approximately 10% of aortic injuries are these minimal types, as you can see here in an image from the original paper showing a small intimal injury with intraluminal thrombus. Notice that there is no periaortic hemorrhage. And at that time, they correctly predicted that these minimal aortic injuries were, quote, a lesion associated with advancing diagnostic techniques, unquote. So these injuries were small enough that using older CT technology just weren't identified. Minimal aortic injuries are also called minor aortic injuries, and there is no universally accepted definition in the literature. However, those definitions that do exist include intimal injury with intraluminal thrombus, an intimal flap less than 1 centimeter in length, a pseudoaneurysm less than 1 centimeter in size, contour abnormality adding less than 10% to the diameter of the aorta, and by definition, these often have little or no mediastinal hemorrhage. So major aortic injuries are far more likely to be encountered than minimal aortic injuries. The initial research indicated that approximately 10% of aortic injuries are the minimal type. However, more recent literature suggests that these minimal aortic injuries constitute approximately a quarter to a third of all aortic injuries, so far more common than initially thought. Our own experience at Indiana University finds that minimal aortic injuries constitute 36% of all aortic injuries. Minimal aortic injuries are most frequently encountered in the descending thoracic aorta. However, compared to major aortic injuries, they are more spread out and distributed along the course of the aorta. Here's a list of some of the most recent literature on minimal aortic injuries, which I'll summarize on the next slide. Minimal aortic injuries constitute approximately a quarter to a third of all aortic injuries. The thoracic aorta is more commonly injured than the abdominal aorta, and often this occurs in the absence of periaortic hemorrhage. Mortality related to minimal aortic injuries is very low, though some embolic events may occur in approximately 10% of patients. Non-operative management has overall favorable outcomes. There's no universally accepted follow-up imaging algorithm for patients with minimal aortic injuries. However, a vast majority of these patients will see stability or resolution on follow-up. Let's look at some images on patients with minimal aortic injuries. On the left, we see a small intimal injury with small intraluminal thrombus. Notice that there is no periaortic hemorrhage. Patient in the middle also has an intimal injury with an intraluminal thrombus that is slightly larger. Again, no periaortic hemorrhage. Patient on the right, a different patient has an intimal injury with intraluminal thrombus, and again, no periaortic hemorrhage. Here are 3 images from 3 different levels of the aorta on the same patient showing multifocal intimal injuries with intraluminal thrombi. Here's a sagittal image through the thoracic aorta showing all these intimal injuries with intraluminal thrombi. Here are 4 images from 4 different levels of the thoracic aorta on the same patient showing all of the imaging manifestations of minimal aortic injuries. The 2 images on the left show intimal flap less than 1 centimeter in length. The top right image shows a small pseudoaneurysm. There is aortic root motion artifact, and the aortic root was not injured. And the bottom right image shows an intimal injury with small intraluminal thrombus. Now let's look at the natural evolution of patients with minimal aortic injuries. Here's an admission CT image on a 42-year-old female following a motor vehicle collision showing an intimal injury with intraluminal thrombus, which is unchanged at 24-hour follow-up. However, after 1 week, this injury has resolved. This is the typical course for patients with minimal aortic injuries. Let's look at some other images on a 25-year-old male following a motor vehicle collision. At admission, there is an intimal injury with intraluminal thrombus, which partially resolves on 3-day follow-up. After 8 days, the intraluminal thrombus has resolved. However, there is subtle contour deformity of the aorta at that level. 15-day follow-up shows interval development of a small pseudoaneurysm at the site of previous injury with small amount of periaortic hemorrhage. This is not the typical course for patients with minimal aortic injuries, though it can occur. There is no universally accepted follow-up imaging algorithm for patients with minimal aortic injuries. In the literature, there's variable intervals between follow-up exams, and typically imaging follow-up ends once the aorta returns to normal appearance. But what we don't know is what to do with stable injuries that persist over a long period of time, and we're not sure which injury types need follow-up and to what extent. One proposal published by Dr. Martin Gunn from University of Washington suggests that if the patient does have a minimal aortic injury, that it be followed up in 3 days. If the injury is still present, re-image the patient in 1 week. And if the injury is still present at that time, re-image the patient again in 1 month. It's not clear what we should be doing with these patients if the injury persists for 1 month or more. This proposal has not yet been prospectively studied. So there are many unanswered questions regarding minimal aortic injuries. For example, what's the optimal imaging follow-up algorithm? We don't really know. Should patients be followed even after injury resolution? It's rare for them to progress to more significant injuries, but we don't know how common that is. Should pseudoaneurysms be included in the definition of a minimal aortic injury? One could argue that pseudoaneurysms from a histopathological standpoint are different from intimal injuries. Should the presence of mediastinal hemorrhage alter management? Does the presence of mediastinal hemorrhage or periaortic hemorrhage in the setting of a minimal aortic injury indicate that the injury is actually more significant than what we think? What's the optimal treatment for evolving injuries? And what is the optimal conservative management for minimal aortic injuries? Now let's talk about some of the pitfalls in the diagnosis of aortic injuries, including failure to perform the correct exam, anatomic variance, atypical locations, atypical distribution along the aorta, and pediatric patients. Here's a patient transferred to our facility who received an abdominal CT for abdominal pain following a motor vehicle collision. We can see here near the top of the exam there's retrocrural hemorrhage extending inferiorly from the chest. We therefore recommended a follow-up chest CT, which revealed a major aortic injury with pseudoaneurysm formation and substantial mediastinal hemorrhage. So failure to perform a chest CT is potential pitfall for missing aortic injuries. Here's a patient with a contour deformity of the proximal descending thoracic aorta at the level of the ligamentum arteriosum. There are smooth edges, there's no intimal flap, and there's no periaortic hemorrhage. This is an anatomic variant called an atypical ductus bump and is not an aortic injury. Here's a patient who received a chest CT following blunt chest trauma. There's a left-sided hemothorax, there's retrosternal hemorrhage, and there's mediastinal hemorrhage. There's also a tubular finger-like projection of contrast arising from the proximal descending thoracic aorta in the region of the ligamentum arteriosum. This patient went on to catheter angiography, and this is an anatomic variant called a ductus diverticulum. Here's a companion case of another patient with a ductus diverticulum who received imaging following a motor vehicle collision. Again, a finger-like tubular projection of contrast arising from the proximal descending thoracic aorta at the level of the ligamentum arteriosum. This is a congenital variant ductus diverticulum and not an aortic injury. Here's a case provided to me by Dr. Stu Mervis from University of Maryland. There's a small focal outpouching along the right wall of the proximal descending thoracic aorta. This looks like a small pseudoaneurysm. However, if you scroll down, this is actually a bronchial artery. So sometimes patients have very prominent bronchial artery origins which can simulate an injury. Here's an unusual case of a 13-year-old girl involved in a motor vehicle collision. There are abnormal mediastinal and aortic contours. And on chest CT, we see substantial mediastinal hemorrhage with a pseudoaneurysm of the proximal descending thoracic aorta. However, in the distal thoracic aorta, there's another pseudoaneurysm with periaortic hemorrhage. And on sagittal MPR, we can see that there are two pseudoaneurysms of the thoracic aorta. So this is unusual, one, because this is a pediatric patient. Major aortic injuries are not common in the pediatric population, and there are two aortic injuries. Here's an unusual case of a patient with an aortic root laceration. As you can see here on axial, sagittal, oblique, and 3D imaging, there's a large amount of mediastinal hemorrhage and hemopericardium. This is unusual because most of the time these patients die and don't get imaging. Here's a patient with abnormal bulbous contours of the right side of the mediastinum. On CT, the patient has a right-sided aortic arch which is transected. There's a pseudoaneurysm and large amount of mediastinal hemorrhage. So this is unusual because this is a right-sided aortic arch which is transected. Here's a patient with an abnormality of the abdominal aorta manifested by luminal irregularity, interluminal flaps, and interluminal thrombi. When you see this appearance, be sure to look at the sagittal and coronal reformatted images, which we can clearly see now. The patient has a transected abdominal aorta with pseudoaneurysm formation and intimal flaps within the aortic lumen. There are a number of treatment options for patients with aortic injuries, including open versus endovascular repair and immediate versus delayed. Typically in the modern trauma center, most patients will receive immediate therapy with endovascular stent placement. This is a strong recommendation by the Eastern Society for the Surgery of Trauma. Imaging plays a big role in the planning for endovascular stent treatment of aortic injuries. We can see where the injury is with respect to the origin of the left subclavian artery, the distance from the left subclavian artery origin, and the caliber of the thoracic aorta just proximal and distal to the thoracic aorta to allow for proper stent selection. Here's a patient who received endovascular stent treatment of a major aortic injury of the proximal descending thoracic aorta. You can see the stent within the lumen of the aorta and its distance with respect to the origin of the left subclavian artery origin. In conclusion, aortic injuries are not common, but when they do occur are highly lethal injuries. CT is the de facto reference standard for the detection and exclusion of aortic injuries. with early diagnosis and definitive therapy improving overall survival. Immediate treatment of major aortic injuries with endovascular stent therapy is the most common treatment option. Advancing imaging techniques have resulted in the detection of smaller aortic injuries which in the past may have evaded detection. And minimal aortic injuries constitute approximately 1/3 of all aortic injuries. Here's a list of the references used in this presentation.
From learningradiology.com, chest trauma. Hello, I'm William Herring from Albert Einstein Medical Center in Philadelphia. Trauma is the leading cause of death in the United States from ages 1 through 45. Motor vehicle collisions are the largest contributor to blunt chest trauma. The major goal of imaging in trauma is to determine if surgery is required. We're going to look for rib fractures, pulmonary contusions, pulmonary lacerations, abnormal collections of air, and abnormal collections of fluid. Rib fractures are the most common blunt chest injury. They are important because of the internal injuries with which they're associated. In one study, the mortality rate reached 12% in individuals who had rib fractures associated with their chest trauma, and it was estimated that there was a blood loss of 100 to 150 cc's per rib fracture. In another study, elderly patients with 3 or more rib fractures were found to have a 4 times greater mortality than those who did not. So rib fractures are important markers for significant underlying disease. Ribs 4 through 9 are the most commonly injured. If you see a fracture of rib 1, then you should look for associated facial fractures. Ribs 1, 2, and 3 traditionally have been thought to be protected, and so fractures of those ribs have been associated with serious trauma, like a rupture of a bronchus. Fractures of ribs 4 through 9 could produce pneumothoraces or pulmonary contusions. And if you have fractures of ribs 10 through 12, which are below the diaphragm, then think of liver and spleen lacerations. 3 or more contiguous ribs fractured in 2 or more places can produce a flail chest. This is an example of fractures of the left 9th and 10th ribs. Since the fractures are displaced, there would be greater concern for injury to the underlying spleen. Here is a CT scan of the chest, which demonstrates a portion of a posterior rib, shown by the red arrow, which is penetrated into the lung, having arisen from the location of the blue arrow, and produced not only a pneumothorax, but also a pulmonary contusion. This is a patient involved in a motor vehicle collision who has multiple fractured ribs on the left side. The 4th, 5th, 6th, and 7th ribs are fractured posterolaterally. The 4th rib, we can see the 2 blue arrows, is fractured in 2 locations. There is an associated pulmonary contusion. This patient did have a flail chest on the left side. Flail chests are relatively uncommon. They're defined as 2 or more fractures in 3 contiguous ribs. The flailed segment moves paradoxically with respiration, so that it moves inward on inspiration and outward on expiration. There is almost always an accompanying lung contusion with a flail chest, and it has about a 10% mortality. Pulmonary contusions are the most common pulmonary injury in blunt chest injury. They represent hemorrhage into the lung, usually at the point of impact. They appear within 6 hours of the injury, and they disappear characteristically within about 48 hours after they appear. This is an example of a pulmonary contusion caused by a gunshot. The red circle indicates the presence of bullet fragments in the chest wall, and in the lung, just beneath the fragments, we can see a fluffy, ill-defined airspace density that represents the pulmonary contusion at the site of maximum impact. Here is a CT scan of another patient who has airspace disease in the posterior aspect of the left lung, shown by the red arrow that represents the pulmonary contusion. When we use bone windows, the blue arrow is pointing to the bullet in the chest wall immediately adjacent to the pulmonary contusion. Pulmonary lacerations, also known as traumatic lung cysts or traumatic hematomas, may not be initially apparent because of surrounding contusion. After the contusion is absorbed in 24 to 48 hours, then the laceration may become more visible. A laceration is actually a hole in the lung parenchyma. It usually occurs, as do contusions, in a subpleural location under the point of maximum impact. About half of all lacerations present as a fluid-filled structure, about half are air-filled. And unlike pulmonary contusions, pulmonary lacerations characteristically can take up to 6 months to clear. This is an example of a pulmonary laceration in the left lower lobe. We can see a relatively well-circumscribed soft tissue density in the left lateral aspect of the lung. Unlike a contusion, it has slightly better defined edges. In this patient, who also sustained blunt chest trauma, there is a pulmonary contusion represented by the fluffy airspace disease, in the center of which is a lucency that represents the pulmonary laceration. This is a CT scan of the chest in another patient with chest trauma. The red arrow is pointing to a pulmonary laceration that contains both air and fluid. The blue arrow is pointing to an adjacent pulmonary contusion. Abnormal collections of air include pneumothoraces, pneumomediastinum, pneumopericardium, and subcutaneous emphysema. Pneumothoraces are most frequently caused by rib fractures in trauma. They can also be caused by deceleration injuries or barotrauma. Almost all trauma patients who have a pneumothorax are treated with a chest tube. In order to diagnose a pneumothorax, you must see the very thin visceral pleural white line. There may also be absence of lung markings peripheral to the visceral pleural line, but lung markings may also be absent in cysts or bullae, so finding the visceral pleural white line is the key to the diagnosis of a pneumothorax. Beware of skin folds and beware of bullae. Here is an example of a right tension pneumothorax. We see clearly the very thin white visceral pleural line and the absence of lung markings peripheral to it. There is a slight shift of the heart and mediastinal structures to the left. The patient also has a scoliosis, which is adding to that shift. Here is a CT scan of another patient who has an obvious pneumothorax on the right side. The denser portion of the right lung at the base could represent a pulmonary contusion or an area of aspiration. And you can see that there is a slight shift of the heart and mediastinal structures toward the left, indicating that the pneumothorax is under tension. Here is a large right-sided pneumothorax to which the red arrow is pointing, with very little in the way of shift. And this is a small pneumothorax, which should always be sought on the basilar images of a CT scan of the chest when a patient is having a CT scan of the abdomen and pelvis for trauma. Air will rise, of course, to the highest point, which is underneath the anterior chest abdominal wall, and it will be visible as it is here, shown by the red arrows, as a lucency without any pulmonary vasculature. And pneumomediastinum may develop after blunt trauma, secondary to pulmonary interstitial emphysema, in which there is a rupture of an alveolus and then tracking of the air back along the bronchovascular bundles to the mediastinum. The mediastinal pleura becomes displaced away from the heart border and presents as a thin white line which resembles a pneumothorax. One finding that can help differentiate the two is visualization of the central portion of the diaphragm, called the continuous diaphragm sign. This is an example of a patient with a pneumomediastinum. You can see that there is a very thin white line adjacent to the left heart border. And this is an example of a patient with a continuous diaphragm sign. Normally, the central portion of the diaphragm is not visible because it is silhouetted by the heart, which is of the same density as the diaphragm. But when there is air in the mediastinum, then we see the diaphragm continuously from one side to the other. And here is a CT scan of the upper thorax, which shows the presence of air surrounding the trachea, which is marked with a T, the esophagus, which is the round structure just to the left of the E, and the vessels. This is a pneumomediastinum on a chest CT. Here is a coronal reconstruction, which also shows pneumomediastinum. The white arrow is pointing to air which surrounds the heart. The red arrows show that this air extends above the level of the great vessels. It extends, in fact, into the neck, and this is a pneumomediastinum with subcutaneous emphysema. Pneumopericardium generally requires direct penetration of the pericardium. Air will appear around the heart, but it does not extend above the great vessels. It is very difficult to differentiate a pneumopericardium from a pneumomediastinum. This is an example of a pneumopericardium. The air here is seen as the lucency between the thin white line representing the parietal pericardium and the heart itself, but the air does not extend above the great vessels. Subcutaneous emphysema is manifest by streaky air that interposes itself within the muscle, usually over the lateral chest wall or in the neck. A localized form of subcutaneous emphysema implies a penetrating injury at that point. A more diffuse form of subcutaneous emphysema is associated with pulmonary interstitial emphysema. This is a good example of a patient with subcutaneous emphysema. Inside the red circle, you can see multiple streaky densities of alternating white and dark lines representing air that is interposed in the muscles of the chest wall, the typical appearance for subcutaneous emphysema. And this is a lateral neck, which also shows subcutaneous emphysema. The red arrow points to the streaky air in the muscle. The white arrow is pointing to a collection of air in the subcutaneous tissue. Abnormal collections of fluid include hemothorax and chylothorax. A hemothorax is indistinguishable from a pleural effusion on conventional radiography. On CT scan, a hemothorax will have a higher CT density. Bleeding from the lung parenchyma is usually self-limiting, whereas bleeding from an intercostal artery tends to produce enlarging hemothoraces. Loculation in a hemothorax occurs early. The fibrinous adhesions occur early in the process, and loculation may occur within a matter of days. Here's an individual who has a large right hemothorax produced obviously by this bullet. You can see that there is actually a slight shift of the heart and mediastinal structures to the left by the mass effect caused by this large hemothorax. Chylothorax is unusual. The thoracic duct may be torn from blunt or penetrating injuries. The key is the appearance of a pleural effusion several days to a few weeks after the initial injury. The effusion can occur in either or both hemithoraces, and if a pleural tap is performed, it yields lymph. On the left, we see an individual with a blunt chest injury. On day 0, the red arrow is pointing to a pneumothorax. Beneath the pneumothorax, there is a pulmonary contusion, but you can see that the left lung is relatively clear. About 2 weeks later, the individual develops a large left effusion, as indicated by the red arrow, and this represented a rupture of the thoracic duct. Fractures of the trachea and bronchi are unusual. They usually require severe trauma, usually of a blunt nature, and frequently resulting in fractures to ribs 1 through 3. The main stem bronchi are affected more often than the trachea itself. Fractures of the 1st through 3rd ribs require a force that can be sufficient to rupture a bronchus. In this individual, there are fractures of the left 2nd and 3rd ribs, pointed to by the red arrows. There is no ruptured bronchus. Features of a fractured trachea or fractured bronchi include mediastinal or subcutaneous emphysema. You should look for a large pneumothorax which does not respond to suction, and if that occurs, think of a rupture of a bronchus. Lobar atelectasis is unusual as an occurrence immediately following trauma, so if you see lobar atelectasis, you should think of the possibility of a ruptured bronchus. And there is a sign called the ptotic lung sign, in which essentially
In this screencast, we will begin a multi-part series on blunt abdominal trauma. We will start by looking at active extravasation versus pseudoaneurysm. At the end of this screencast, you should be able to differentiate a pseudoaneurysm from active extravasation and recommend the next step and manage it based on the key imaging features. The main decision you're trying to make when evaluating somebody who's been part of blunt abdominal trauma is whether they can be non-operatively managed, whether they're going to require some sort of angiography to stop bleeding or other vascular complications, or whether they're going to require surgery. Before you make these key management decisions, you have to understand what type of facility you're practicing in and whether or not they have the appropriate level of care to manage a critically ill trauma patient. You need an intensive care unit. You must have 24-hour access to a CT scan. You need 24-hour angiography, often provided by an interventional radiology service. And you'll need a 24-hour operating room. That is why there is a trauma system or trauma network in most states, and patients are very quickly transferred to higher levels of care when they are found to be unstable or the victims of blunt trauma. Basic criteria for determining whether a patient is hemodynamically stable or unstable would include their blood pressure, their heart rate, whether you can detect any capillary refill, and whether or not they have altered mental status. These are 4 quick and easy ways to assess for hemodynamic stability. And patients who are unstable should be resuscitated. If resuscitation does not result in stability, they will often need to be operatively managed. If resuscitation results in stability, you can also often proceed to diagnostic imaging. Now that the patient is stable after resuscitation, how do we scan the patient? Well, there's a few different protocols, and this is very dependent on the institution that you're practicing. Here at UK, we will use a multi-phase scan, and we'll often do what we refer to as a man scan, where the entire body is scanned in multiple phases. We often will start with a non-contrast scan of the head and the C-spine. We will then do a CTA of the head and neck. That will be followed by a CTA of the chest, predominantly looking for acute aortic injury. We will then do a portal venous scan of the abdomen and pelvis. And oftentimes we will get a delayed scan at 3 to 5 minutes. Having both arterial phase, portal venous phase, and delayed phase is going to be very helpful in distinguishing active extravasation from pseudoaneurysm. Some institutions are now trying to move toward a single pass approach to reduce the radiation exposure to a patient that multiple CTs require. In this single pass approach, we will still get a non-contrast examination of the head and cervical spine, but then we will get a CTA of the head and neck, aorta, and abdomen and pelvis in a single pass. Again, this reduces the amount of radiation the patient is exposed to, but it doesn't give you that temporal information that you get by having an arterial phase, a portal venous phase, and a delayed phase. Now let's look a little bit closer at some of the findings of vascular injury. Vascular injuries are often what are causing the patient's hemodynamic instability, and identifying a vascular injury and classifying the type of vascular injury is critical to determining the next step in management. The 2 main types of vascular injury that we will see are pseudoaneurysms and active extravasation. I've given you 2 examples here of pseudoaneurysm and active extravasation. In one example, we can see this area of arterial opacification within the liver in the setting of blunt abdominal trauma. We see that arterial opacification maintains its shape and remains the same density as the aorta. In this other example, we can again see dense contrast, similar in density to the aorta, around the spleen in a patient who's had blunt abdominal trauma. And notice that as we move through the phases, that density remains quite dense and also expands and even maybe starts to pool. And that is a critical feature differentiating active extravasation from pseudoaneurysm. Let's look at this in a graphical representation. In the arterial phase, we have two patients who have a very similar injury. So this is a graphical representation of the liver, and we have a liver laceration here in the left hemiliver. We also have a laceration in the kidney and a laceration in the spleen. And identifying pseudoaneurysm versus active extravasation will be very similar regardless of which solid organ you are looking at. So in the arterial phase, a pseudoaneurysm versus active extravasation can be difficult to differentiate because they will both show dense contrast opacification similar to the aorta. As we move into the next phase of contrast, the portal venous phase, we now see that the density of the pseudoaneurysm is going to remain similar to that of the aorta. And that's because this is actually still within what we call the blood pool. Blood is flowing into the pseudoaneurysm and out of the pseudoaneurysm. It often is related to an arterial vessel, and therefore its density will often be similar to our best arterial vessel as an internal reference, which is the aorta. So the density will decrease substantially to a similar degree that the aorta decreases. In the case of active extravasation, the density of the area of active extravasation may not decrease to the same degree as the aorta. You think about active extravasation, it is not still contained within a vascular space, and therefore the contrast begins to pool, and it does not wash out as it might in pseudoaneurysm. So the density of active extravasation in the portal venous phase may be slightly greater than that of the aorta. On the delayed phase, we can often really start to differentiate pseudoaneurysms from active extravasation. This delayed phase may be at 2 to 3 minutes. In some institutions, it may be as far out as 5 minutes. On this delayed phase, the pseudoaneurysm will continue to maintain the same size and shape. It will also continue to have similar density to the aorta. Again, this is a contained injury that is contiguous with the vascular space, and so the density of the aorta will often be similar to the density of this contained vascular injury. Active extravasation is not a contained injury. So as the patient continues to bleed, contrast will continue to accumulate in that space. Now, there may be some dilutional effect of bleeding that continues to occur after contrast is cleared out of the aorta, but the area of active extravasation will often remain more dense than the aorta. And you will also get expansion of the abnormality. As bleeding continues, there will be an enlarging abnormality or vascular injury. And that is a key differentiating factor of pseudoaneurysm versus active extravasation. And that can be seen, again, in the liver, the kidney, or the spleen. Another feature that you can see with active extravasation is what I would refer to as pooling. So as the bleeding continues and the contrast continues to accumulate in that injury, you can see contrast that starts to pool or starts to spread in dependent spaces adjacent to the organ of injury. Often you can see that in the perisplenic space, in the perinephric space, under the surface of the left hemiliver, or even in Morrison's pouch with injuries of the right hemiliver. You can also sometimes identify this pooling of contrast within the pericolic gutters or the peritoneal space more generally, indicating hemoperitoneum. In summary, a pseudoaneurysm follows the arterial blood pool. It is a contained vascular space that communicates with the arteries, and therefore its density often reflects the density of contrast within arterial vessels. It should not change shape substantially, again, because it is a contained injury. Active extravasation, on the other hand, will remain dense. So as the contrast begins to be cleared from the aorta will become less dense than the area of active extravasation. There may be some dilutional effect from continued bleeding from the arterial vessel that no longer contains contrast, and that dilution will result in expansion and or pooling of the contrast. But the contrast will still typically be more dense than the aorta. When assessing a patient who's experienced blunt trauma, first assess for hemodynamic stability. If they're unstable, attempt resuscitation. If you can stabilize them after resuscitation, non-operative management tends to have the best outcome. To optimize non-operative management, you will often need a CT And a multi-phase CT is going to provide you the best characterization of vascular injury and the best detection of vascular injuries. If you detect a vascular injury, it's important to differentiate a pseudoaneurysm versus active extravasation, although both of those injuries will typically be treated with angiography and embolization. We're going to talk more about the different grades of blunt organ injury in future parts to this series, but remember that a higher grade does not necessarily mean a higher chance for operative management. It just tends to indicate a greater chance of delayed complications and worse overall outcomes, and may necessitate follow-up imaging. Thank you for your time. I hope you will join us for additional parts in this series on blunt abdominal trauma. In this screencast, we will review blunt liver injury as part 2 to our blunt abdominal trauma series. At the end of this screencast, you should be able to describe the relevance of the liver injury grading system to management and recommend next steps in management based on some key imaging features. The American Association for the Surgery of Trauma, or the AAST, is the most widely accepted grading system. It was initially developed in 1989, but was most recently revised in 2018. Its initial scale was before widespread availability of interventional radiology and the routine use of embolization, and the revisions do reflect the importance of embolization in management. Let's dive right into the scale. There are 2 basic types of injuries that fall within the liver injury scale, one being a hematoma, 2 being a parenchymal laceration. So with grade 1, these are minimal injuries, with the hematoma only occupying about 10% of the surface area of the liver, or the parenchymal laceration only extending 1 centimeter or less into the liver. A grade 2 liver injury, again, can be classified as either a hematoma or a laceration. A hematoma that is subcapsular should occupy less than 50% of the surface area. If there is an interparenchymal hematoma or a contained hematoma within the liver, it must be less than 10 centimeters and show no evidence of active extravasation. A laceration will be grade 2 if it is less than 3 centimeters in depth. A grade 3 liver injury starts to become a more severe injury, where we see the subcapsular hematoma occupying more than 50% of the surface area, or a contained hematoma that's greater than 10 centimeters, or any contained hematoma showing active bleeding or active extravasation. Lacerations that are classified as grade 3 will be greater than 3 centimeters in depth. Note that you can increase the grade of a liver injury if there are multiple injuries. So if you have 2 grade 2 injuries, that will be a grade 3 injury. If you have 3 grade 1 injuries, that could be a grade 3 injury. But you cannot increase the grade or advance the grade beyond grade 3 based on multiple different injuries. Grade 4 lacerations are where we're getting into these very severe injuries where there may not be hematoma, but there is actual disruption of the hepatic tissue or the hepatic parenchyma. So parenchymal disruption, up to 75% of the liver, is going to be a grade 4 injury. And then if you have active bleeding, into the peritoneal cavity. So unlike a grade 3, where you have active bleeding that is contained within the liver, you now have active bleeding that is extending into the peritoneal cavity, causing hemoperitoneum. Finally, a grade 5 injury is where there has been at least 75% of the liver tissue that's been disrupted, or you have a laceration that extends to a major central vein or the vena cava. These are very severe injuries. They often have delayed complications, but they also can be unstable patients that require either angiography or surgery. This grading scale does not correlate with the need for operative management. In the past, almost 80% of patients with blunt liver injury were managed operatively. Now, greater than 80% are managed non-operatively. This scale does correlate nicely with patient outcomes, and in particular, patients who are managed non-operatively will have a greater incidence of delayed complication with a higher grade injury. So let's take a look at a few classic cases. Here we have a 17-year-old woman, unrestrained driver, in a 45-mile-per-hour collision. She comes in with loss of consciousness, and we can see multiple injuries to the liver. So here we have this area of hypoenhancement, or a low-density area within the liver. We have another low-density area within the liver. These may qualify as contained hematomas, but this actually is more of a laceration with an associated hematoma. And notice that when we look at this in coronal and sagittal views, that laceration or hematoma encompasses the right hepatic vein and extends right up to the IVC here. Because of that central venous involvement of the laceration or hematoma extending to the IVC, this is going to be a high-grade lesion. We don't see any active extravasation. This is a grade 5 liver injury. The patient was managed non-operatively and did not require embolization or angiography. They had a stable hemoglobin and hematocrit, they had stable abdominal examinations, and they were actually discharged home without any operative or interventional radiology management. So this is a case of a grade 5 injury due to injury occurring along the central veins of the liver. We have another 17-year-old woman who was in a motor vehicle collision. This time, at least, she was wearing her seatbelt. Also had loss of consciousness. And in this case, we can see extensive injury to the right hemiliver. The injury, this is what we would consider parenchymal disruption. You can see there is poor perfusion and heterogeneity of almost the entire right hemiliver. In addition, this injury extends right up to the intrahepatic IVC and involves both the middle hepatic vein and the right hepatic vein. In this case, we can see the right hepatic vein in the middle of this parenchymal disruption. This is, again, a very high-grade injury with parenchymal disruption and central venous involvement, a shattered or devascularized liver, parenchymal disruption. And again, this was a grade 5 liver laceration. Due to the extent of the parenchymal disruption, this patient was sent to angiography to assess for active extravasation that may not have been detected on the CT, but the angiography was normal. The patient did not require operative management. 1 week after their initial presentation, the patient was re-imaged, and we can now see the disrupted liver parenchyma has started to become more well-defined. We can again see that disruption extends right up to the right hepatic vein and the IVC. And I believe this patient was presenting with a degree of peritonitis and some hyperbilirubinemia and abdominal pain. And this person went to a HIDA scan, and on the HIDA scan, they could see accumulation of the radiotracer within this large area of parenchymal disruption. And so that means that their biliary system has been disrupted and is leaking into this area of parenchymal disruption, resulting in a biloma. The bile was managed non-operatively, so the patient was able to go to ERCP. They were able to cannulate the bile duct. They did demonstrate this large area of contrast accumulation within that biloma, indicating disruption of the biliary tree, and a stent was placed to allow for improved flow, and the patient was again managed without the need for surgery. They did, in addition to stenting the bile duct, go to interventional radiology for percutaneous drainage of the biloma. And here we can see the fluoroscopic CT images of the interventional radiologist placing a pigtail catheter into the biloma. Another interesting case, we have a 22-year-old woman, again, not wearing their seatbelt and becoming unconscious at the scene. In this case, the liver actually looks relatively intact. There certainly is a hematoma here, so a small amount of fluid, perihepatic fluid or perihepatic hematoma. But when we look more closely at the vena cava, the intrahepatic IVC, we see irregularity of the vessels, expansion of the vessel, okay? And this is highly abnormal. And this indicates a central venous injury, likely disruption of the intrahepatic IVC. This patient did require surgery. They continued to be hemodynamically unstable after a period of stability related to aggressive resuscitation. This patient was actually placed on cardiopulmonary bypass, and their central veins were repaired primarily. When we think about the different complications that occur from non-operative management of high-grade liver injury, bile leak and biloma are going to be the most common. A bile leak into the abdominal cavity, meaning an uncontained leak, can result in bile peritonitis, and that can cause abdominal pain, leukocytosis, and hyperbilirubinemia from the resorption of the bile. You can also get hemophilia, where there is a communication between one of the vascular structures in the liver and the biliary tree, and that often results in blood filling up the bile ducts because most of the vascular structures are higher pressure structures than the biliary tree. You can also develop hepatic abscess, where there is superinfection of a hematoma or a region of parenchymal disruption or a biloma. Many of these complications can still be managed non-operatively with ERCP and stenting or percutaneous intervention or embolization, but at times they may require operative management based on the stability of the patient. In summary, it is hemodynamic instability that determines operative management. Most of our vascular and biliary injuries are managed with minimally invasive techniques, and a higher grade correlates with a higher incidence of delayed complications, so consider getting some follow-up imaging in patients with higher grade injuries. Thank you for your time. I hope you enjoyed part 2 of this series on blunt abdominal trauma, and will join us for part 3. In this screencast, we will review blunt splenic injury as part 3 in our series on blunt abdominal trauma. At the end of this screencast, you should be able to describe the relevance of the splenic grading system, differentiate pseudoaneurysm from active extravasation, and recommend next steps in management based on key imaging features. The key decision is non-operative management versus angiography or surgery. Let's look at the AAST splenic organ injury scale, which was revised in 2018. It has grades 1 through 5, and a grade 1 injury can either be related to a hematoma, laceration, or capsular tear. The hematoma should be less than 10% of the surface area of the spleen, and the laceration should be less than 1 centimeter in depth. The capsular tear should be a minimal injury to the surface of the spleen. A grade 2 injury, again, can be a hematoma, and in this case, the hematoma should occupy less than 50% of the surface area. You can have an interparenchymal hematoma, similar to what we described in the liver, but in this case, the hematoma must be less than 5 centimeters, where in the liver it's less than 10 centimeters to qualify as a grade 2 laceration. Similar to the liver grading scale, a laceration of the spleen that's less than 3 centimeters in depth will be classified as grade 2. Grade 3 injuries are going to be, again, similar to that liver grading scale, in this case greater than 50% of the surface area of the spleen, a hematoma that is greater than 5 centimeters in diameter but shows no evidence of active extravasation or pseudoaneurysm, or a laceration greater than 3 centimeters in depth. A grade 4 splenic injury is a severe injury that often requires some form of intervention. In this case, any vascular injury or active bleeding that is contained within the spleen is going to be considered a grade 4 injury. So that could be a pseudoaneurysm, a focus of active extravasation, or an arteriovenous fistula, which is very difficult to differentiate from a pseudoaneurysm on CT. You could also have a large laceration that causes devascularization of a portion of the spleen or central hilar vessel or segmental vessel involvement. These grade 4 injuries are often going to require some form of intervention, preferably angiography, but if a patient is not hemodynamically stable after aggressive resuscitation, operative management may be required. Grade 5 injury is the most severe form of injury. In this case, any form of bleeding from a vascular injury that extends into the peritoneal cavity, so intraperitoneal hemorrhage, is going to be considered a grade 5 injury and will often require angiography or surgery, depending on the stability of the patient. Another type of grade 5 injury is a shattered spleen, in which there is devascularization and multiple regions of laceration that extend throughout the spleen. Again, this can oftentimes be treated with angiography if the patient is hemodynamically stable, but if after resuscitation the patient cannot maintain stability, surgery may be required. Now let's look at a few cases of splenic injury. Here we have a small 2-centimeter laceration of the spleen. On arterial phase, we can see associated with that laceration a small focus of dense contrast in the region of that laceration that is similar in density to the aorta. On the portal venous phase, we can see that region of contrast has expanded or changed its size and shape. That is our first indication that this could be a region of active extravasation. It also, in this case, is closely mimicking the aorta, but will often maintain more density than the aorta. On the delayed phase, we can see that that region continues to enlarge and maintain some foci that are more dense than the aorta, and this is consistent with active extravasation from a small laceration. So even though the laceration was 2 centimeters, the active extravasation into the peritoneal cavity results in a grade 5 injury. This particular injury was treated with embolization as the patient was stable after resuscitation. Here we have another example of a splenic injury. This was a woman who's riding a motorcycle, and in this case we see a laceration here through the spleen. We see a splenic hematoma, but in addition we have this focus of high density in the spleen. This is consistent with a vascular injury, and we now would like to further classify that vascular injury as either a pseudoaneurysm or active extravasation. In this case, on the portal venous phase, we can see that the vascular injury closely parallels the aorta in density. On the delayed phase, there is also density very similar to the aorta, albeit maybe slightly more dense. Again, on the portal venous phase, we see this well-defined area. Okay? And on the delayed phase, notice that we don't see this area change shape. We also do not see any pooling in the perisplenic space of the peritoneal cavity. In this instance, we can classify this as a pseudoaneurysm of the spleen. It is contained within the splenic tissue. It does not show any intraperitoneal bleed, and therefore it is a grade 4 splenic injury. This grade 4 splenic injury did require operative management. That is because the patient was hemodynamically unstable. So even though we did not see any active extravasation in the peritoneal cavity, the inability to maintain the patient's blood pressure despite aggressive resuscitation resulted in an emergent laparotomy and a splenectomy. Ideally, if this patient could have been hemodynamically stable after resuscitation, this pseudoaneurysm could have been treated with embolization. So we have two different instances. One, a grade 5 injury treated with embolization because the patient was stable. Another instance of a grade 4 injury that was treated with surgery because of patient instability. Another case, we have an unrestrained driver in a motor vehicle collision. On the arterial phase, we see multiple foci of high density along the inferior pole of the spleen. We also see quite a bit of fluid within the peritoneal space around the spleen. On the portal venous phase, those areas of density become more prominent, possibly due to slight enlargement of those areas. On the delayed, we see those regions become diluted and are not quite as prominent, but are more amorphous than they were on these prior phases. This was felt to represent active extravasation, and we may even see a little bit of pooling in the perisplenic space. This person was taken to angiography. On the angiography, they did detect some active extravasation from the lower pole of the spleen, and this was treated with coil embolization. Here we have another case of splenic injury, in this case, a 26-year-old who fell into a toolbox in his pickup truck bed. Unlike the other cases, we had a non-contrast image in this patient that showed a large hematoma with some mixed density along the spleen. This covers more than 50% of the splenic surface and is therefore at least a grade 3 injury. On the portal venous phase, we see this region of linear, sort of ill-defined hyperdensity consistent with contrast along the splenic capsule. We also can see that the hematoma appears to have gotten larger. And on the delayed phase, we again see that linear density along the capsule, but an area that has actually increased in size and density on the delayed, with additional increase in the size of the perisplenic hematoma. Because of the changing in the size and the persistent density of this abnormality, this is more consistent with active extravasation into the peritoneal space. This is a grade 5 injury of the spleen due to active extravasation into the peritoneal cavity. The patient did go to angiography, and no active extravasation was evident despite the CT imaging findings. The patient was prophylactically embolized with gel foam, at times with expanding hematomas or appropriate patient positioning. There can be tamponade of active extravasation, and that can impact the diagnostic sensitivity of angiography. But to ensure that active extravasation does not restart with patient positioning or movement, or in the future, gel foam embolization can reduce the risk of rebleeding. In summary, the revised AAST scale really focuses on vascular injury. Grade 1, 2, and 3 splenic injuries are almost always managed non-operatively. Grade 4 injuries are severe injuries, often with some form of vascular injury, but that vascular injury is contained within the spleen. Grade 5 injuries are either a shattered spleen, which is completely devascularized, or a spleen that has some vascular injury with bleeding into the peritoneal cavity. Again, management is not dependent on the grade, but is dependent on the patient's hemodynamic status. Patients will go to the operating room for a splenectomy if they cannot be stabilized, but ideally they could go to interventional radiology for embolization. Thank you for your time. I hope you've enjoyed part 3 of this series on blunt abdominal trauma, and I hope you join us for part 4 on renal injuries. In this screencast, we will discuss blunt renal injury as part 4 in our series on blunt abdominal trauma. At the end of this screencast, you should be able to describe the relevance of particular renal injuries to the grading system. You should be able to describe key features to diagnosing collecting system injury and understand some of the next steps in management based on imaging features. The key decision often comes down to non-operative or non-interventional management, so conservative management, versus using some form of angiography to treat bleeding or stenting to treat a collecting system injury, versus having to go to surgery, which often results in a nephrectomy in the case of blunt renal trauma. The renal trauma grading scale, like the other grading scales we've discussed, was revised in 2018. Grades 1 through 3 tend to require no intervention. These are subcapsular hematomas or contusions or small lacerations without injury to the collecting system. Grade 4 injuries are often going to require some form of angiography to stop bleeding, or may require some intervention within the urinary tract to address a collecting system injury. Grade 5 injuries tend to be extremely traumatic injuries that are causing substantial vascular damage or large volume bleeding and are often going to require angiography or surgery. So let's look at these. Grade 1 tend to be small contusions or subcapsular hematomas. Grade 2 lesions can be larger hematomas or lacerations less than 1 centimeter. Grade 3 are lacerations that are greater than 1 centimeter but do not involve the collecting system. Grade 4 are deeper lacerations, often involving the collecting system, resulting in urinary leak, and can involve small vessels. Grade 5 injuries tend to be devascularizing injuries where there is injury to a large artery or vein or a shattered kidney. So let's look at a few examples of renal injury. In this case, there was a groom working with a horse. The horse kicked the broom hit the groom, and he came in with bruising to the right abdomen. We can see in this instance, when we look at the right kidney, okay, we can see a hematoma here along the kidney. But in addition to the hematoma, we can actually see these 2 clefts in the renal parenchyma. And those are both consistent with grade 3 lacerations. We can also confirm at least a grade 3 laceration extending into the renal hilum. Because there is extension into the renal hilum, there is risk for collecting system injury in this case. So this is at least a grade 3 laceration. In order to further evaluate the integrity of the collecting system, a CT urogram was done. Now, if you had identified these lacerations while the patient was still on the CT table, we could have done a 10 or 15 minute delayed scan, and that would have served the same purpose as the CT urogram. But this person came off the CT table. The laceration was then seen to extend into the hilum. So they were sent back for a CT urogram to assess the integrity of the collecting system. In this case, we see a very small amount of hyperdense contrast along the renal capsule on the urographic phase. So notice the collecting system is now filled with contrast because this is a delayed phase where the kidney is already excreting contrast into the collecting system. And we see this area of hyperdensity along the capsule. And that's consistent with leak from the collecting system. So while this looked like a grade 3 laceration on the initial study, it was actually a grade 4 laceration. Now, this was a small amount of leak. And because it was a small leak, urology opted not to place a stent to decompress the collecting system, but instead manage this conservatively. The patient did, however, have persistent hematuria. Due to the persistent hematuria, there was concern for communication of the collecting system with a vascular structure, and we got a CTA. The CTA showed a pseudoaneurysm within the lower pole of the kidney. It's possible that the pseudoaneurysm also was leaking blood into the collecting system, and that may have accounted for the persistent hematuria. This person was taken to angiography, which confirmed a pseudoaneurysm, which was treated with coil embolization. Now let's take a look at another case example. In this instance, the patient was in a motor vehicle collision. We can see a perinephric hematoma along the kidney, but in addition to that perinephric hematoma, we can see a large laceration that's resulting in separation of the upper and lower poles of the kidney. In this case, the degree of injury was noticed on the initial CT, and the patient remained on the CT scanner table for a delayed phase, somewhere between 10 and 15 minutes. On this delayed phase, we can again, like on the CT urogram, see contrast within the collecting systems, but in addition to the contrast in the collecting system, we can see multiple areas of hyperdensity outside the expected collecting system. This again is consistent with a collecting system injury. In this case, again, a Foley catheter was placed to decompress the bladder, but there was no stent placed into the ureter. There is some thought that these collecting system injuries can heal without stenting, and that stenting may cause additional disruption to the collecting system, although at times a stent is placed at the discretion of the urologist. Again, this delayed phase is going to serve a similar purpose to the CT urogram in the patient we saw before. Lastly, we have a 21-year-old man who was chased by police on a motorcycle and wrecked at high speed. When he presented for his CT, we got a multi-phase CT, and on the arterial phase, we can see the left kidney and the spleen show no enhancement. We do, however, see a very small area of hyperdensity on the arterial phase in the region of the spleen, and that hyperdensity greatly increases around the spleen and the kidney by the delayed phase. There may also be a small hematocrit level in the dependent portions of the perinephric space. All of this suggests active extravasation with devascularization of the kidneys and is therefore a grade 5 renal injury with devascularization of the kidney and spleen. This patient was hemodynamically unstable after resuscitation and therefore went emergently to the operating room. And at exploratory laparotomy, they performed a nephrectomy and splenectomy due to devascularization of both organs and active extravasation. In summary, grade 1 to 3 injuries are often non-operative. Grade 4 injuries can be managed conservatively, but are more likely to need angiography to address bleeding or stenting to address collecting system injury. Grade 5 renal injuries are often going to require some form of angiography or surgery. One of the pitfalls of surgery for blunt renal injuries is that there is a very high rate of nephrectomy. So if possible, it is often preferred to not go to surgery, manage with angiography or stenting, and see if any of the kidney remains viable. If the patient is unstable, surgery may be required, and again, a nephrectomy will often be the result. Thank you for your attention. I hope you've enjoyed this series on blunt abdominal trauma.
Hi, this is Elliot Fishman. Welcome to our latest vodcast, and this one's going to be on abdominal trauma. And trauma is an important topic. It's something all of us do in practice, just by the numbers. I sound like the news radio, but 100,000 deaths annually by trauma, and as leading cause of death in the 1 to 44-year-old age group. Blunt trauma accounts for about 70% of trauma cases, and 2/3 of these are related to motor vehicle accidents. It's a $300 billion cost in the U.S. each year. Now, as CT has changed, so has how we use CT in terms of the trauma patient. Now, remember the old articles, initially Mike Federle, Brooke Jeffrey, showing how good CT was in the trauma setting and how important it was, and how staging of things like liver and spleen and renal injuries became much more conservative with the development of these new technologies. Now, with the very fast scanners, we talk about a pan scan, imaging the chest, neck, head, abdomen, pelvis, in one fell swoop in the trauma patient, and a good article by Soto made that point. Now, when you make protocols, and protocols are so important for everything we do, and especially in this case of trauma, it's so very important to look at the things we do. So, for example, what are we scanning? Are we scanning a chest only or abdomen only, or are we scanning very long, extended ranges? What's the type of injury? Was it an MVA, or was it a gunshot wound? Did someone fall off a ladder? The type of injury you have will often dictate what the likely injuries are, and so we'll really design our protocol to match that. Also, you have to be practical. What type of scanner do you have? Is it an 8 slice, 16, 64? Is it a dual source? Scanner speed and coverage become very critical. And again, what has been seen in other imaging studies, and what is the clinical suspicion? Now, in designing protocols, we typically do not use positive oral contrast. If we can, we give water. We love to use IV contrast, and in most cases, we will use IV contrast. Depending on the injury, we might use rectal and bladder contrast as well. Gunshot wounds to the pelvis, trauma to the pelvis where there are pelvic fractures. Then you're thinking about bladder injury, you need CT cystogram. Gunshot wound to the pelvis, perhaps it's near the rectum, or anywhere in the abdomen. It can be near the colon, and so then you want to exclude that possibility. When we look at protocols, we talk about parameters from KVP to MAS, we talk about delay, we talk about the need for single or multiple phases, as in with any application. We talk about contrast volume and injection rate, and the importance of post-processing. Recent article by Dresden, with a single continuous acquisition, whole body CTA is able to demonstrate all potentially injured organs, as well as vascular and bone structures from the circle of Willis to the symphysis pubis. So you can see very large areas are scanned, and in this article they talk about how valuable it is, the whole body CT angiography. By scanning this large volume, you don't miss specific injuries, you don't overlook injuries, and you're really doing a very large volume scan. And again, it's somewhat controversial, but their feeling is it is the ideal thing to do. Acquisition of subisotropic voxels confers equivalent resolution in any plane and provides many opportunities for maximizing efficiency for injuries in patients with blunt polytrauma, necessitating a move away from over-reliance on axial images. Thus, the use of coronal and sagittal should no longer be considered complementary. And you see, one of the things they talk about that we've often speak about as well is the fact you have to use imaging beyond the axial plane. If you're scanning in a volume, you need to review things in the volume. Now, if you're curious as to their protocol, they do an unenhanced brain CT, and then they do a scan from the circle of Willis to the symphysis pubis, and here's their protocol. And that's on a 64-slice scanner. Obviously, if you have a flash, you can do a pitch of 3, which would make the study substantially faster, and you can cover literally through the lower extremities. Now, in terms of the specific protocol, they do a scan delay at 20 seconds for patients under 55 and 25 seconds for those over 55. There's a biphasic injection, and depending on the situation, they will typically not be doing delayed scans. Arms above the head in all cases, so they have a very, very defined protocol. We also have a defined protocol at Hopkins. In our new ER, we have a flash scanner. So we're doing thick and thin sections, and we're doing the reconstructions and doing 3D post-processing, as well as coronal and sagittal, routinely in cases. Now, in speaking about trauma, if I want to cover the entire spectrum of trauma, we'd have a series of 10 or 20 lectures. But I'm going to cover some, what I would say are hot topics, things that have been written about recently, things that I want to review with you that you should know. So let's first look at the adrenals. The first thing you see in this case is very bright adrenals. In the trauma setting, when you see bright adrenals, you better think the patient is possibly hypotensive. You can see the adrenals here, or you can see the adrenals in this patient who's a child with a large abdominal wall injury. Yes, adrenals can enhance, but when they're super bright, you better be thinking about hyperperfusion. When you have trauma besides the adrenals being super bright, this whole hypovolemic shock syndrome, you talk about changes in perfusion, you'll get a dense, intense pancreas and adrenal and small bowel. You may see poor perfusion of major organs like the liver, spleen, and kidneys, for example. So in that category, we talk about bright adrenals, dilated small bowel fluid filled either with hypo or hyperenhancement, typically hyperenhancement of the gallbladder, reduced splenic perfusion, intense persistent enhancement of the kidneys, and peripancreatic edema. So another example, peripancreatic edema, there's free fluid representing blood in the abdomen, and then very bright adrenals in this complicated case in this patient with chest trauma as well. There's a hydropneumothorax on the right, for example, but again, very, very bright adrenals. So that is a terrific sign. Once in a while, fast injections, the adrenals can enhance, but they don't enhance to this level. Other things you look for in this case, flat IVC, and the perfusion changes in other organs. Now, another thing with adrenal we want to talk about in the trauma setting is hemorrhage. Now, the most common cause of hemorrhage usually is Coumadin, but there are many other causes from tumors to infection. But trauma also is one of the causes. Now, typically what you'll see is a high attenuation adrenal gland that typically is oval. In trauma settings, most of the time it's unilateral, but occasionally it can be bilateral. And in the trauma setting, the bilateral is associated with Addison's syndrome, and so those patients need replacement hormonal therapy. Article by Sasserat, adrenal hemorrhage is rarely suspected clinically, exhibits no specific clinical symptoms or lab findings, and yet is immediately life-threatening when bilateral. Recognition of adrenal hematomas is complicated by the variable appearance of these lesions. So you can see round and oval and high density in this patient with liver trauma and resection. Article by Coe, traumatic adrenal injury occurs in 5% of trauma cases, most commonly affects right adrenal. While rare, adrenal injury is an indicator of severe trauma and should prompt a search for associated injuries. Again, something to think about. Now, as I mentioned, the appearance of the adrenals in trauma typically oval or round, but it can be a regular hemorrhage which obliterates the gland with lots of blood in the bed of the gland. You can see uniform adrenal gland swelling with increased attenuation. You can see periadrenal hemorrhage or stranding. You can see a large retroperitoneal hemorrhage around the gland, and you in fact do not see the gland. Or you can even see more long-term is an adrenal cyst or more likely a pseudocyst. So again, look at the adrenals in every trauma case. You may see injury to the adrenal, or it may give you a hint that this patient is about to do very poorly. Okay, let's move on then to the spleen. Splenic size is very variable. Top normal, we usually talk about 13 centimeters. Variations in the spleen are common. Accessory spleens, lobulations. Lobulations can be confused with lacerations or infarcts. Accessory spleens can be confused with masses in the pancreas or near the pancreas. Those are all definite possibilities. In terms of the spleen, in terms of density, the spleen typically is 10 Hounsfield units less than the liver on non-contrast scans. The issue you want to be very careful about is when you're doing very fast injections, which is common in the trauma setting, the spleen can have this moire pattern of enhancement due to the variable circulatory routes through the spleen. And you can see the schematic very nicely shown here. And in real life, when you look at it, you tend to see a serpentine cord-like enhancement, most common. It's more pronounced with fast injection rates and early scanning. It's accentuated in a patient with decreased cardiac output, splenic vein occlusion, or portal hypertension. Now, very important to recognize, if you look at this case and you're not certain, and you say, could this be a laceration? Is there possibly a laceration? Well, one thing to think about, you don't see any blood near the spleen, but you can still have a laceration. Just go back in 30 seconds and look how normal the spleen looks, okay? Another case, 30 seconds apart. So it is of some concern sometimes, but but it's only typically a problem when you're doing early scanning. When you're scanning a bit later, it's not going to be a problem. Other things in terms of the spleen, we know the splenic artery is very variable in terms of number and its course, but easy to recognize, particularly if you do 3D maps. MIPS works very nicely. Here you can see a small calcification on the splenic artery, but very nice definition. Here, similarly, you can see the splenic vein in this patient. Splenic veins are usually best seen in about 60 to 70 seconds post-injection. But again, nicely showing you how timing will allow us to see either splenic artery or splenic vein. Now, when you have trauma, the appearances become somewhat classic. You can see active bleeding, as you can see here, multiple sites of active bleeding, and this patient has had significant injury, and this spleen subsequently ruptured. But again, very nice example. There's some blood near the spleen, but there's blood in the pelvis. The site of blood in the pelvis, even minimal, you really have to be looking for what you missed. If you don't see liver, spleen, kidney, then you better be thinking about bowel injury. Now, when I mention trauma, we also want to mention, at least touch on the pregnant patient, and that's always a topic of interest when it comes down to CT. People will argue, what should you do in the appendicitis? What should you do with the pregnant patient in PE? But no one argues in terms of trauma. Patient had an MVA, high suspicion for injury. There's the placenta. No one is going to worry about radiation dose, because when all is said and done, it's the mother that's most critical. So if you're thinking that the patient has a substantial injury and you need a CT, not just doing a CT on everybody, well, then you want to do it correctly, and make certain, as in this case, there's no vascular injury and no significant trauma. Good article by Sadro, when there's concern for maternal injury. CT is the mainstay. The risks of radiation to the pregnancy is small compared to the risks of miss or delayed diagnosis of trauma. Okay, so very, very important to really recognize that. Trauma is the leading cause of maternal deaths, non-OB causes of maternal deaths, and that indeed is very, very important to recognize, that you really need to, when you're in doubt, just do the study. That indeed becomes very, very important. Causes of trauma in pregnancy are most commonly MVAs, falls, and assaults. Okay, those are the big ones. Sadro also makes note certain injuries in pregnancy are associated with increased risk of fetal loss. Pelvic and acetabular fractures occurring in pregnancy are associated with high maternal and a higher fetal mortality, increasing to 75% for severe fracture patterns. Now, so that's one thing. Patients pregnant, just do the study. It's a question that commonly comes up. Do not waste time. You do not want this patient to do poorly. Now, what else? Let's look at the pelvis. One thing I mentioned and always mention when you're speaking about looking at the abdomen or pelvis, we talk about protocols and the key to really think about what you will need. So depending on the patient's injury, you might think about a bladder injury. You might think about a colon injury. Well, in that case, give the CT cystogram, put contrast in the bladder, or put contrast in the rectum, depending on the scenario. Depending on what the injury is, because only scan the patient one time. There's no need to scan the patient 2 times. So with trauma, blunt trauma is the most common. Penetrating iatrogenic are the next 2. GU trauma occurs in 5 to 10% of all patients with trauma. Bladder injury occurs in about 1.6%. Bladder rupture in about 2 to 11% of patients with pelvic trauma. The majority of patients with pelvic injury, with bladder injury, have pelvic fractures, often significant fractures. And that's one of the reasons, if you have complex pelvic fractures, you really should always get a CT cystogram. If you wait to do the delayed bladder imaging, the bladder will fill, but the bladder is not distended, and injuries are very easy to miss. Some facts about bladder trauma: up to 80% of cases are extraperitoneal, 20% are intraperitoneal, and 5 to 10% are combined. Bladder trauma, we mentioned blunt trauma is the most common. Penetrating iatrogenic are all things that we do tend to really think more about. And then when you put the bladder trauma into categories, you end up with contusion, you end up with intraperitoneal, and intraperitoneal is the one that goes to surgery. You talk about bowel wall hematomas, extraperitoneal spread, and combined. Okay? So intraperitoneal up to 20%. Delayed diagnosis results in increased mortality due to the risk of peritonitis, and these patients require surgical management. A statement by Ishak, MD-CT cystography is becoming the study of choice for evaluation of bladder for suspected trauma, and it's becoming the study of choice for many different applications that do involve the bladder. And in terms of choosing when to do it, Ishak makes the point when there's pelvic fluid present, when there are fractures or gross hematuria, you should just do the CT cystogram as part of the regular CT scan. And it looks very nicely. There's the bladder. If there was bladder injury, you would see it very nicely. Here's another patient. Here we had a wound to the chest. You can see blood in the pleural space as well as in the lung parenchyma. And when you scan the pelvis, you can see there's a small chip off the superior pubic ramus on the left. There's associated hematoma, pelvic sidewall. These are the things you have to worry about. And now you give rectal contrast, and everything looks sort of good. There's that little bit of contrast extravasation anteriorly, but it is to that small collection that was known. But you can see it nevertheless. And you can see multiple different views. And then, of course, on delayed phase imaging, the communication is still present. So you can very nicely suspect the possibility of bladder injury and do the CT cystogram. The worst case is a CT cystogram is negative. What you don't want to do is bring the patient back a second time. That would be most impractical and would also increase the dose to the patient. We only scan the one time, so the dose is much lower. Now, another thing about pelvic fractures we commented with bladder injury is the ones that are more extensive, more likely to have bladder injury. So here's a comminuted fracture, involves the sacrum and acetabulum on the left. You do a CT cystogram, you can see contrast extravasation. You can follow it upward, and this contrast extravasation is in the retroperitoneal space. Very, very nicely to show there. Another case, there's a mass in the bladder, and here it is against the positive contrast. And this was a large hematoma. So again, bleeding is not always the same as organ injury, but or rupture to be exact. But in this case, very nice bleed, but there's no evidence of bladder rupture. Now, stab wounds and gunshot wounds really create havoc in the pelvis. Here's a good example of a gunshot wound in the perineum, perirectal. There was no rectal injury, and in fact, there was no bladder injury. The bladder looks very nice on these images, very nicely shown there and there. You can see in this case, what about the bladder here? Another case of gunshot. You can see the pelvis, the bladder, everything's filled. We scan upward, the few small nodes. You can see that the bladder is intact, despite the fact the patient got this pelvic injury. And here it is very nicely shown. You see the tube in the patient's rectum, best seen on sagittal view. So now you see the intact rectum, you see that the bladder's intact, you see the kidneys are intact, and the ureters are intact. Okay? Other things looking at the pelvis, pelvic hematomas can be within muscle, subcutaneous tissues like this case, or this incredible example. We were looking for a site of bleeding. You can see the hematoma on the left, but look at the early appearance of the IVC. This is an AV fistula from the superficial femoral vein to the artery. So a very nice communication, and you can see the blood pouring in from the arterial to the venous side, giving this very flash acquisition, very nicely shown in this image and in this set of images. When I speak about vascular injuries in the pelvis, and this is the last thing I'll talk about, and then we'll take a break, we talk about all sorts of different injuries, from extravasation to occlusion to pseudoaneurysms. And I think we'll do is, the time is getting short, why don't we just take a break there, and then we will be right back in a few minutes to start again. Thank you very much. Hi, this is Elliot Fishman, and welcome back to part 2 of CT imaging of select topics in trauma. And I left off last time mentioning vascular injuries, and I think one of the big gains with CT in general, with CT angiography and 3D imaging, is the ability to look at vascular injuries, and that's literally from head to toe. When we look at the pelvis, we're talking about active arterial extravasation, we talk about vessel occlusion, we talk about intimal injury, we talk about pseudoaneurysms, dissections, AV fistula, and venous injury. So there's really a very wide spectrum of possibilities that indeed we can see. I showed you this case at the very end of the last talk. The patient has a large hematoma in the upper aspect of the right groin, and you can see it's very dense, very high density. It's consistent with a bleed. But what's most impressive in this case, when you looked at the images, was that the patient has early filling more superiorly of the iliac vein and femoral vein up into the IVC, and you can see very nicely the superficial femoral artery upward. And what you're seeing in this case is you're seeing actually communication between the artery and vein, a classic AV fistula, beautifully seen. And you can see when you get to the right level, look at the axial images, compare the right side and left side. On the left side, you do not see opacification of the vein. On the right side, you do. There's early filling, and also the veins dilated. Just a beautiful example of an AV fistula, and hopefully you can really appreciate it on these images. Therefore, when you look at this list, you really need to be thinking about all of the possibilities. And so timing is critical. Arterial phase imaging is critical. Occasionally, we will go back and get delayed phase imaging. As I mentioned previously, and some of the other different articles have shown, 2D and 3D mapping is critical. Now, in looking at pelvic trauma, an article by Aida said application of MDCT technique, specifically 64 slice, to pelvic CTA is useful in evaluating for potential vascular injuries and may be integrated into admission trauma imaging in order to triage patients with blunt pelvic trauma, and its utility in detecting and characterizing vascular injuries, including arterial and venous hemorrhage. Now, what's important about this article, and no great surprise, is this point about triaging. The comments I've made before. Think in advance. You know the injury. It's a gunshot wound, it's a stab wound. You're going to worry about vessels. Just do the CTA from the get-go. We want to decrease radiation dose. These are often younger patients. Well, just design the protocol correctly. Curtiz makes the point. Pelvic CTA has significant clinical utility in the evaluation of patients with blunt pelvic trauma. The ability to characterize arterial injuries and to differentiate arterial from venous injuries is important for ensuring appropriate and timely treatment. So again, you can see it's a very critical component of what we do. It's an ever-expanding area. Dual energy CT can be used in this area. A good article by Fritz from Hopkins on this topic is coming out in Radiographics, but very important to be able to look very carefully at the vessels, and dual energy with automated bone removal may speed up the process. Now, another area that's very important in looking at trauma is bowel. And bowel and mesenteric trauma is indeed one of the really good things that CT can do, but it's also one of the most challenging. First of all, only a small percent, less than 5% of patients with severe abdominal trauma actually do have bowel injuries. The problem is, if you don't make the diagnosis early, the rate of morbidity and mortality from peritonitis and sepsis increases very quickly in as short as 8 to 12 hours. The small bowel is involved in over half the cases, with proximal jejunum and distal ileum most commonly involved. A number of different articles. This article by Brofman making the point that bowel and mesenteric injuries are detected in 5% of blunt abdominal trauma, and are the third most common type of injury from blunt trauma to the abdominal organs. He speaks about three basic mechanisms that may cause trauma and mesenteric injuries. Direct force may crush the GI tract. Rapid deceleration may produce shearing forces between fixed and mobile portions of the GI tract, and a sudden increase in intraluminal pressure may result in bursting injuries. So three would sound like very impressive injuries, and he also comments that CT has been shown to be accurate for the diagnosis of bowel and mesenteric injuries and as a test of choice in the evaluation of blunt abdominal trauma in the hemodynamically stable patient. Specific findings of bowel and mesenteric injuries include bowel wall defect, intraperitoneal and mesenteric air, intraperitoneal extraluminal contrast material, extravasation of contrast from mesenteric vessels, and evidence of bowel infarct. So those are a lot of good findings. I will tell you they're often a challenge. Any free air is critical. Any fluid near bowel is critical. So you need to be very, very careful, particularly in the areas that are most commonly involved, which are the proximal jejunum near the ligament of Treitz and the distal ileum near the ileocecal valve. And that's because in these regions, mobile and fixed portions of the gut are continuous and therefore are most susceptible to the shearing forces. So again, think about that near the ligament of Treitz and terminal ileum. Now, what can you see? There are many different findings in bowel and mesenteric trauma. You can see transection of the bowel with focal discontinuity. That's pretty uncommon. You can see extraluminal oral contrast material. We typically are giving water as a contrast agent or nothing, so that's not going to help much. Pneumoperitoneum is a good sign of something going on, but not very specific. Hematoma in bowel wall and mesentery can be very valuable. Peritoneal extravasation of IV contrast enhanced blood. You can see the site and location of bleeding, and bowel wall thickening with or without abnormal enhancement is very important. We're looking for changes in the bowel, whether it's increased or decreased enhancement, whether it's mass effect, anything changing the bowel pattern. You can see pneumoperitoneum, but I do like always to mention that there are many causes beyond bowel perforation for pneumoperitoneum in the trauma patient. Intraperitoneal rupture of the bladder with the Foley catheter, massive pneumothorax, barotrauma, peritoneal lavage of benign pneumoperitoneum. So you want to be careful. You really want to be thinking about bowel perforation, but it's not pathognomonic. Now, we mentioned bowel wall trauma. Focal bowel wall thickening, especially when associated with fluid in the adjacent mesentery, is an important finding in trauma. You also may see diffuse wall thickening, but that may be due to a hypoperfusion state rather than to any direct bowel injury, the so-called findings in shock bowel. Remember, we spoke about the adrenal gland, we spoke about the kidneys, spoke about the pancreas. And mesenteric injuries can occur without bowel injury and can include active bleeding or injury to the mesenteric vessels. And this is common in injuries with rapid acceleration and deceleration. So let's look at a couple examples. Here's a wonderful example. Look at the duodenum from the second portion through the fourth portion into the proximal jejunum. You see how dilated it is? There's something in the wall. Look at these images, both on the axial and coronal. This patient has a large hematoma in the wall of the duodenum. It's a very common location. It causes mass effect. It can simulate a tumor, but also it is one of the causes of bowel obstruction. It's important to recognize. These patients are often treated conservatively. Sometimes this patient will need surgery. Very, very nice example. And you can see the obstructive processes. You can imagine this patient needs an NG tube. The patient's going to have gastric outlet obstruction because of this hematoma within the wall of the small bowel. Sometimes these lesions are very focal. Sometimes they are extensive, as in this case. So just a beautiful example of intramural hematoma of the duodenum. Now, another area I wanted to touch on in the pancreas is pancreatic trauma. And pancreatic trauma is something, again, we tend to not think about all that commonly. It doesn't happen as frequently as one would expect. And when it does happen, the neck and body are the most common sites of injury. You can classify injuries as contusion, laceration, or transection, with contusion being the most common. Injury to the pancreatic duct is what's associated with the most severe injuries. Article by Soto. The injured pancreas may appear normal on CT images, particularly in the first 12 hours post-injury. If the admission CT shows a normal pancreas but pain develops subsequently, even up to 48 hours, you might consider doing another CT to look for pancreatic injury. So pancreatic injury is very hard, particularly small lacerations. Now, sometimes you see more impressive injuries like a pseudocyst. In this case, post-trauma, well, that's easy. You see, as you look at these images, there's a pseudocyst, there's dilatation of the pancreatic duct. You can go through a differential diagnosis of pancreatic cystic lesions, but in the post-trauma patient, a pseudocyst post-trauma is indeed a very nice diagnosis. Now, I mentioned also things like bleeding and relationship to bowel before. Often it's associated in patients who do get injuries to the pancreas as well. Pancreas and bowel injuries tend to go hand in hand. Here's a great example of a patient who had suspected pancreatic injury, elevated amylase, but look in the pelvis. Look at that large active bleed present. There are tears of vessels at a sigmoid colon with active bleed present. Just a beautiful example showing you the extent of bleed in the pelvis. And then here it is on the 3D map. So just a very nice example of active extravasation. This is the importance, again, of CT angiography that allows you to pick up this, and here's just a couple more images making the point. So you can see that we look at a combination of things. What's very important in terms of injury is to recognize that if you see one injury, you see bowel injury, that's great, but you better look harder. Maybe there's liver and spleen. Maybe there's pancreas. You got to keep looking. Now, in terms of bowel injury, typically we think about small bowel, but you also can think about large bowel. This is a patient who was shot, and you can see the active bleed in the patient's rectum. So again, it's uncommon, but active bleeding, the role of IV contrast, the fast acquisitions are indeed critical in that application as well. So hopefully I've showed you, as this quote from before, MDCT offers unprecedented imaging capabilities that can be readily applied for optimal evaluation of the polytrauma patient. However, to maximize the diagnostic potential, you really have to optimize the exam protocols for each patient, but also within your center. You need to know how you're going to handle the data, when you're doing single energy, when you're doing dual energy, who's going to process the data, when's it going to be read, and these decisions often need to be made very quickly, so you need to have basic pathways in place. So with that, I'll stop there, and thank you for your attention, and see you next time.
Hi, welcome to Imaging of Liver and Spleen Blunt Trauma. This is a case-based review. I have no relevant financial disclosures. And so our learning objectives for this session are to be able to identify liver and spleen traumatic injuries, to recommend appropriate best imaging tests and protocols, know the types of contrast to use or avoid, and know when to recommend IR. In abdominal trauma, high-velocity mechanisms can occur that result in multisystem injuries. Blunt trauma occurs much, much more frequently than penetrating. The liver and spleen are by far the most commonly injured organs. Most injuries are non-operatively managed, and imaging plays a key role. The chest and pelvis x-rays are taken during trauma resuscitation, and these are used to detect severe injuries like tension pneumothorax or pelvic fractures. It's important to note that the sensitivity for detecting traumatic injuries is not great by radiographs. So you'll have a certain number of false negatives, and so that means that negative does not exclude injury. Ultrasound, the EFAST exam is used to detect free abdominal fluid. This is usually performed by the trauma surgeon or emergency medicine physician. And again, limited sensitivity and limited utility for detecting abdominal injuries. MRI takes a long time. There are obvious magnetic field hazards, which aren't good for a patient who's got lots of life support equipment hooked up. And so MRI is not good for potentially unstable patients. And MRI is really a problem-solving tool, not a screening modality. So MDCT is our gold standard imaging test for abdominal trauma. The sensitivities for detecting abdominal injuries approaches 100%. IV contrast is really required if you want to pick up as many injuries as possible. And one contrast bolus can provide rapid multi-phase imaging that can be reformatted easily and quickly to best depict injuries. All right, so let's turn to the liver, and this is where the case-based portion starts. So our first case is a high-speed MVC, and you can see that there are multiple linear, low attenuation areas cutting through the right hepatic lobe, consistent with extensive lacerations. Some of these extend to the middle hepatic vein. So here's the middle hepatic vein, and you can see these lacerations go right up against it. Here's the main portal vein, anterior branch of the right portal vein, and periportal low attenuation, which is likely periportal edema from the fluid resuscitation. So the next thing I look for is any areas of attenuation that are similar or higher attenuation compared to the aorta, that tells me that it's active bleeding or a contained vascular injury or a vascular injury. And so here's our aorta, and you want to just check out that attenuation. You can see that there are no areas that are high attenuation, so no evidence of active bleeding or a vascular injury. You want to check out the spleen. Here's the spleen to see if there are any associated splenic lacerations. And we see none, but there's a small amount of hemoperitoneum. And from this point, you want to check out the lung bases to see if you can find a pneumothorax or contusions. Check out the overlying ribs to see if there's associated rib fracture. When you're on lung windows, keep those lung windows on and scroll through the abdomen to look for free air in the abdomen and pelvis. Okay, so let's go to our first question. So what is the AAST grade for these injuries? So the AAST organ injury scales were revised in 2018, which was a big deal. They were first introduced in 1989. Remember, these are based on operative findings. And with the advent of CT, it was discovered in 1971, and then we really went into MDCT by the probably late 90s. We started to see things like active bleeding, and these were found to be associated with worse clinical outcomes. And so for some time, we've been asking for active bleeding to be included, and finally they were included, and you can see that they're right there in grades 3 and 4. All right, so now let's grade these lacerations. So if we just go to 3, I always use 3 centimeters depth. It correlates with grade 3, and so I think some of these lacerations are much deeper than 3 centimeters, even though we don't have precise measurements we can drop just by eyeballing these. I think those are probably at least 5 centimeters in depth. Here, parenchymal disruption, I think we could argue that 25% of the hepatic lobe is involved. I think you could argue for or against that. We don't see any active bleeding, but we did see, which is grade 5, that we did have juxtavenous injuries because some of these injuries went right alongside the central portion of the middle hepatic vein. All right, so based on that, the grade for these injuries, I would assign grade 5 for the juxtavenous injury portion. All right, so let's go to case number 2. This was a high-speed MVC. And you can see that the injuries are really quite bad here in the right hepatic lobe. A lot of this right hepatic lobe looks like it's devascularized, so these are sort of all disrupted, probably because that portal branch of the portal vein got injured. And then, so these are extensive lacerations. Some of these go right to the margin of that right hepatic vein. And the next thing we do is look at the aorta, check out the attenuation, and we see immediately that there is a focus of attenuation that is just as high, and I think it's actually a little bit higher than the aorta. So this is a focus of either active bleeding or a vascular injury, such as a pseudoaneurysm. Hard to tell based on just one image. If we had more delayed images and this got bigger and more amorphous, then we would say this is active bleeding. But because this is so rounded looking, I would call this a pseudoaneurysm. All right, so let's go to a corollary case. This is a different patient, and this is one where you can see lots of hemoperitoneum, and you can see the layering blood products increasing in attenuation dependently. Here is the inferior margin of the right hepatic lobe coming through, and there's this bright area. It's upside down, mushroom shaped, similar or higher in attenuation to the aorta. So this is a big area of active bleeding. And I'm calling this active bleeding because it doesn't have this rounded pseudoaneurysm morphology, and it's going beyond the confines of where we would expect that hepatic margin to. It looks like the blood is kind of streaming down. And then I think the other notable thing about this image is just this part, and this is obviously abnormal looking bowel. And so it's hard to tell exactly where we are. I think this is probably the duodenum or a portion of the hepatic flexure, and this is obviously pronounced wall thickening. That mucosa is irregular and thickened, and so we expect that there are extensive contusions and probably some hematoma in that injured bowel segment. Okay, so our next question is, which of the following is defined as a vascular injury? A, subcapsular hematoma, B, vascular thrombosis, C, pseudoaneurysm, and D, active bleeding. All right, so on your trauma scans, you always want to look for active bleeding and vascular injury. The vascular injuries are being defined as a pseudoaneurysm or AV fistula. In the past, on some of the older papers, we were calling these contained vascular lesions, and with the new AAST, update, we're calling these vascular injuries. The key points for active bleeding and vascular injuries are they are going to be equal or higher in attenuation than the aorta. If you have two phases, it helps in differentiating the two. So on a later phase, what you would expect is that the pseudoaneurysm or AV fistula stays sort of focal in morphology, rounded in morphology, and the enhancement washes out with the aorta. As the enhancement washes out with the aorta, you might expect that the lesion looks smaller. And with active bleeding, it's usually irregular in morphology. There's nothing confining it, so it enlarges on later phases. And sometimes it can increase in attenuation, and so that's an obvious difference from the pseudoaneurysm or the AV fistula. But if you have a biliary injury, and so there's bile coming out, or in renal injury, if you have a collecting system injury and there's urine coming out, obviously there's going to be some dilutional effect. And so it's not a hard and fast rule what the attenuation of active bleeding looks like on a more delayed phase. It can be higher, it could be iso, it could be hypo, depending on what's happening. All right, so with that in mind, let's go back to the question. And remember, these were our cases where we had an area that looked like a pseudoaneurysm, and this looks like active bleeding. And the answer to this question is based on the definition that's been outlined in AAST. It is a pseudoaneurysm. Okay. Case 3. This person was kicked by a horse. We have a number of horse injuries in the Midwest. And this is just a single image from a contrast-enhanced CT. And you can see that there are all these areas of decreased attenuation. These are all lacerations. This is the right hepatic vein, which is very well outlined. And these lacerations go right along the margin to, these are pretty central portions of the hepatic vein there. The retrohepatic IVC also looks a little bit funny. It looks a little bit squared off or rectangular off. And that's because there's all this low attenuation, which may represent some hemorrhage going up and maybe some contusions that are, affecting that portion of the IVC. All right, so question for the case. What is true about liver injuries that extend to or involve the hepatic veins or IVC? All right, answer choice A, more than 90% of these require surgery. B, you can expect less than 10% mortality. C, it's not usually associated with arterial injury. And D, there is a lower rate of non-operative management failure. All right, so we're going to go do a little bit of didactic. So juxtahepatic venous injuries are no joke. All right, these are defined as extending to central hepatic veins or the IVC. 92% of these require surgery, and these are associated when they go to surgery with 50 to 80% mortality. These injuries are 3.5 times more likely associated with hepatic arterial injury, and they're 6.5 times more likely to require surgery. And I spoke with a trauma surgeon one time asking about these injuries, and they say they need to know about these if possible because it often requires them to change their operative approach so they can access those hepatic veins. And if they are injured, they have to be very fast about stitching them up because the patient can exsanguinate from these injuries. So these are really quite scary, and that's why they're in the grade 5, the highest grade severity. Okay, so going back to our question, what is true about liver injuries that extend to or involve the hepatic veins or IVC? And the answer is more than 90% of these require surgery. Okay, so very important severe injuries. Case number 4, and I think this is our last liver case. All right, so this was an MVC, and I put this case in here to show you how how the reformats can really help you. So I have to say, when I looked at this case initially, I mean, these are your lacerations. Here's a little bit of the portal vein. And, it's not really that impressive looking. And when I scroll through all the axial images, it really wasn't that impressive. But the coronal really shows how extensively that right hepatic lobe is being affected. So when you can, go to your coronals and sagittals and just take a look at some of these injuries. It can help you, and it can maybe even change how you grade those injuries. Okay, so case number 4 question. Which is the best contrast choice for a blunt trauma patient? A, oral and IV contrast, B, oral, IV, and rectal contrast, C, IV contrast, and D, no contrast. All right. So in blunt trauma, we do not recommend giving oral contrast. Nobody gives oral contrast in blunt trauma. If you give oral contrast in blunt trauma, you are practicing outside a standard of practice. There's some literature on this. This was the one that was probably the one that's most often cited. And what they found was that there were no injuries that required surgery that were missed when they didn't use oral contrast. There was a very real risk of aspiration if that patient ends up needing to go to surgery. And what can be recommended is a follow-up CT with oral contrast when the patient is stable. All right, so no oral contrast in blunt trauma. You need to use IV contrast because it's essential for depicting injuries. We perform oral arterial phase if we're looking for active bleeding and vascular injuries, and the portal venous phase helps us see the solid organs. It's the parenchymal phase of enhancement and looking for bowel injuries. And having 2 phases helps differentiate active bleeding from vascular injuries. It helps you see different things. And so many major trauma centers will image both arterial and portal venous phase through the abdomen. There is a role for oral and rectal contrast, and this is in penetrating trauma. And what they do is it improves detection of bowel perforation. And so this is what rectal contrast looks like. It's really bright, and it's actually really pretty looking in depicting the structures if you use it. And in this one, this was a stab wound, and you can see there was a multiple stab wounds, I think. But here was the trajectory for the one stab wound through the kidney, and you can see there's perinephric hematoma. And then here's a little bit of stool in the ascending colon going up to the splenic flexure. And this is contrast, rectal contrast, that's extended beyond the luminal confines of the colon. And so there's been a penetrating injury to the colon here. Okay, case 4, here's your question. Which is the best contrast choice for a blunt trauma patient? And so for blunt trauma, the answer becomes IV contrast. All you need is IV contrast when you're imaging a blunt trauma patient. Nope, one more case for the liver. So this is case 5, and this was a patient who was kicked by a horse. It was a young adult, and this was the follow-up scan. On the initial scan, most of the left hepatic lobe was devascularized, and she went on to getting that embolized, and post-embolization developed this collection that contained gas and debris. Didn't know if it was infected or not. This was a sterile collection. But what we noticed was that she had also developed this funny sort of, vermiform appearing fluid collection, not particularly thick-walled. I'm sure most of you are guessing what this is. And so a follow-up test was recommended. And what we see is also something similar, this contrast collection, not contrast, this is radiotracer. So this is a HIDA scan with this large collection of radiotracer, and this was a biloma. All right, so question for you is, which is a delayed complication of liver trauma? A, bowel perforation, B, biloma, C, liver failure, or D, abscess? And so I wanted to go through some of the risks. So non-operative management has been the way the surgeons have been doing things for almost 2 decades. But there are certain risks. So these are the risks of non-operative management. So after the patient gets their initial scan, they watch the patient. If their clinical, examination deteriorates, they have increasing pain, they may be experiencing these various things. So they may come back to us in radiology and get a repeat scan, and you're looking for these possibilities. Is the patient rebleeding? Has there been something happening that's causing an infection? You're looking for biliary complications. And so going back to our question, a delayed complication of liver trauma is a biloma, especially with extensive lacerations or lacerations that involve portions of the liver more centrally where the bile ducts are larger in caliber. And this is a slide just reviewing the different biliary complications. And so I want you to just note biliary leaks are more frequent in penetrating trauma compared to blunt trauma, possibly because the liver capsule gets violated during penetrating trauma, and maybe that has plays some role in containing biliary leaks. Biliary injuries are more severe, though, in blunt trauma. It's important to note that free fluid on CT has very low specificity for bile leaks. So of all patients who have free fluid on CT in the setting of blunt trauma, only 25% of them had a bile leak. But if you don't see any free fluid by CT, this has a very high negative predictive value for bile leak. And this was a really nice article by Chrissy Lebetis out of Boston Medical that went through these complications. All right, so we just have to wrap up and make sure we assign the AAST grade to the injuries. So let's go back. So I wanted to remind you, when you go and look up these, the AAST grading, they're very easily accessed at the website. You'll notice at the bottom there's fine print, okay? And this is where we get the definition for pseudoaneurysm or AV fistula. You can see that if you have more than one grade of injury present, you want to go with the highest grade. And if you have multiple injuries, advance one grade for multiple injuries up to grade 3. Okay, so beware of the fine print when grading the when grading these injuries. All right, so let's go back to our case 2. So the grade for this one, this has a focus of active bleeding, which is within the liver parenchymal confines, but we had lacerations that extended to the central portion of the right hepatic vein, and so this ends up being a grade 5. The corollary case, this was the one that had active bleeding beyond the confines. We can't see the rest of the liver, so we can't use that for our grading. But just with this finding alone, we know that this gives us at least a grade 4 because there's active bleeding extending beyond the liver parenchyma into the peritoneum. So this was a grade 4 injury just based on the one image. For case 3, again, this one goes right to that right hepatic vein, and this is a juxtahepatic venous injury, so this is a grade 5. And for this case, these were extensive injuries. There was no evidence of active bleeding based on these images. On the coronal, we can see that this involves at least 25%, if not almost 50% of that right hepatic lobe. So this puts us at the grade 4 category. And for the last case, the initial scan showed that most of the left hepatic lobe was devascularized. So this puts us at least at a grade 4 injury. All right, so let's switch gears and go to the spleen. So this is case 1, and now we're going to look on the other side of the abdomen. So left upper quadrant, here's the spleen, and there are all these decreased areas of attenuation, areas of decreased attenuation consistent with multiple lacerations. Here's the area of the splenic hilum, and these pretty much avoid the splenic hilum, which is a very good thing. Now, along the inferior portions of the spleen, there's this curvilinear high attenuation, similar in attenuation to the aorta, and this is a little bit of active bleeding, probably extending beyond the confines of the spleen, and there's lots of hemoperitoneum. Here is the left adrenal gland, which is enlarged, so there are multiple contusions involving that left adrenal gland, and more hemoperitoneum extending around the liver, and we don't see any lacerations involving the liver. Oh, this is from Dr. Napolitano, was chief of trauma surgery, and she lent this image to me showing what lacerations look like. So you can see that, anatomically, the CT lines up very nicely. This is what it looks like by CT, and this is what it looks like in real life. And this area that's dusky has been devascularized. All right, so case 1 question, what is the AAST grade? And this is the 2018 revision. So this is what the whole thing looks like. I only showed you a portion of it for liver. This is what it looks like when you go to the website and in publication. And you can see that they use imaging criteria, operative criteria, and pathologic criteria. Okay, so this is the full thing. For the spleen, again, there are 5 grades possible. Each one is described. And they have now incorporated CT findings of active bleeding. And then there's the fine print on the bottom that you should pay attention to as well. And then for us, this is really what we focus in on. The surgeons in their final grading will take into account all of those other things. So focus on that part and don't forget to read the fine print. Important, very important. All right, so going back to our case, this is a grade 5 injury because there is active bleeding. So let's just go back to that grading, and here you can see any injury in the presence of a vascular injury, and there's active bleeding extending beyond. All right, so this is a grade 5 injury. Okay, so this case was a gentleman who played in a rugby, some pickup rugby, and he was tackled and had some left upper quadrant pain a day or so later, and came into us. And you can see that on this one image, you can barely, the spleen is up there. I'm only showing you one image, and that there are multiple areas of high attenuation, higher than that of the aorta. And so these are areas of active bleeding along the inferior aspect of the spleen. And then this went on to embolization, and again, post-embolization developed bubbles of gas within the embolized portion of the spleen, and they took a little bit of tissue and aspirated, and this was also sterile. And so we have a question based on this case. In which patients would you recommend angioembolization? So grade 1 injury, no active bleeding. Grade 2 injury with active bleeding. Grade 2 injury, hemodynamically unstable. Or grade 5 injury without active bleeding. And so this brings us to the role of angiography and angioembolization. And so active bleeding at CT is associated with the need for splenectomy. And if you have multiple bleeding splenic injuries, there is an even higher splenectomy rate. The role of angioembolization is viewed as sort of an adjunct or extension of non-operative management, and it improves, it's been demonstrated to improve non-operative management success rates. Angioembolization is recommended when you have lower grade injuries with active bleeding, but it's also recommended for the higher grade injuries, 4 and 5, when there's no active bleeding. And doing both of those, lower grade with active bleeding, higher grade without active bleeding, have been demonstrated in the literature to improve the success rates of non-operative management. It's important to note that if the patient is hemodynamically unstable, they should not be in radiology or go on to angio. They should be going directly to the operating suite. And also, finally, higher grades of injury with active bleeding may be unstable injury. So if you see a high grade lacerations, high grade injuries, and there's active bleeding, the patient may not be stable. Okay, so case 2 question, in which patients would you recommend angio? And for this, we would definitely want to do grade 2 with active bleeding, but also we would recommend angioembolization for grade 5 injuries without active bleeding. All right, so case 3, this was a very bad motor vehicle collision, and we are here centered in the left upper quadrant. This is where the spleen should be, and we don't see anything that looks like splenic parenchyma. I think maybe you could discern a little bit of a splenic shadow right here. Here are some preserved, barely preserved hilar vessels, and this is basically a large hematoma. The spleen is essentially shattered, and this is the highest grade injury, which is the shattered spleen, and will go on to splenectomy. Okay, so in olden times, when they did more operative management, what was and what is the most dreaded consequence of splenectomy? And the answer is overwhelming sepsis, because of the role that the spleen plays in the immune system. Okay, so non-operative management, it's really important to know that NOM results in lower complication rates, fewer blood transfusions, lower morbidity and mortality, and lower hospital costs. So this is multiple wins on the part of both management and for the patient. And in summary, imaging plays a key role in the evaluation and management of traumatic injuries. MDCT with IV contrast is the best imaging test. The AAST revised its grading system in 2018 to reflect and incorporate CT findings of active bleeding. Active bleeding and vascular injuries increase the AAST grade, and angioembolization plays an important role because it can improve non-operative management success rates. And that is all. I hope you enjoyed the session. Thanks very much, and stay safe and healthy. Thank you.
Hello, I'm Joel Gross, and I'm pleased to be talking to you today about renal and bladder trauma. I have no relevant disclosures. We'll start with renal trauma. The format of this portion of the talk is as follows. We'll start with a brief introduction, review some common and typical renal injuries, review injury grading, review imaging protocols, and then we'll go a little bit beyond the basics. Renal trauma occurs in about 10% of patients with abdominal injury. 90% is due to blunt trauma, and the kidney is the third most commonly injured organ in adult blunt abdominal trauma. Now, why should we image these patients? In the 1950s and 60s, renal exploration often led to nephrectomy. Yet less than 2% of patients with blunt kidney injuries require surgery, and many of the penetrating injuries can also be treated non-operatively. Thus, accurate characterization of the injury can produce improved outcomes with appropriate management, whether it's conservative or surgical. Why bother grading? It's a research tool that allows comparison of data between institutions. The OIS grade is used to calculate the Injury Severity Score, or ISS, and the ISS correlates with patient outcome and likelihood of death. Our surgeons often want an assigned grade. Now, what's different about the kidney versus other organs, such as the liver and the spleen? It produces urine, and this affects imaging protocols. It's retroperitoneal, and so we can miss injuries on a fast scan, a diagnostic peritoneal lavage, or with peritoneal exploration. Let's turn now to injury types and grades. The American Association for the Surgery of Trauma, or AAST, Organ Injury Scale, was published in 1989 and is the most commonly used grading system over the past decades. This will be the focus of our talk. We will discuss the newer grading systems as well. Here we see a simplified description of the organ injury scale. And this diagram nicely shows us the types of injuries it covers. Grade 1 injuries are contusions and subcapsular hematomas. Grade 2 injuries are superficial lacerations and perinephric hematomas. Grade 3 injuries are deeper lacerations but without collecting system involvement. Grade 4 injuries extend into the collecting system or are contained main renal artery and vein injuries. And grade 5 injuries are shattered kidneys or renal hilum avulsions. Here we have an example of a grade 1 injury with a contusion which demonstrates persistent contrast material staining on the delayed images. Here's another grade 1 injury, a subcapsular hematoma, which present as a round or elliptic hyperattenuating fluid collection which indents or flattens the renal margin, as seen here. A grade 2 injury is a superficial laceration defined as less than 1 centimeter, while a grade 3 injury consists of a deeper laceration greater than 1 centimeter. Notice that I'm showing you the delayed images here to show you that it's a deeper laceration but without urinary extravasation. Grade 4 injuries have urinary extravasation due to a laceration extending to the collecting system. Another grade 4 injury is a main renal artery or vein injury with a contained hemorrhage. These are rarely seen. Grade 5 injuries are shattered kidneys or renal hilum avulsions, again, rarely seen. Now, there are other important injuries that are not explicitly specified in the AAST system. These include main renal artery traumatic thrombosis, which can lead to renal infarction, segmental renal artery injury leading to segmental infarctions, pseudoaneurysms as shown here or arteriovenous fistulas, and collecting system injuries without a renal lac. Newer grading systems have been developed. A 2011 proposed update included some of these previously excluded injuries, but the revision was not clearly incorporated into the official AAST system and was not listed on the AAST website, leading to variable adoption. There was no significant change in grade 1 through 3 injuries. They included the following injuries in grade 4: segmental renal artery and renal vein injuries, and all renal collecting system lacerations. And they included all main renal artery and renal vein injuries in grade 5. An updated grading system was published in 2018. The 2018 update clarified a number of injuries and added or updated injuries, such as grade 3 injuries to include pseudoaneurysms or arteriovenous fistulas or active bleeding within Gerota's fascia. Grade 4 injuries to include segmental or complete renal infarction due to thrombosis without active bleeding, or segmental renal artery or renal vein injury, or active bleeding beyond Gerota's fascia, or all collecting system injuries. Grade 5 injuries included devascularized kidney with active bleeding. Now, is this 2018 update what everyone is using? And the answer is not yet. While the paper states that the OIS has been reviewed and approved by the board of the managers of the AAST, it's not on the AAST website as of May 2019, and it's not been widely and consistently adopted. So we'll continue to use the original 1989 system for this lecture. Now, this might all seem complicated and scary, especially if you don't do much trauma or if you're unsure what classification system to use locally. But the most important thing is simply to describe the findings which allow the injury to be graded. And most of these are findings that you would normally report regardless of the grading system in use. So what should you report to cover all or most needs? A contusion, subcapsular hematoma, laceration and specify its depth so they can tell if it's less than or greater than 1 centimeter, shattered kidney, urinary extravasation, UPJ disruption, a hematoma or active bleeding, and specify whether it's within or beyond Gerota's fascia, pseudoaneurysm or arteriovenous fistula, segmental renal artery or renal vein injury, segmental or complete renal infarction, main renal artery or renal vein laceration or hilar avulsion. So let's start now with an illustrative case. And here we see a patient who's undergone some trauma. There are some deep lacerations in the kidney. And this is a grade 3 injury. Are we done with our imaging? The answer is no. Delayed images are required because there's a laceration and perinephric fluid. Delayed images were obtained, and here we see there's urinary extravasation, and this upgrades the injury to a grade 4. Now, this example helps us understand our renal imaging protocols. While indications exist for when to image renal trauma, we rarely image a patient just for renal trauma, and we essentially always do this as part of an evaluation of their abdomen and pelvis. So we won't spend time on the indications, although there are some references below. The kidney differs from other organs due to production of urine. And so while fluid adjacent to other solid organs following trauma could be, and is usually, hemorrhage, fluid adjacent to the kidneys or ureters is hemorrhage, urine, or both. Here I show our current protocol at Harborview Medical Center, where we inject 125 cc's of contrast. We scan the patient during the venous phase to evaluate the parenchyma and vessels using a fixed 70-second delay. We scan from the dome of the diaphragm to the ischial tuberosities. And if there's a renal injury or fluid around the kidney or ureter, we get 10-minute low-dose delayed phase images through that region to evaluate for urinary extravasation. We limit the scan to the region of interest and don't scan the entire abdomen and pelvis. Arterial phase imaging is occasionally helpful, but it increases radiation. The 2018 OIS updates recommend both arterial and portovenous phase imaging, but this may not be performed at all facilities. Arterial phase imaging is not obtained in our trauma CT, abdomen, and pelvis protocol to minimize radiation. However, when we do a pan-scan protocol, we do arterial phase imaging through the chest, which extends through the upper abdomen and does include the kidneys. Delayed images are important. This may seem obvious, and they're recommended when a renal injury is known or suspected, but we still receive many transfer patients without the necessary delayed images. Here's an example of a report where they very nicely identified a prominent laceration in the lower pole of the left kidney with a large perinephric hematoma, but there was no comment that delayed images were not obtained and that we can't exclude urinary extravasation. If you're unable to check if delays are needed in real time while the patient is in CT, and if you see a renal injury or adjacent fluid, you can either bring the patient back for delayed images, or you can simply state that you cannot exclude urine extravasation without delayed images. Now, when should we perform delayed images? Many or most institutions do this at about 5 minutes. But some of these institutions detect only 50% of urinary extravasation on initial imaging. A 2019 study demonstrated that increasing the time to the excretory phase is positively associated with finding urinary extravasation at the initial CT scan. And they state that a 9-minute delay between the early and excretory phases optimized detection of urinary extravasation. This corresponds to approximately a 10-minute delay from the start of contrast injection, which is what we do and recommend. Let's now go beyond the basics. Our next case has 3 images showing damage to the kidney. 10-minute delayed images are also available. So how would you grade this injury? Our findings are multiple deep lacerations through the mid-portion of the kidney, a large amount of perinephric fluid, but no urinary extravasation on delayed images. So this would be diagnosed as a grade 3 injury. Follow-up imaging was obtained, and when we compare it to the initial images on the left, we see that in the follow-up images, we do see urinary extravasation. This is an example of the progression of severe grade 3 injuries. On initial imaging, a clot may occlude a laceration extending into the collecting system. Urokinase can lyse this clot over time, allowing the collecting system to communicate externally, and urinary extravasation to occur, thus upgrading an injury from a grade 3 to a grade 4. Our lesson is that we may need to follow up severe grade 3 injuries. Unfortunately, there are no clear criteria as to which injuries require follow-up imaging and when to obtain follow-up imaging. At our institution, severe grade 3 injuries undergo a urinoma protocol 2 to 3 days following injury or prior to discharge if that is earlier. A urinoma protocol is not a trauma abdomen pelvis CT, and it's not a CT IVP. It's a low-dose CT specifically designed to evaluate for urinary extravasation. It's a low-dose, non-enhanced CT as a first phase to evaluate for residual contrast from a prior CT. We then inject IV contrast and wait 10 minutes and obtain 10-minute low-dose images through the region of interest only. Note that there are no parenchymal phase images unless they're specifically indicated at this time. Here's an example. On the initial study, delayed images, we see that there's urinary extravasation from this kidney, which happens to be a horseshoe kidney. For our urinoma protocol, we start with a low-dose non-contrast image to see if there's any residual contrast from the prior study, and here we see there's none. And then we inject our contrast, wait 10 minutes, and scan the patient, and we see that there is persistent urinary contrast extravasation on the right. Our next case, we see images from a portal venous phase and delayed phase. Notice that there's no parenchymal laceration, but we see contrast in the renal sinus and around the ureter. The diagnosis here is a forniceal disruption. Let's review the fornix. These are the corners of the calyces as seen in these coronal and axial images. Blunt trauma can increase intra-abdominal pressure, leading to increased pressure in the collecting system and a tear in the calyceal fornix. This can lead to urine and contrast extravasation. Contrast can pass from the fornix, down the minor calyx, along the infundibulum, along the pelvis, and finally out into the periureteral space. The diagnosis is made if there's no parenchymal or collecting system laceration and there's contrast within the renal sinus. In contrast with ureteral lacerations, we'll see periureteral contrast, but it rarely dissects retrograde back into the renal sinus. Traumatic forniceal disruptions usually resolve quickly without intervention. Short-term follow-up imaging can be obtained to confirm resolution. At this point, we're pretty good at evaluating for urinary extravasation from a variety of causes. But let's look at one more case. Here are the portal venous phase images, and we notice that there's a dilated collecting system, fluid around the kidney, and some hyperdense material within the collecting system. Are we done? No, delayed images are required because of the fluid around the kidney. Here are the 10-minute delayed images. Are we done at this point? No. We have a dilated collecting system and it's not distended with contrast, and so it hasn't adequately been challenged to look for a leak. The patient was brought back for 3-hour delayed images, and now we see contrast distending the collecting system, and we're able to diagnose urinary extravasation. This is nicely demonstrated in these coronal images. On the left, in the parenchymal phase, in the middle with 10-minute delayed images, and some contrast in the collecting system, and finally at 3 hours with contrast, nicely filling the entire collecting system, we're able to see the urinary extravasation. So our teaching point here is that urinary extravasation has not been adequately evaluated for until the collecting system is distended with contrast. A dilated collecting system may require longer delayed images to fill and distend the collecting system. Other options are to move or roll the patient around to distribute contrast, but this can only be done once the spines are cleared. Let's briefly talk about at-risk kidneys. At-risk kidneys are abnormal kidneys, as the amount of trauma needed to damage an abnormal kidney is often minimal. The evidence for this is that injured abnormal kidneys are uncommonly associated with other abdominal injuries and have significantly lower ISS scores. Injuries caused mainly by low impact velocities. Kidneys predisposed to injury include those with tumors, those with cysts, kidneys with hydronephrosis, and here we see a tear through the thinned parenchyma, and ectopic kidneys, such as those in the pelvis, and horseshoe kidneys. Let's briefly talk about some new developments. A nomogram was recently published to predict the need for bleeding interventions. There are multiple factors that the clinician looks at. They'll look at trauma mechanism and hypotension, but the radiologists can help them with the concomitant injuries, vascular contrast extravasation, pararenal hematoma, and hematoma rim distance. Pararenal hematoma is defined in this paper as a hematoma that extends beyond the aorta on the left, or beyond the inferior vena cava on the right, or that extends inferior to the aortic bifurcation into the pelvis. The hematoma rim distance is the longest perpendicular distance from the renal parenchymal border to the hematoma border on axial images. In other words, the thickness of the hematoma on axial images. If this nomogram is adopted by surgeons, we will need to report the presence of a pararenal hematoma using the definition provided in the paper and the hematoma rim distance. So in summary, we've reviewed the common and typical renal injuries. We've reviewed injury grading. We've reviewed imaging protocols and the selective need for delayed images and when and how to perform a CT urinoma study. And we've spent some time going beyond the basics. Let's move now to bladder trauma. The format of this portion of the talk is we'll start with a brief introduction, review the classification and appearance of bladder injuries, review imaging protocols and indications, and review some cases and challenges. Bladder injuries due to blunt abdominal trauma are rare, occurring in 1.6% of blunt abdominal trauma cases. 90% are due to motor vehicle crash, motorcycle crash, or car versus pedestrian. Contusions are by far the most common injury, followed by extraperitoneal bladder rupture, intraperitoneal bladder rupture, and combined bladder rupture. A blunt blow to the abdomen in a patient with a distended bladder can lead to a large tear at the dome of the bladder. This can produce gross hematuria and an intraperitoneal bladder rupture. A pelvic ring fracture or disruption can cause an extraperitoneal bladder rupture, which is more common than an intraperitoneal bladder rupture. The majority of patients with bladder ruptures also have pelvic fractures. Only a minority of patients with pelvic fractures have a bladder rupture. And we don't want to image all these patients with pelvic fractures, so we'll discuss some guidelines to select the appropriate patients. Let's look now at the management of bladder trauma. Intraperitoneal bladder ruptures require urgent surgical repair to avoid a chemical or infectious peritonitis or electrolyte disturbances and other problems. An extraperitoneal bladder rupture can be treated conservatively with catheter drainage unless there are complicating factors, such as a penetrating injury, anterior pelvic surgery required, inadequate drainage, rectal or vaginal injuries, a low injury near the bladder neck, foreign body or bone fragments in the bladder. 85% of these extraperitoneal bladder ruptures treated with catheter drainage heal by the 10th day, and almost all of them heal within 3 weeks. Let's look now at the classification and types of bladder injury. The AAST surgical classification system is based on size and location. We can evaluate this at surgery, but cystography is not reliable in evaluating the size and also has some trouble with the location. so it's impractical for us to use this system. So what do we report? We describe full thickness ruptures, which include intraperitoneal bladder ruptures, extraperitoneal bladder ruptures, and combined bladder ruptures. There are lesser injuries that are rarely seen, such as a contusion, which is not well visualized, and an interstitial rupture, which is a tear or dissection between the layers of the wall of the bladder, which is extremely rare. Let's look now at the CT cystography appearance of a bladder rupture. A bladder rupture is diagnosed if there's extravasated bladder contrast in the intraperitoneal, extraperitoneal, or both spaces. The bladder laceration itself is not always visualized, but we report its location when it's identified. Intraperitoneal contrast accumulates in the typical intraperitoneal spaces, much like ascites. And extraperitoneal contrast is typically streaky as it insinuates between fat and fascia. Here we have an example of an intraperitoneal bladder rupture with contrast around the bowel loops and between the mesentery. More contrast is seen here in the rectovesical recess and supravesical spaces. With an extraperitoneal bladder rupture, contrast fills the extraperitoneal spaces around the bladder. This is typically streaky and irregular, and it may also form a molar tooth appearance, as shown in this example and in green on the right. From there, it can extend into the anterior abdominal wall and beyond the pelvis. A combined bladder rupture is simply an extraperitoneal bladder rupture combined with an intraperitoneal bladder rupture. Now, at this point, we know what a bladder injury is. Next, we'll talk about who to image, and then we'll talk about how to image. So who should we image with CT cystography? Patients who present with one of the following: gross hematuria and intraperitoneal fluid, to rule out an intraperitoneal bladder rupture, or patients with 3+ or greater microhematuria and a pelvic ring injury, to rule out an extraperitoneal bladder rupture. So we do not need to image most patients, including those with gross hematuria but without free fluid, less than 3+ microhematuria, more than 3+ microhematuria if there's no pelvic ring injury, or isolated acetabular wall or iliac crest fractures. Let's move on now to CT cystography technique. CT cystogram is performed after the CT of the abdomen and pelvis to avoid any extravasated bladder contrast obscuring vascular extravasation. The technique is as follows. We drain the bladder via the catheter to eliminate dense excreted contrast and unopacified urine. We hang a bag of dilute contrast 40 centimeters above the bladder, and we instill the contrast until flow stops or it becomes uncomfortable for the patient or the contrast runs out. The catheter is clamped, and we scan once and only once through the bladder and pelvis. Now, we're emphasizing this because occasionally we get outside studies in which the patient was scanned multiple times, much like they would have done in the past with a fluoroscopic cystogram. And here's an example of a patient who they scanned 4 times. Now, adequate distension is critical. We need to generate a pressure of 40 centimeters of water, and we can do this by hanging the bag of contrast 40 centimeters above the bladder and letting it run in until it stops flowing. We may have to stop earlier if the patient becomes uncomfortable due to distension of the bladder. And in the literature, they say that a volume of 300 to 350 cc's is enough, but we believe that more is better unless it's limited by the other 2 criteria, and we just let the bag keep running. Here's an example of why it's important. With 100 cc's of contrast in the bladder, it looks just fine. But when more was instilled, a large extraperitoneal bladder rupture is clearly identified. At this point, you might ask, can bladder filling on delayed CT images replace a CT cystogram? Let's take a look at a few cases, and here we see on the portal venous phase and 10-minute delayed phase images, there's no evidence of bladder extravasation. But when we do a CT cystogram, we clearly see an extraperitoneal bladder rupture. You might argue, well, there wasn't much contrast in the bladder, so let's look at another case. Here in the delayed CT images, we see a large amount of contrast in the bladder and a well-distended bladder. It looks a lot like a CT cystogram. Yet when we actually perform a CT cystogram, we do find that there is, in fact, a bladder rupture. So the answer is no. Delayed CT images cannot replace a CT cystogram, as inadequate distension limits sensitivity. Let's move now to cases and challenges. Here we see some contrast beyond the normal bladder contour. Is this an extraperitoneal bladder rupture? No, this is in fact just a bladder diverticulum. It looks like one. It has smooth borders rather than the streaky contrast in the extraperitoneal spaces. Here's another example. Here we see a patient who has a bladder injury, the extraperitoneal contrast, and very nicely we can see the difference between the right-sided bladder diverticulum with the smooth walls, smooth contour, compared with the streaky contrast in the extraperitoneal spaces. Next case, we see contrast in the bladder and in the ureters, and there's a smooth collection of contrast behind the bladder. This was initially read as an intraperitoneal bladder rupture. But when you review the lower images, you'll see that there's contrast in the vagina, and the correct diagnosis here is vaginal reflux of contrast without a bladder injury. So how does vaginal reflux of contrast occur? If we look at this distended bladder, and we see this contrast in the vagina on the right image, and now we'll focus in on the urethra and blow that image up. The black ring is the Foley catheter, and there's contrast in the lumen of it. But notice that there's also contrast that's refluxing around the Foley catheter, down the urethra, and that can drop back and reflux into the vagina. Next case, we see contrast external to the bladder. It looks like an extraperitoneal bladder rupture, but when we carefully window the images, we notice that the contrast is actually brighter than the contrast in the bladder, and so we need to start thinking about other possibilities. And when we looked further, we found that this was indeed due to arterial extravasation in the pelvis. This brings us to the end of our talk. So in summary, we've reviewed the types of bladder rupture and typical appearances. We've reviewed the technique and indications for CT cystograms. We've learned that adequate retrograde bladder distension is essential. And we've demonstrated that not all perivesical contrast is due to bladder rupture. Thank you for your attention.
Hello everyone, I'm Dr. Nicholas Murray, a radiologist at Vancouver General Hospital, University of British Columbia in Canada. Today we're going to talk about the traumatic bowel and mesenteric injuries. Specifically, the learning objectives are to recognize the CT signs of traumatic bowel and mesenteric injuries, and of course to recognize the perils and pitfalls in evaluating patients with suspected traumatic bowel and mesenteric injuries. Here's the plan. We're going to start with a short quiz, 5 questions quiz. Then I'm going to talk about the findings, and I'm going to show different cases to illustrate these CT findings. And we're going to come back at the end with the answers for the initial first 5 questions. Let's start with a quiz. Question 1. True or false? All mesenteric and bowel injuries should be evaluated by surgery. True or false? Question 2. What is the most sensitive sign for traumatic bowel and mesenteric injuries? Is it A, free air, B, free fluid, C, mesenteric stranding, or D, bowel wall thickening? Question 3. Which injuries can happen with the lowest force level? Is it the burst injuries, crush injuries, shear injuries, or tensile injuries? Question 4. True or false? Free fluid should normally never be seen in male patients. True or false? And last question, number 5. Which one is not a recognized risk factor for traumatic bowel and mesenteric injuries? Having multiple solid organ injuries, pancreatic laceration, a pre-existing Crohn's disease, seatbelt sign, or having a vertebral wedge fracture. Which one is not a risk factor for traumatic bowel and mesenteric injuries? First of all, I would like to recommend this really good radiographics article published in 2017, multi-detector CT of surgically proven blunt bowel and mesenteric injury. A majority of the clinical information I'm going to show you today is from that paper. First of all, the bowel and mesenteric injuries are relatively uncommon, happening only in 1 to 5% of the trauma cases, most commonly happening after MVC accidents. There's apparently a greater risk for injuries if you're a passenger as opposed to being a driver, and especially if for those in the rear seat. Mesenteric injuries are 2 to 3 times more common than bowel injuries. The problem with these is that a delayed diagnosis will usually be associated with increased sepsis, increased number of intra-abdominal collections, peritonitis, prolonged ICU and hospital stay, bowel stricture, and of course, overall increased mortality. And the challenges with bowel and mesenteric injuries, it's first that it's not common. It's usually associated with multiple concomitant or concurrent injuries on a really busy scan. The mesentery is an undefined organ, so you cannot follow its contour. The bowel is also a really long and tortuous organ, which is also mobile, and the injuries can happen or can involve multiple segments. And on top of that, usually the findings are quite subtle on imaging. The bowel injuries will most commonly affect the small bowel in 67% of the time, followed by the colon in 20% and duodenum in 8%, and less commonly will involve the appendix, stomach, and rectum. The CT diagnosis of TBMI presents a relatively variable sensitivity and specificity between 80 to 95% and 50 to 99% respectively. The non-recognized TBMI will be the most frequent cause of delayed laparotomy after trauma, and the diagnostic delay will have a significant impact on prognosis and mortality, especially if the diagnosis is delayed by more than 24 hours. And usually the questionable radiologic or clinical findings should be closely observed, and repeat CT should be recommended in 24 to 36 hours with oral contrast administration. And a repeat CT can alter management in up to 3 types of mechanisms can cause bowel injuries, specifically the shearing injuries associated with rapid deceleration, and the shearing forces will be more pronounced at the location where the bowel is fixed, especially at the ligament of Treitz, at the ileocecal valve, and also at the sigmoid colon junction. The crush injuries, on the other side, will be associated with compression of the small or large bowel against any solid structures, for example, the bone structures. Usually most commonly associated with seat belt across the abdomen, and or, for example, the impact against the steering wheel or the dashboard. The burst injury, finally, are associated with an increased intraluminal pressure that will cause perforation of the bowel. And this can cause multiple perforations, sometimes called the Swiss cheese appearance. The risk factors for that, having a pre-existing ileus obstruction or inflammatory bowel disease, and these burst injuries can occur with a relatively less force than other mechanisms, and they are less likely to be associated with other injuries, for example. Not all TBMI injuries are surgically significant. For example, if you have an isolated mesenteric hematoma with stranding, or an isolated mural hematoma without any active bleeding, those are usually managed conservatively. On the other side, the significant injuries will be the full thickness bowel perforation, the complete serosomuscular tear, specific type of degloving injury of the bowel, a devascularized bowel segment, a disrupted mesentery, a mesenteric injury with secondary ischemic changes within the bowel loops, or active extravasation of contrast within the mesentery. Those are usually managed with surgery. Different signs and symptoms have been described with bowel and mesenteric injuries, and usually we characterize those as being direct or indirect signs of injuries, and we'll go through these signs one by one to show you some examples as well, and discuss a little bit more about the specificity, sensitivity of these findings on CT imaging. First of all, the direct signs of bowel injuries. If you have a discontinuous bowel wall, that's usually extremely specific, but however poorly sensitive. It's not common that we see a complete discontinuity of the bowel wall, especially because sometimes the defects are really small and usually difficult to identify on CT imaging. Free air is also considered really highly specific. But keep in mind that there's some pitfalls. You can get free air if you have a pneumothorax tracking down the abdominal level. You can be secondary to a chest tube placement, a diaphragmatic injury as well, a penetrating abdominal wall trauma. If it's because the air can come from the outside of the patient and track within the peritoneal cavity. Similarly, a rupture of the bladder with a Foley catheter in place may cause a pneumoperitoneum. Air can also be isolated to the space between the abdominal wall and the peritoneal space, which is sometimes called the pseudo-pneumoperitoneum. And keep in mind that you may not have any free air even if the bowel is perforated. For example, in case where the bowel was initially collapsed before the injury, or if it was only containing fluid in that segment. But however, if you see free air with one of these signs, being free fluid, the seatbelt sign, or a focal bowel injury, that is usually highly predictive for bowel injury. But however, again, with a relatively low sensitivity. Extravasation of oral contrast is again highly specific, but usually in the trauma setting, the CT examination will be done without oral contrast unless there's a specific clinical indicator that and the clinical team will suspect a bowel injury, because usually this will delay the initial acquisition of the examination. Let's look at this first interesting case. That's an 18-year-old female who was involved in a moderate speed MVC, but keep in mind that she had a large meal just before the accident. As you probably saw on the CT, there's a lot of free air and free fluid within the intraperitoneal cavity. And in addition, the stomach is extremely distended by a really heterogeneous content. And the content within the stomach and outside the stomach is of similar attenuation. In addition, you have a direct signs of bowel perforation, where a large gap is seen in the proximal aspect of the lesser curvature of the stomach. On surgery, the patient had a large gastric perforation that was primarily repaired. Indirect signs of bowel injury, you have to look for the bowel wall enhancement. If it's abnormal, it will usually be associated with 90% specificity for diagnosis of bowel injury. But keep in mind that the shock bowel can give you abnormal enhancement, but it's usually more diffuse within the abdomen. And look for the associated signs of a flattened IVC and abnormal increased adrenal enhancement. A second sign that has been described is the Janus sign, where you can see within a same bowel segment an area of normally enhancing and abnormally enhancing bowel loop, and such as in this example here, where the abnormal bowel wall enhancement is just close to the area of normal enhancement. For example, in this case of a 25-year-old male patient who was involved in an MVC, a lot of vascular injuries within the abdomen, with a small area of active extravasation, fat stranding as well here. And if you look on the coronal plane, you have two adjacent small bowel loops, one being abnormally hypo-enhancing compared to the normal bowel loop adjacent to it. And using dual energy CT, you can highlight this difference in attenuation or enhancement by loading up your iodine overlay maps, and you see that there's a relative lack of iodine within the involved bowel loop. And this difference in attenuation is also exaggerated at low KEV imaging, in this case 40 kV compared to the regular 120 kVp imaging normally obtained in trauma cases. For suspected bowel injuries, look also at the bowel wall thickening. Abnormal thickening has a specificity of 90% for bowel wall injury, although not really sensitive. Keep in mind these numbers, but they are relative numbers of thickness for the small bowel up to 3 millimeters and greater than 5 millimeters for the colon may be associated with injury, but there's a broad differential. Again, look to see if the involvement is more focal, which can suggest a contusion or a bowel wall hematoma, or if it's more diffuse, and in this case also keep in mind the shock bowel appearance. Free fluid, that's the most common, the most sensitive sign of bowel wall injury, present in more than 90 to 100% of the cases, but again, extremely non-specific. Important fact to remember, up to 3 to 5% of the male patients may have a small amount of simple pelvic free fluid, usually associated with the aggressive IV repletion. And you have to evaluate the amount of fluid, but also the attenuation. If it's simple, it's less concerning. If the attenuation is higher than 20, 25, 30 HU, then you're suspecting more blood in this case, which is more indicative of a bowel or mesenteric injury, if there's no other solid organ injury. In a paper published in 2013, there was a mention that even a minimal amount of free fluid can be relevant depending on the location, especially if it's in the interloop region between the bowel loops, or if it's intra versus retroperitoneal for specific bowel segments, as you probably know. Indirect signs for bowel injury, look at the mesenteric stranding, not really specific and not really sensitive as well, more intermediate in both sensitivity and specificity. And you know this sign, you just have to look for the stranding within the mesenteric fat. Keep in mind that some pre-existing medical conditions can cause stranding, such as the typical paniculitis, or prior trauma or infarction can also give you this appearance. Case number 2. Let's look at this 26-year-old female patient who was stabbed in the left anterior abdomen. In this case, you also have multiple signs of bowel injury. First of all, you have the surrounding fluid adjacent to the really thickened proximal small bowel loop, which is also distended, containing fluid and a hyperdense content, suggestive of blood in this case. In addition, you have a small focus of hyperattenuation, indicative of an area of active extravasation of contrast, and you have also a focal area of abnormal bowel wall enhancement with a transmural defect suggestive of a penetrating injury. And that was also better seen on the coronal and sagittal images, where you have your focus of active extravasation of contrast within your area of transmural bowel wall defect. Case number 3, 25-year-old male patient was stabbed in the anterior abdomen on the left side of midline. So in this case, you have your stab wound in the left anterior abdomen, where a skin defect is seen and partial herniation of a short segment of small bowel. In addition, you have on the second image an area of interloop free fluid identified by this yellow arrow. In fact, the herniated bowel loop appears relatively unremarkable, but if you look at a close-by bowel loop on the first image here, this one looks a bit more heterogeneous, and you have difficulty identifying the mucosal and mural enhancement compared to the adjacent small bowel loops. On further reformats using dual energy CT, you can confirm that there's a relative lack of iodine uptake within the affected bowel loop, and in fact you also have a small focus of extravasation of contrast shown by this red dot within the bowel lumen here, and this case was confirmed to represent a transmural injury to the small bowel loop here on surgery. So teaching points to remember: bowel injuries can be extremely subtle, so you have to pay attention to your case carefully, and sometimes it's almost impossible to identify a bowel injury on CT. Keep in mind that the bowel is a mobile organ, and the herniated bowel loop might not be the injured one. Other indirect signs of bowel injury, the associated CT findings. So if you have a chance fracture, you have a higher likelihood of having a bowel injury, especially involving the duodenum and small bowel. Having multiple organ injuries is a significant risk factor for TBMIs. For example, you can have up to 34% of bowel injury if you have more or 3 or more solid organs that are injured on the CT scan. As you may probably know, pancreatic injuries are highly associated with duodenal injuries in 20% of the cases, and having a seatbelt sign on clinical examination or even on CT, such as in this case here, has a significant likelihood of being associated with bowel injury in up to 30% of the cases. Other indirect signs, the wound track or the continuous injury sign. If you have extension of a wound track on both sides of a bowel loop with fluid on one side and or stranding on the other side, then the likelihood of the bowel loop being injured is quite high. Some less common signs have been described as well in the context of trauma, such as bowel intussusception, and it's unclear why this may be associated with trauma to the bowel loops, but proposed etiologies have been suggested, such as the associated spasm, bowel wall edema, or abnormal peristalsis. And finally, extremely rare, you may have crush compression of the appendix against the iliac crest, which can cause secondary post-traumatic appendicitis. Let's look at this case 5, 27-year-old male patient who was stabbed multiple times in the abdomen, as you can see on the CT with all the stab wounds identified with paper clips. This is a perfect example to show the relative limitations of CT in diagnosing TBMI. In this case, multiple stab wounds were noted in the right upper quadrant, although even in retrospective, absolutely no injuries were noted in the gastric wall. However, at surgery, a large gastric perforation was noted and primarily repaired. If we move on to the mesenteric injuries, we have the direct signs. If you see vascular bleeding within the mesenteric vessels, that is usually associated with a quite high specificity of injuries. Abrupt termination, of course, again, really high specificity with mesenteric injuries. However, sensitivity is quite low for both of these signs. So bleeding and complete lack of opacification of a mesenteric branch are usually better seen on the reconstructed MIP images to see the full length of the involved vessel in one plane. Active extravasation of contrast on the other side is extremely specific. If you see active extravasation of contrast, it's usually the strongest indicator of a surgically significant injury within the mesentery. On the other side, the indirect signs, having a mesenteric hematoma, quite specific, mesenteric stranding, not really specific and not really sensitive, as I said before. Pre-existing conditions such as mesenteric paniculitis can give you the same appearance. So again, not really specific for a traumatic injury to the bowel or mesentery. Free fluid, as we said, it's also extremely sensitive but not specific. And if you have secondary changes within the bowel, drained or supplied by the mesenteric region, then you have a high likelihood of having a mesenteric injury as well. Case number 7. This is a 58-year-old male patient who was involved in a high-speed MVA. So in this case, you have the perfect example of a slam dunk mesenteric injuries with mesenteric hematoma, active extravasation of contrast, and even fat stranding. The bowel loops within the involved segments are abnormal with surrounding stranding and also a mild wall thickening. And these findings are highly positive, highly significant for both the mesenteric and bowel injuries that should be managed surgically. Case number 6. This was a more trickier case. A 28-year-old male patient was involved in a work-related accident when a 350-pound block fell on his body. So this case demonstrated a few splenic lacerations with a moderate amount of complex free fluid within the abdomen, mainly surrounding the spleen, the liver, and within the paracardial gutter, also of course extending into the pelvis. However, on the initial CT report, there was no mention of any bowel injuries, but however, later on the same day, the patient was rushed to the OR for an abdominal compartment syndrome. At surgery, the trauma team found a huge laceration, transmural laceration involving the mesentery, extending from the bowel to the root of the mesentery, and that's just a surgical gas showing the through and through perforation of the mesentery here. In retrospective analysis, especially using the dual energy CT iodine overlay map, pay attention to the interloop free fluid, also retroperitoneal free fluid, and hematoma that will be shown on this examination. Looking retrospectively at this CT angiogram study of the abdomen, if you focus on the left side of the abdomen, you'll see that there's a short segment of occluded SMA branch that can be seen on the axial images, however, way better seen on the coronal MIP images, especially since it's occluded from the origin. So it's hard to follow a vessel that is occluded right from the origin. As you can see here, this small SMA branch is occluded right from the beginning and showing poor distal opacification, really asymmetric compared to the other branches, better seen on this MIP reconstructions. And just selected images of the same case here showing the occluded SMA branch, and in retrospective you could probably see that the mesenteric fat here is disrupted in two pieces with a transmural mesenteric defect here that was later on seen at surgery. So if we come back to the quiz First question was, true or false? All mesenteric and bowel injuries should be evaluated by surgery. And the answer is false. Of course, isolated bowel wall or mesenteric hematoma without any active extravasation of contrast or secondary ischemic changes within the bowel loops are usually conservatively managed. Question 2 was, what is the most sensitive sign for traumatic bowel and mesenteric injuries? And the answer was free fluid. Really common in mesenteric injuries in 90 to 100% of the cases. But again, pay attention to the density, if it's simple in attenuation or if it's hemorrhagic in attenuation, and also the location. Interloop free fluid is way more sensitive than dependent pelvic free fluid for mesenteric injuries. Question number 3, which injuries can happen with the lowest force level? You remember that it's the burst injuries with associated less forces needed to injure the bowel compared to the other cross shear or tensile injuries. Question number 4, true or false? Free fluid should normally never be seen in male patients. It's false. It can be seen in up to 3 to 5% of the male patients, secondary to the aggressive IV hydration. Keep in mind again the density and the location of the fluid. Usually the fluid should be seen within the pelvis and not, for example, in the interloop space. And last question, which one is not a risk factor for traumatic bowel and mesenteric injuries? And the answer was the vertebral wedge fracture. It's more the chance fracture that is a risk factor for bowel injuries. But all the other ones, the having multiple solid organ injuries, pancreatic laceration, pre-existing IBD, such as Crohn's disease, and the seatbelt sign will all be associated with TBMI. So in summary, TBMI can be very subtle on CT, sometimes impossible to diagnose if you remember the case of gastric perforation after stabbing injuries. Also, the herniated bowel loop might not be the injured one, so pay attention to the nearby bowel loops. Pneumoperitoneum is not specific to bowel injuries. Keep in mind some differential diagnosis. Specific injuries are associated with TBMI. Evaluation of the mesenteric branches on CT is essential, and use the coronal, MPR, and MIPME formats to evaluate for vascular injuries. Thank you very much for your attention. I hope you appreciated the lecture.
Good afternoon, everybody. I'd like to welcome you to the next session of our APDR National Virtual Noon Conference. My name is Dr. Hart Beatty. I chair the Education Committee for the APDR, and I'm also the Neuroradiology Fellowship Director at Boston Medical Center. I'd like to welcome 2 amazing speakers again today for our series, and we're so grateful for them taking the time to give the talks. A couple housekeeping items that we always go through. I'd like to remind everybody that the webinar is being recorded, and all the questions and comments would be recorded as well. The webinar attendee microphones have been muted to ensure optimal quality for all the participants. If you do have questions for the presenters, we urge that you use the question and answer tool in the Zoom platform, and our presenters will try to get to those questions either during or after their talks. If not, we can send them the questions on email, and they'll try to get to you there. As a reminder, the lectures are being recorded and posted on the APDR YouTube channel to be viewed on demand at any time for free. So please enjoy those at your leisure. Our 2 speakers for today, Tuesday, April 28th, are Dr. Gary Danton from the University of Miami. Dr. Danton is the Associate Professor of Clinical Radiology and the Program Director of the Radiology Residency in Miami. His topic is traumatic diaphragmatic injury. And we also have Dr. Adam Flanders from Jefferson University, Professor of Radiology and the Co-Director of Neuroradiology NT. And Dr. Flanders at 12:30 will be speaking on spinal trauma, fact and fallacies. So without further ado, I'd like to welcome Dr. Danton from Miami. And I'll stop sharing my screen and ask if you could take over the presentation.
Hello, everybody. So I'm going to be talking about traumatic diaphragmatic injury. And I'm down in University of Miami and Jackson Memorial Hospital and Ryder Trauma Center. So we get a lot of trauma down south. And I hope all of you are doing well. Let me see if this can advance. Okay, no disclosures. All right, so what is really important about diaphragmatic injury in the setting of trauma? Well, the most important thing is that you look for them. And the reason that you have to look for them is because they are very easy to miss. So we're going to talk initially about the why, when, and how do you find a diaphragmatic injury. So why look for them? Well, you have to look for them, as I said, because they're hard to see. You have to look for them because if the patient is intubated and on a ventilator, the ventilator can trick you and hide them. And you need to look for them because they can have a delayed presentation. So if you miss them, the patient can show up 2 to 3 years later with strangulation from a diaphragmatic hernia, which carries a pretty significant mortality. So why else? Well, patients are more frequently being selected for non-operative management in the setting of trauma, but many of these patients will have an occult diaphragmatic injury. And the surgeon may opt for operative management if you detect that occult diaphragmatic injury. So there have been some studies that looked at diaphragmatic injury and shown that in patients who were initially non-operative but had significant enough trauma to become operative, about 20% had injury. Now granted, if they went from non-operative to operative, they had significant trauma. But still, that's a fairly high percentage that actually had diaphragmatic injury. In patients with stab wounds, about 7% of stab wounds to the thoracoabdominal region had diaphragmatic injuries, most of which are on the more commonly on the left side of the abdomen. About 17%, I think, were on the right side. So when do you look for them? You look for them in cases of severe blunt abdominal trauma, and in cases of penetrating a trauma to that thoracoabdominal region, where you have basically the nipple line to about L1. All right, now how do you find them? So the way I like to think about signs of diaphragmatic injury is I break it down into signs where the diaphragm itself is injured, signs, secondary type signs where you're looking at the herniation itself. So these are hernia related signs. And then you have signs where you're looking at the injury pattern. So for diaphragm injuries, you have segmental defects. So you actually see like a hole or defect in the diaphragm. You may see thickening of the diaphragm. And we'll show you the dangling diaphragm sign, where you kind of see the diaphragm just flopping around in the abdomen. Then your hernia-related signs include the collar sign, which is most commonly seen around the liver. For the collar sign, it's usually around hollow viscus, where the diaphragm is squeezing the viscus. And so you get this kind of collar appearance. Then there's the dependent viscera sign, which we'll talk about in a few slides. And then the hump sign and band sign are related to the liver. Then there's signs where you look at the injury. The contiguous injury sign, you're essentially looking for injury above and below the diaphragm. Now, this was classically described in the setting of penetrating trauma. So if you have injury above the diaphragm and you have injury below the diaphragm, well, there's a good bet that if there's one injury, that diaphragm is injured. And then you can do a tractography, which can be very complex or can be very simple, but it's essentially it essentially reflects the importance of following the trajectory of a projectile or a stab wound from its origin in the skin to where that ends up. And then if you follow that, you can look for injuries of multiple organs, including the diaphragm. So I'm going to talk a little bit about sensitivity specificity. I'm not big on memorizing numbers. So if I say that something is high, I'm talking about like 75 to 90%. If I talk about low, 25 to 50%, very low, less than 25%. And we'll talk about that with respect to some of these signs. Okay, so now we're going to look at a few examples, and then we're going to look at a few cases. All right, so here's an example of a segmental defect. And I will say in most injuries, you're going to see multiple signs. But of course, you only need one necessarily. So if you look at where the arrow is, you see a little bit of a thickened diaphragm over here, and then there's a defect in the diaphragm. So you have that hole, and we have some herniation of mesenteric fat. So that is a segmental defect. The dangling diaphragm is when you have a little bit of thickening of the diaphragm. It's usually around the cruce, and it just, here it is, and it just kind of hangs out, and you don't see continuity. So you usually have a segmental defect, but you kind of have a little piece of diaphragm dangling. The collar sign is when you have, here you have some viscus that is herniated through this defect in the diaphragm, and you have the squeezing of the viscus. Now the sensitivity is relatively low. You don't always see a herniation, but if you see it, you know that there's a very high chance that there's a diaphragm defect. The dependent viscera sign is a little tough. So ordinarily, you will have some lung interposed between the ribs and any abdominal contents. When you're high enough at that thoracoabdominal region where you have the lungs showing on images. So here's an example of a normal. So this is how it should normally look. And then here again is the dependent viscera sign, where the viscera is just opposed to the ribs. So there are some findings that can confuse you. And they can be hiatal hernias, which can give you the appearance of an injury. You have Morgagni hernias. And if the patient is missing a spleen, sometimes it can look like you have a dependent viscera sign, even though it's really not. And this is normal up here on the top left. You have patients who have chronic diaphragmatic hernias. And so this patient has a huge hernia, but it was chronic, so they're not always traumatic. And then of course, your classic Botchdalek hernia. Okay, the hum sign and the band sign reflect the changes in the liver as the liver herniates up through the diaphragm. And the hum sign is just the appearance of the liver herniating up above the diaphragm, where you get this kind of big hump to it. The band sign is a little bit tough, and you really don't see it all that often, but when the liver is getting squeezed, you can have a change in the attenuation of the liver at the level where the diaphragm is squeezing it. It's kind of like a collar sign for the liver. And the hum sign, I would say, has a medium to good sensitivity. The band sign, the sensitivity is very low. For the contiguous injury sign, again, this was initially described in the setting of penetrating trauma, and it has a fairly high sensitivity, a surprisingly high sensitivity. If there is one penetrating injury, then it has a high specificity as well. But if you have multiple penetrating injuries, then you lose some specificity. So here you have a bullet tract through the soft tissues, and then you can actually follow it go between the ribs into the abdomen. You have some hematoma underneath the diaphragm, and so here you have a contiguous injury above and below the diaphragm, and the diaphragm was injured in this patient. Just one thing I'll mention, about bullet injuries is in the body, bullets do not travel in straight lines. They can curve within tissues. They can bounce off of bone. So you can't necessarily just look at the skin entrance and then where the bullet is and draw a line between them. You have to kind of follow bubbles of air and hematoma, look for fractures, look for subtle injuries to figure out the path. And this was really tough because it went straight down the skin and then hooked a turn into the diaphragm. So for trajectography, you do look at the origin of where the projectile went in, and you follow it to a structure, and then you follow it to the next structure. And you can do this using oblique MPRs, or you can just follow it along the path, looking at again little bubbles of air and hematoma. Okay, so your sensitivity will be higher on left-sided injuries. It's harder to see injuries on the right side because of the liver. All right, so we're gonna go through some cases. So here's a patient with a gunshot wound, and it started in the chest, and you can see all of this contusion and hematoma, and it followed into the abdomen. And again, you can see, so you have a contiguous injury sign. Here you have that segmental defect. You have the mesentery herniating up, and you kind of create like a collar sign. It's usually used for hollow viscus, but I'm going to use it for the mesentery in this case. And then you have some diaphragmatic thickening. So all of these signs showing you that diaphragmatic injury. So, you know, the mesentery I'm counting as this organ for the sake of the collar sign. All right, next case, stab wound. So here you have some air within the subcutaneous tissues, and then we have a fracture. And look at this little fracture fragment off the rib has just barely penetrated the diaphragm. And so we have a segmental defect. You might say, who cares? It's so small. What difference does it make? Well, this was mentioned on the radiology report back in 2010, and this is what the patient looked like. And then the patient comes back a year later, and you can see there's no lung markings. It's an abdominal study, so I don't have the whole chest, but there's no lung markings here. This is all colon that had herniated through the diaphragm defect as it grew. So this is one important thing about diaphragm defects. They don't get smaller, they get bigger. They get worse. And that's why you have to find them. So he came in with a surgically confirmed colonic obstruction. All right, next case. Here's a patient with blunt trauma after a motor vehicle accident. Initially on the x-ray, we suspected a traumatic injury because the patient had some pretty significant blunt abdominal trauma. And let's take a look at some of the CT images. And so here you can see the viscus herniating through. Here's the diaphragm, right? So this gives you a dangling diaphragm sign. As the viscus kind of gets narrowed as it passes through here, that gives you a collar sign. The diaphragm is a bit thickened, and we can see the segmental defect. So here in this one image, you know, or two images, you have the collar sign, the dangling diaphragm sign, thickening of the diaphragm, and your segmental defect, showing you this traumatic diaphragmatic injury. All right, we'll look at a case with multiple gunshot wounds. So again, with multiple gunshot wounds, the trajectory and the contiguous injury signs are going to be difficult to use because you don't know if one bullet went in the abdomen and one bullet went in the chest. So, but here on this image, here you have the stomach. So you have hollow viscus layering along the ribs. And so here you have the dependent viscera sign. So here you have air, here you have that hollow viscus, as we scroll down, dependent viscera sign. And then you get to see where the stomach is herniating through this defect. So we have a segmental injury and a pretty significant collar sign in the stomach. You can see how the stomach gets narrowed pretty significantly as you pass through the defect in the diaphragm. Okay. Next case, 82-year-old woman with presents with pain, which is the most common indication in our trauma center. They don't give you much history, and we see this large air-filled structure on the chest x-ray, and we're thinking, oh, traumatic diaphragm injury. And you get the CT scan, and okay, we're saying dependent viscera sign, so we're feeling pretty good. But then we notice that you see this beaking of the stomach going right through the esophageal hiatus. And you can follow it down, and turns out this is just a paraesophageal hernia. So the actual history was an 82-year-old who just slipped out of her wheelchair. So an example of how you can get fooled, and the history really helps you. And also looking to see where that hernia is coming from. All right, next case. You have a patient with blunt abdominal trauma. And as you're going through the coronals, you can see the liver pooching up above the diaphragm. Right, this is our hump sign, maybe a collar sign, and this kind of pooching upwards is what you're looking for, again, with the hump sign. And you're really paying attention to patients who had pretty significant blunt abdominal trauma to give you a rupture on the right side. Next case. Patient with a motorcycle accident. So we have bilateral pneumothoraces, lung contusions. We're going to have some hemothorax and some atelectasis. Okay. Again, we have our pneumothoraces, so we have some pretty significant trauma. And again, so we know we have trauma above the diaphragm, and we have trauma below the diaphragm, right? So we have some liver injury. Now this isn't blunt abdominal trauma. And the contiguous injury sign, so injury above and below the diaphragm, was classically described in penetrating trauma. But we suspected, on the basis of these injuries and the accompanying fractures, that there may be a diaphragmatic injury. Difficult to call, but we suspected it. So they took the patient to the OR, and they ran the bowel, which was negative. They found some mesenteric hematoma, duodenal hematoma, but they did not check for a diaphragmatic injury. So this was the patient shortly after surgery. You can see all the lung injury, but the diaphragm looks pretty good. Patient, getting better. Everything looks fine. Patient intubated. And then what happened? So here is August 1st, and then on the left is August 2nd, so 1 day later. And something is different about these images. And if you look at the diaphragm, you'll see that the right diaphragm on the second is much more elevated when compared to the first. And so what's the difference? What happened? Well, he was extubated, tracheostomy. There's no longer positive pressure from the endotracheal tube. And he stayed that way, multiple x-rays. We just have this elevation appearance of the right diaphragm. Patient continued to feel a bit short of breath. And a chest x-ray kept noting this right basilar opacity, so they did a CT. You see the liver looks pretty high up to, some, and then we'll take a look at the coronal. So nothing was noted, but the patient ended up coming back, and we'll see those images soon. So nothing was noted on this exam, which was a month later while the patient was still being treated. But you can see while they're intubated, here's where the position of the liver is, then extubated, look at that liver. That is a hump sign, right? Here's the liver, hump sign, okay? And here's 4 years later, all right? The exam from 2012 versus the exam from 2016. And it wasn't picked up, the difference wasn't picked up on those initial scans. It wasn't realized. And more of the liver, including some other organs, you can see were herniating gradually up into that right chest. And look at the size of this diaphragm defect. You have this huge segmental defect containing now not just liver, but viscous and mesentery as well. So again, diaphragm injuries get worse. They get bigger, you get more herniations. That's why you have to find them. All right, case 8. Patient has a history of an old traumatic diaphragm injury. This is a 90-year-old patient who was transferred to us. So not too surprising, she's got viscous and mesentery above the diaphragm. That was part of the history. That was from her prior injury, so we knew about that. You look on the sagittal, a lot of viscous above the diaphragm. So this was on the same day. So at 6:50 a.m., this is how her chest x-ray looked. And then by 8:10 a.m., looked much better, much better. Well, what happened? They didn't repair her diaphragmatic injury. What did they do? Well, they intubated her. So now you have positive pressure ventilation. So everything, I mean, she still has, some hernia. You can see the gastric decompression tube above the diaphragm. She's intubated. Doesn't look too bad, right? 111. She's getting better from her more recent injury. 115, they started decreasing the positive pressure to get ready to extubate her. So they're weaning her off the vent. What's happening? Well, now you see the viscous coming back. Then finally, she's extubated. And look how high that diaphragmatic hernia is, right? You have the feeding tube in the stomach all the way filling that left side of the chest. So then they realized they needed to go in and repair that, which they did, and patient did fine. But now you have post-op repair. She's intubated. Everything looks good. The stomach was incarcerated, but everything else pulled successfully down into the abdomen. The defect in this patient was 20 by 15 centimeters, so pretty sizable defect. 1 week later, patient is extubated and everything stays down, which is good. Okay, so here's another next case with a gunshot wound where you have the help of using the trajectory and the contiguous injury sign to your advantage. So we know the patient was shot up here in the axilla, but you see the bullet below the abdomen. He was shot once. So pretty much had to go through the diaphragm. And if you follow the pathway of the lung contusions and the fractures, as you follow it down, you basically go right through the lung, through the abdomen, into the spleen, and you have to have injury to the diaphragm. So by using the trajectory, you can tell where the bullet has passed through, and that there must be a diaphragm injury. And you don't have to question it, because the surgeons need to go in and confirm it. They have to do surgery to figure out if there's a diaphragm injury and repair it. Case 10, stab wound. Here's another example. So you're going to use the trajectory, right? So here's the defect in the skin. Here's the defect, goes right up to that rib. You have still more air there. Another rib fragment. This is different from that last case that I showed you. So this is a similar case with a little fragment off of the rib showing you, in this case, where the defect is, which was probably made from the knife itself. And then you have this segmental defect of the diaphragm with herniation of fat through the diaphragm and under the rib. So in conclusion, I would say most important in your trauma patients is remember to look for these injuries. We went through a bunch of signs, and hopefully by practicing them a few times now, you'll remember them. You gotta look for the diaphragm injuries because they don't get better, they get worse. And the patients represent with complications up to a year, 2 years, even 3 years later. So with that, I'm going to turn it back to Harp so we can welcome the next speaker.
Hello, everybody. First, I want to thank Harp and the APDR for the invitation here. Did you notice there's 641 people watching this? This is pretty cool. This is the biggest audience I think I've ever had. So I want to continue the discussion about trauma, but I want to focus on the spine, and I particularly want to focus on MRI of the spine. So my whole talk here is about concepts and controversies because, you know, I've got an axe to grind here. So I have no disclosures, but this is what we want to kind of talk about, or this is what I would like to talk about now, is a little bit about why do we use MRI in spine trauma? Are we using it correctly? Are there things that MRI is really good for? And so what are the controversial things about it? And we'll focus on spinal cord injury because obviously that's the most important reason why we do MRI and why it's good for the neurologic exam. So why do we do this stuff to begin with? You know, well, why use it in spinal cord injury? Well, it does offer the most comprehensive evaluation of injury and spinal cord injury because it depicts the soft tissue component. That's a thing that we can't see on radiography or on CT as well. There's a lot of centers where the clinical evaluation is not complete without an MRI study. That is, if there's a clinical deficit, and it's really kind of changed our focus from the spine to the spinal cord. And most people around the world would agree, do an MRI in the acute period for any patient with a persistent neurologic deficit, a real neurologic deficit, that is spinal cord dysfunction. So we're all familiar with these kind of algorithms, you know, that are out there. You know, there's this, you know, that a lot of papers have been written about this. What's the best approach for doing these sorts of things? And, you know, what, you know, follow this arrow if this happens, and do this if that happens. I don't really know if anybody follows any of these guidelines. A lot of hospitals have them. They have them in their pathways and guidelines in their hospitals, but a lot of it is just kind of done shooting from the hip. So the previous approach was, you know, we would do an emergent MRI for patients with post-traumatic myelopathy, not somebody who had a little bit of numbness in their finger after a car accident, but actually had true myelopathy, true dysfunction of the spinal cord. You know, for patients that are obtunded, they were not examinable. Some of them would get a cervical collar and then get re-examined. Sometimes in the old days, they used to do flexion extension, even in obtunded patients. That's pretty old school. And we've all heard about these prediction rules, like the Nexus, you know, the National Emergency X-ray Utilization Study from 2000, a lot of patients, 34,000 patients, and the Canadian Cervical Study Group had about 8,000 patients. And they all kind of came up with the same conclusions about, you know, when you should do any kind of imaging, including radiography for spine trauma. So according to the Nexus, low risk criteria, okay, C-spine radiography is indicated for trauma patients unless they exhibit all of the following criteria: no tenderness, no intoxication, normal alertness, normal focal deficit, no focal neurologic deficit, and no painful distracting injury. Well, I can tell you here in good old Philadelphia, hardly anybody who comes in our emergency room meets this criteria because, you know, people are doing this kind of stuff, acting a fool. By the way, this is from, the good old Super Bowl win for the Philadelphia Eagles. And there were a lot of people doing this kind of activity. And I can guarantee you the mobs of people that you can see on the street, every one of them is intoxicated. So none of them would have fulfilled nexus criteria. So if you look at the appropriate use criteria, they kind of mimic a lot what's written in the Canadian and Nexus rules to begin with. But they do agree you should do multi-detector CT with sagittal coronal reconstructions. It's the best screening procedure right now in adults with high-risk criteria. The entire spine should be examined with CT, and you can even derive them from thoracic, lumbar, and pelvic CT, so you don't have to rescan people. Radiography is still the imaging method of choice in children, and flexion extension radiography is a waste of time. So our surgical colleagues, the Eastern Association for Surgery and Trauma, they recommend that they say there's just 4 categories of spine trauma patients. There's the alert, awake, non-intoxicated, normal neuro. They certainly don't occur here in southeastern Pennsylvania. We have patients who are alert, awake, complain of neck pain, and we have patients with neurologic deficits that might be related to spine trauma. And then there's a 4th category, mental status obtunded, and may return to normal mental status not anticipated for greater than 2 days. And really, out of those 4 categories, the only one that they actually recommend that you should do MRI on is number 3, neurologic deficits related to spinal cord injury, not even for number 4. So what are we talking about here? We're talking about an awake patient versus an obtunded patient. The first patient you're looking at here, this person has been in a car accident, but he's alert, he can follow commands, he can answer questions. This patient cannot. Should we be using MRI for the second patient? Does that answer all the things we need to know? Because we can't do a good physical examination on these folks. So the conditional recommendations are in obtunded adult plyometricians patients, they conditionally recommend taking off a cervical collar after a negative CT exam, but don't recommend doing an MRI. So I can tell you, so why do we do MRI, and why does it seem like we seem to do a lot more MRI than we've ever done before? What's really the problem here? What's going on, or is there a problem? Well, if you look at some of the CMS data right now for outpatient utilization for MRIs across the country, you can see it's kind of flattened out. If you look at inpatient utilization, it's kind of decreased and flattened out. But if you look at utilization of MRI in the emergency room setting, it has continued to rise over the last 12 years, almost to the tune of 4 times. And these are the things that, the Deficit Reduction Act, these are the things that has put radiology in the crosshair with PAMA and so forth. People are looking at us and saying, hey man, what are you guys doing about this overutilization without any potentially a proven benefit in the literature? So I want to focus a little bit about this. So does MRI provide any complementary or supplemental information in spinal injury? And I want to kind of go through the spectrum of injuries that exist out there, what's true and might not be true about all of this. And recognizing that this was kind of a broad spectrum of injuries, the most important thing that we can see, and the only modality where we can actually see a spinal cord injury on imaging, is on MRI. So for fractures, it's really not the most cost-effective way for looking for fractures. We know CT is so much better for this, and yet people still, and sometimes in the reports, and I certainly tell the residents frequently, your pertinent negative in reading an MRI is not to say no fracture or no evidence of fracture is seen. That's not what we do it for. But certainly if you have a rip-roaring fracture like this L5 burst fracture where you can see disruption of the superior end plates, yeah, you can see it. But I guarantee you a 25-cent radiograph might have shown you the exact same thing. And granted, while you can see the fracture line, the split sagittal fracture in the cervical vertebra here, you cannot see the fractures of the posterior elements at all on MRI. So in fact, MRI is notoriously bad for looking at posterior element fractures. But what MRI really shines about is for compressive injuries, compressive marrow injuries to the trabecula where there's been axial loading to the bone. These are things that you may not see. They're relatively subtle on CT, but they show up really great on MRI. And you get this characteristic low signal on T1, hyperintensity on T2. You may not be treating any of this because there may not be mechanical failure of the vertebral body, but you can certainly see that there's been multiple axial loading injuries to multiple adjacent vertebral bodies in addition to this burst injury here at L1. How about here? This is a young woman that was in a motor vehicle accident, has searing neck pain, and sure enough, she has these striations in her vertebral bodies from a hyperflexion type injury. More to come. So this is one of those things, an added benefit we get with MRI, and certainly for all the people that we see that have osteopenia, osteoporosis, develop multiple insufficiency fractures over time. MRI will show you the acute fracture here. You'll see it healed 3 months later. Meanwhile, 2 more fractures have developed, and you can see them. You can see them great because you can see the reversion of the marrow changes going on and so forth. So I'd say, you know, MRI has some supplemental benefit for fractures, but it's not really the primary reason why we do MRI to begin with. And we know disc herniation is the prototypical, you know, soft tissue abnormality that we see, and that's what MRI is really designed to detect. And it really kind of exceeds all other abnormalities. And the incidence of disc injury is relatively high in high-speed motor vehicle accidents, but not necessarily traumatic disc herniations as often. And so here's an example of someone with a disc herniation with some epidural hematoma. You can see the disc herniation really nicely on the MRI, and you know, it kind of stands out against the hematoma, but this one's where it's so large that you can actually see it even on the good old-fashioned CT scan. But this is what I mean by disc injury. This is somebody who had a hyperextension type injury, widening, an open book type of injury to this C5-6 interspace. And what ends up happening is you end up macerating the disc, and the disc, the lacerations inside the disc, if you will, fill with fluid, and that disc ends up being brighter than any of the other ones. So if you see somebody with a really degenerated spine who's had trauma and one of the discs is brighter than all the others, take a little time to scrutinize it a little bit because it might have been injured at that level. If you have a CT, go back and look at the CT again and see, could you see a little avulsion of an end plate? Can you know, is there a little bit of soft tissue edema? This one is not too hard to see, this big prevertebral injury here in the front in this other case that also has a hyperextension injury. So I think it's fair to say MRI's got a lot of value for traumatic injury of the disc and disc herniation. How about for looking at vascular injury, vertebral artery injury? It actually occurs relatively frequent, with a fair amount of frequency in cervical injury. And back in the day, you could say, well, if you're doing MRI anyhow, you could just do an MRA as well to see if somebody lost their vertebral artery. Here's somebody who has a flexion teardrop fracture of C5, a bad spinal cord injury, and whoops, lo and behold, lost their dear friend, Mr. Right vertebral artery in cross section on the axial T2s. You can see a nice flow void on the left. On the right, we've got light bulb on, light bulb off. This is clot sitting in the foramen transversarium. And there's been some series written about this that say it's actually more frequent than you might think. This is a whole series of over 600 patients, just spinal injured and spinal cord injured patients, finding that losing a vertebral artery could happen more often when you had spinal cord injury, but in patients that had minor injuries, or even patients that had no injury at all, 11% of them lost a vertebral artery, but had no clinical consequences of it. So the moral of the story was absence of a spinal cord injury does not exclude loss of a vertebral artery. The best way to evaluate for this, there has been a debate. There was previously a debate: is CTA better than MRA? Is MRA better because, you know, or black blood techniques? But the fact of the matter is everybody's favorite toy in the emergency departments today is CTA. So I'd say, you know, CTA is getting done with much more frequency than MRA or black blood techniques, just because of the era of convenience, and everybody is used to doing it. The consequences of this is up in the air. There's been some literature that say up to half of the patients that lose a vertebral artery as a result of trauma will suffer a serious posterior circulation stroke. But the lower limit of this is less than 1%. So it's hard to know. It really depends on what series you're looking at and who you've been talking to. Here's an example of someone. This is an unfortunate father who was trying to teach his son how to skateboard, and you can see this dislocation here at C23. This is one of the worst I've ever seen. So here's the dislocation at C23, a lot of prevertebral edema here. If you look in cross-section on the T2s, 2 light bulbs here, both vertebral arteries are clotted off here from this dislocation. They relocated him in the operating theater. You could see the edema in the spinal cord took off. And of course, he was already a high cervical injury. He then became obtunded. And when you look here on the CTA that was done afterwards, there's a clot floating inside of his right vertebral artery. So basically restoring alignment to the spine, restored flow in the vertebral arteries. There was clot in the vertebral arteries and it sent it skyward up into the brain. And unfortunately, he did not survive. So the value for MRI for detecting clinically significant vascular injury and spine trauma is probably pretty good, but probably not used as much. Up to 40% of patients will have extraaxial epidural hematomas associated with their spine trauma. Most of the time, particularly because the epidural space is freely communicating, the hematoma will disperse itself up and down longitudinally in the spinal canal, and you don't see a whole lot of consequence as a result. But loculations can lead to focal compression. Here's a few examples of ones of, here's somebody with ankylosing spondylitis with a huge posterior epidural hematoma. Here's somebody who was on anticoagulation who fell and had a big posterior epidural hematoma and also a fluid collection. And here's just a garden variety fall with a huge hematoma ventrally from the thoracolumbar junction on down. And this patient had no consequences neurologically. Here's another patient with no consequences neurologically because the cauda equina is extremely tolerant to compression. So here's a very long hematoma running the full length of the lumbar spinal canal, causing compression of the thecal sac with no issues. Here's another patient with a large loculated hematoma in the posterior epidural space of the cervical canal, which you can almost see better on the CT than you can on the MRI. Interestingly enough, here on the cross section on the CT, it shows up a lot better. This patient required urgent decompression because it was MASH in the spinal cord. Here's another focal one that did not track up and down very well, compress the spinal cord, also required evacuation. Speaking of fluid collections, one of the other things you can see after trauma, particularly after traction injuries, is that you can get nerve root avulsions, and you'll see one of the things to look for in heavily T2 weighted sequences is epidural fluid elevating the dura away from the ligamentum flavum or the bony landmarks, because this may imply that there's been a root avulsion or a tear to the dura that's actually causing the CSF to leak out. And here's a nice nerve root avulsion here of C6. So MRI is pretty good for, this is pretty the sine qua non for looking for traumatic epidural connections. So this is what I want to spend some time on, because this is where I got some beefs. Ligamentous disruption on MRI. And so let's spend a little time about this. And I think it's true, MRI is probably the only modality that really demonstrates either discontinuity of the ligament, fissuring of the ligament, or maybe edema of the tissues around the ligament. But the real question is this thing down here. When does it mean, what we see, when does it actually reflect spinal instability, either acute or delay, and when is fixation required? So when you see something like this, where you see the split end of the ligamentum flavum right out here in front of the spinous process, you're right, this is a torn ligamentum flavum. I agree, we can see it, and it may be helpful, and you can see all the edema in the posterior paraspinal muscles. What does this mean regarding treatment? Here's an even crazier case, but you could see this on a 25-cent lateral radiograph, someone with a cervical thoracic dislocation where you can see the free edges of the anterior longitudinal ligament and the torn edges of the annulus fibrosus dangling in the breeze, as well as the ligamentum flavum floating around back here. Everybody knows this is an unstable injury, but you'd know it was an unstable injury from a cervical radiograph. Here's an unfortunate kid who was injured during a wrestling practice with a dislocation at C3-4, a big dollop of disc material compressing the spinal cord ventrally, the whole posterior ligamentous complex disrupted posteriorly, but the angulation and everything that you could see here on a lateral radiograph would tell you that this is bad news. And here's another example of somebody with a unilateral interfacetal dislocation, which is supposed to be the mechanism of injury is not only hyperflexion, but it's also rotation. And MRI is helpful in showing us, and also the disc is destroyed because you rotate one vertebral body on top of the other. So the disc loses its own integrity. And you can see all of those features are represented. Here's your jump facet. Here's the inverted hamburger here on the right side here for those that believe in hamburgers. And here's the disruption of the posterior ligament, the posterior soft tissues, and there's the damaged disc, some of it leaking out here in the front. So all of that is proven. Here's someone again with a big dislocation at the thoracolumbar junction, an oldie but a goodie. This one has all the free edges of all of the structures, the ALL, the inner and outer fibers of the annulus all just dangling in the breeze, and the horribly compressed thecal sac and spinal cord. Here's just yet one more extension type injury here, a double extension type injury where the fissuring of the disc occurs, but undoubtedly the interlongitudinal ligament is split here as well because there's just a big wide gap here and a lot of prevertebral fluid. So what does this mean in terms of instability? So what are the significance of soft tissue? And so here's your 25-cent lateral radiograph, and what's going on with this patient here. And the hint is, of course, this patient is a little bit taller today than he was yesterday because his head is actually floating way above C1 and C2. And this is a guy with a complete craniocervical disassociation. Do you need an MRI for something like this? You know, it's pretty clear on the X-ray and then on the CT that there's, 8 feet of space between the head and the neck. Probably not. This is really great for demonstrating the total circumferential disruption of the soft tissues that you'd expect anyhow with MRI. Here's that woman we saw before who had the searing neck pain. Remember, we were talking about the striations of her vertebral body from axial loading, but look what's happened to her posterior soft tissues. This is not bad fat suppression. This is signal in the back of her interspinous ligaments. So what does this actually mean in terms of ligamentous instability? Does this mean this patient needs to get 8 feet of titanium put inside of her neck, or is this something that will heal on its own? Here's one of those classics that people ask about. In fact, Harp was asking me about one of these just the other day. Here's a rotatory injury of C1-2. There's a patient who could not straighten his neck out after an injury at a basketball game, clearly has asymmetry in his dens. Figure this is a classic soft tissue injury that can be solved with MRI. Hyper-rotated between C1-2, rotatory subluxation, C1-2. MRI is clearly going to be horrible. And sure enough, we do the MRI and the ligaments are really quiet. There's not much going on here at all. So MRI seems to have let us down. And here's an example, of course, where MRI is really helpful, although I would advocate you could actually figure this all out on a CT scan. This is a patient who got drunk, fell down a flight of stairs while walking home, started getting weak, woke up the next day, and he was paraplegic. And all of his studies were read as normal. But the important thing is, and this is what I always advocate to everyone I know, don't forget to check the soft tissues on your CT scan. If you look at the soft tissues, there's all kinds of trouble going on back here. You don't see any of the normal striation of muscle or any of the fat and tissue planes very well here because there's been a horrible soft tissue injury here. So this patient has had a pure hyperflexion, a non-osseous hyperflexion injury, an unstable hyperflexion injury, and he was actually banging into his spinal cord when he was walking home because he was just subluxing while he was walking. But you can see all the disruption posterior here, interspinous ligament, and even the intervertebral disc space didn't affect any of the bones at all. So always check the bones. Is there surgical proof for this? Well, there's been a series of articles. This one was touted for a number of years, but this one would kind of, which I'd say has fallen out of favor for things like this, where they did actually a little more, I would say a little more aggressive evaluation. In this case, cervical MRI findings of ligamentous injury in a small group of patients, multiple readers, then checked to see if the ligaments were messed up in the operating room. And what they found was agreement between readers was very low and inconsistent, which was problematic, even though they thought they were seeing things. But their conclusion was, based on results, some caution should be used in relying on MRI for preoperative planning, as it can falsely overestimate the degree of soft tissue injury. And there's a lot of studies out there that would say, that is probably true, that you don't need to do MRI for this kind of stuff. Here's a prospective study, 100 whiplash patients scanned at 1.5 Tesla 48 hours after MVA, looking to see if you could find abnormalities in these proven clinically whiplash patients from other patients, normal controls and whatever else. And their conclusion was, in all but the most severe grades, MRI findings were similar in both groups of patients. So we didn't write a lot of this literature that says MRI, it may not be helpful. Here's one from Archives of Surgery. Over close to 3,000 patients, 100 of the patients had cervical injuries. And what they say is that the sensitivity of multi-detector CT for important findings, 99%, specificity, 100%, risk of missing an injury, 0.04%. It's pretty, it's pretty daunting. Multi-detector CT is really, really good. And their conclusion is that you do not need anything else after you get a normal CT result. And there's more. Here's Journal of Trauma, 2007. blunt trauma patients receiving MRI. 6 of the patients uncovered occult injuries like microfractures, interspinous ligamentous injury, cord signal abnormality, and even epidural hematomas. But yet none of these findings changed management or even required use of a cervical collar. And yet 6 of those patients had cervical collar complications. So their conclusion was, hey, MRI could be completely unnecessary if a CT is negative, and it can decrease costs and lead to early collar removal. And the real stinking truth here is that these fashion accessories are not so benign after all. There's a whole body of literature that says this causes skin ulceration, maceration, decubiti, exacerbates intracranial hypertension, interferes with swallowing mechanisms, creates difficulty with intubation. When we say there's something wrong in somebody's neck, it could potentially keep somebody in a collar longer, keep somebody in a unit longer, or whatever else. And people have worked this out. They've worked out the economics and have basically said early collar removal and foregoing an MRI can offer the lowest risk strategy for comatose patients with a negative CT and no positive, although I don't know how they figured out the positive neurologic findings if the patient is already comatose. But people have already figured out it can cost a lot of money just to detect an occult instability, and 1 in 1,000 patient can cost several $1 million to begin with. There's hidden costs for keeping people on a ventilator in an ICU when they may not need to, because they're waiting for an MRI for some kind of clearance or whatever else. And so basically, this was one of the best articles ever done. This one was done Journal of Neurosurgery, 14,000 meta-analysis from 17 studies basically said sensitivity and specificity for multi-detector CT exceeded 99.9% overall, you know? And there was no validated path description for acute unstable injury in the absence of bony injury and neurologic correlates. So they concluded, strongly suggests you can remove a collar in an obtunded or intubated patient if the MDCT is negative. They predicted 1 false negative multi-detector CT study every 14 years in a typical trauma center, compared to up to 67% of cervical collar complication rates. So during those same 14 years, up to 32 patients could have a complication just from prolonged use of a cervical collar. So that's really the dilemma. Up to 25% of all comers will have soft tissue abnormalities on their MRI, and we don't really know how to equate that with instability and management decisions. So we should always approach that with a little bit of caution. So while it could be great, it can also be fraught with problems. So I just want to spend the last couple of minutes talking about spinal cord injury and what we use MRI for that. Injuries is still a big problem in the United States, still peaks in the summers and weekends, although with the advent of really good quality safety harnesses and airbags and so forth, a lot of this has decreased, but it's still, US expenditure is about $6 billion a year. Things have changed for spinal cord injury in contact sports specifically, because there was a decrease in head injuries in the 1970s theoretically due to better head care, but there was a sharp rise in spinal trauma. And we break these up into transection type injuries where the cord actually splits in half, which is relatively rare. Here's a transection in the thoracic spine, and here's a spondylopsis from a motorcycle accident. Obviously, you don't need an MRI for this, the 25-cent radiograph, and here's a stab wound to the cervical spine. It still gives me chills just to look at that. And then there's concussive injuries that can happen from a bullet passing it through or nearby the spine that can cause edema inside the spinal cord. But the main thing to know about this is that for blunt trauma to the spinal cord, portions of the architecture are salvageable, so this is why Big Pharma is very interested in this. And the 3 features to see are swelling, edema, and hemorrhage. The edema is proportional to neurologic deficit and prognosis, and hemorrhage is usually associated with the most severe injuries and predicts the greatest or the poorest neurologic recovery. And here's just an example of edema on some sagittal long TR sequences on a unilateral facet dislocation. Here's a potpourri of edema, hyperintense, flame-shaped area spanning the length of the spinal cord. Compare that to hemorrhagic spinal cord injury, which is dark on gradient echo and T2-weighted images and has the worst prognosis. Here's a thoracic example and another potpourri and a stab wound. There's also a scoring mechanism that was developed by Jason Talbot at UCSF for scoring the severity of spinal cord injury graded 0 to 4, called the basic score, which I invite you to look at this reference for. And essentially, those are the features of MRI: the length and location of hemorrhage and edema inside the spinal cord, the cross-sectional extent, the extent of compression, and so forth. This has high value in evaluating spinal cord injury because there is no other correlate to this. And with that, it's top of the hour. I'm going to finish up there. And thanks a lot.